നമുക്ക് ഇന്നലത്തെ കൂട്ടല്ല, ഇന്നലെ നമ്മൾ ട്രാൻസ്ലേഷൻ സെർച്ച് എന്നുള്ള കൺസെപ്റ്റിനെ പറ്റിയായിരുന്നു ഡിസ്കഷൻസ് മുഴുവൻ, അക്കാഡമിക് ഡിസ്കഷൻ. അപ്പോ അകത്ത് ശരിക്കും പറഞ്ഞാൽ വി ലിസൺ ടു ഗ്രേറ്റ് റിസർച്ചേഴ്സ് ആൻഡ് സ്കോളേഴ്സ്. അത് കഴിഞ്ഞിട്ട് വി ഹാഡ് എ വെരി എഫക്റ്റീവ് ഗ്രൂപ്പ് ഡിസ്കഷൻ ആൻഡ് വി ഹാവ് മെയ്ഡ് സം പോയിന്റ്സ് വിച്ച് വിൽ ബി ഹാൻഡ് ഓവർ ടു ദ പോളിസി മേക്കേഴ്സ്. അത് ഇന്നലെ തീർന്നു. ഇന്ന് നമ്മൾ കംപ്ലീറ്റ് അപ്പോൾ കോവിഡ് എക്സ്പീരിയൻസ് നമ്മൾ കഴിഞ്ഞ 2 വർഷമായിട്ടുള്ള ഒരു കാര്യമാണ് കേരളത്തിലത്. അതിൽ യൂണിവേഴ്സിറ്റി ആദ്യം നമ്മൾ സർവീസ് ടീമിൽ ജോയിൻ ചെയ്തു, വോളണ്ടിയർ ആയിട്ടൊക്കെ കൊടുത്തു. പിന്നെ നമ്മൾ ഫക്കൽറ്റി അപ്ഡേറ്റിംഗ്, സ്റ്റുഡൻസ് ആസ് വെൽ ആസ് ഫക്കൽറ്റി അപ്ഡേറ്റിംഗിൽ വി വെയർ ഇൻവോൾവ്. അത് കഴിഞ്ഞാണ് നമ്മൾ ഡോക്യുമെന്റേഷൻ എന്നുള്ള ഒരു ഐഡിയ വരികയും അങ്ങനെ വി ഹാവ് കോൺസ്റ്റിറ്റ്യൂട്ടഡ് ഡിഫറെന്റ് ടീംസ്. അത് വിത്ത് ദ ഹെൽപ്പ് ഓഫ് ഹെൽത്ത് സർവീസ്, കാരണം ദേ ആർ ദ പ്രോഗ്രാം പീപ്പിൾ, ദേ ആർ റിയലി ഇൻ ഇറ്റ്. അപ്പൊ നമ്മൾ 2 കൂട്ടരും കൂടെ നല്ലൊരു കൊളാബറേഷനിൽ ചെയ്ത ഒരു എക്സ്പീരിയൻസ് ആണ്. അതിന്റെ ഡിസ്കഷൻസ് ആണ് ഇന്ന്. അപ്പൊ ഇന്നിപ്പം നമ്മൾ അതിൽ ദയവ് ചെയ്ത് എല്ലാവരും അത് ശ്രദ്ധിച്ച് കേട്ടിട്ട് അതിനകത്ത് ഡിസ്കസ് ചെയ്യുക. കാരണം കോവിഡിന്റെ എക്സ്പീരിയൻസിൽ നമുക്ക് ഇനിയും നമ്മൾ അറിയാൻ ഒരുപാട് കാര്യങ്ങളുണ്ട്. നമ്മൾ ഒരുപാട് ചെയ്തു, വർക്ക് ചെയ്തു, എല്ലാവരും ഒന്നിച്ചു നിന്ന് വളരെ കഷ്ടപ്പെട്ട് എല്ലാ കാര്യങ്ങളും ചെയ്തു. പക്ഷേ അതിന്റെ നോളജ് ബേസിൽ ഒരുപാട് കാര്യങ്ങൾ നമ്മൾ ഇനി അറിയാനുണ്ട്. അതാണ് നമ്മൾ അതിനുള്ള ശ്രമമാണ്. അതിൽ എല്ലാ കാര്യങ്ങളും അറിയാൻ, കാരണം ക്ലിനിക്കൽ എന്ന് പറഞ്ഞാൽ തന്നെ എന്തുമാത്രം ഉണ്ട്. ഓരോ പേഷ്യന്റും യുണീക്ക് ആൻഡ് ഡിഫറൻസ്. അപ്പൊ അതെല്ലാം ഡോക്യുമെന്റ് ചെയ്ത് കുറേയൊക്കെ എല്ലാം, കാരണം ക്ലിനീഷ്യന് ഡോക്യുമെന്റ് ചെയ്യാതിരിക്കാൻ പറ്റത്തില്ല, എല്ലാം ഡോക്യുമെന്റ് ചെയ്തിട്ടുണ്ട്. എങ്കിൽ പോലും അതെല്ലാം എടുത്ത് അനലൈസ് ചെയ്യാനൊക്കെ പാടാണ്. എങ്കിലും വി ആർ ജസ്റ്റ് എക്സ്പ്ലോറിങ് ദ പോസിബിലിറ്റീസ് ഓഫ് ഐഡന്റിഫൈയിങ് ദ മോസ്റ്റ് ക്രൂഷ്യൽ റിസർച്ച് ഗ്യാപ്സ് ആൻഡ് വിച്ച് ക്യാൻ ബി വർക്ക്ഡ് ഔട്ട് ലേറ്റർ ഓൺ. ഒരു സൈഡ്. രണ്ടാമത്തെ സൈഡ് പബ്ലിക് ഹെൽത്ത് ആസ്പെക്ട്. വാട്ട് ഹാപ്പൻഡ് ഇൻ ദ ഇൻഫെക്ഷൻ. ഇന്നലെ അറോറ പറഞ്ഞപ്പോൾ നിങ്ങൾ എല്ലാവരും ശ്രദ്ധിച്ചു കാണും. ആൾ ഇൻഫെക്റ്റഡ് ആർ നോട്ട് ടേണിംഗ് ടു ബി ഡിസീസ്ഡ്, ആൾ ഡിസീസ്ഡ് ആർ നോട്ട് ടേണിംഗ് ടു ബി സിംറ്റമാറ്റിക്, ആൾ സിംറ്റമാറ്റിക് ആർ നോട്ട് ടേണിംഗ് ടു ബി ഹോസ്പിറ്റലൈസ്ഡ്, ആൻഡ് ആൾ ആർ നോട്ട് ലീഡിംഗ് ടു കോംപ്ലിക്കേഷൻസ്, ആൻഡ് ആൾ ആർ നോട്ട് ലീഡിംഗ് ടു ഡെത്ത്. അപ്പൊ ഈ ഒരു സംഭവം നടക്കുമ്പോൾ അതിനകത്ത് ഇൻഫെക്ഷൻ എന്നുള്ള കാര്യം നടക്കുന്നത് കമ്മ്യൂണിറ്റിയിലാണ്. ആർക്കും അറിയത്തില്ല ആരാണ് ഇൻഫെക്റ്റഡ് ആവാൻ പോണത്, ആരാണ് ഇൻഫെക്റ്റഡ്. അത് റീഇൻഫെക്ഷൻ ആണെങ്കിലും ഇൻഫെക്റ്റഡ് ആണെങ്കിലും അതുപോലെ തന്നെ വാക്സിനേറ്റഡ് ആണെങ്കിലും നോൺ വാക്സിനേറ്റഡ് എല്ലാം അങ്ങനെയാണ്. ഏജ് സ്ട്രക്ചർ തന്നെ ഒരുപാട് പേര് സ്റ്റഡി ചെയ്യാൻ ശ്രമിച്ചു. പക്ഷെ ഇപ്പോഴും ഒരു കാര്യം മാത്രം കാണുന്നുണ്ട്, ഏജിന്റെ ആ ഹയർ ഏജ് ഗ്രൂപ്പിൽ ഒരു വലിയൊരു സ്ക്യൂവിങ് ഉണ്ട്. പക്ഷെ ഈ ലോവർ ഏജ് ഗ്രൂപ്പിലുള്ളവർ ഇൻഫെക്റ്റഡ് ആവുന്നു, അവരുടെ ഇമ്മ്യൂണോ ഡിസ്റെഗുലേഷൻ എത്രമാത്രം നടക്കുന്നു, അതൊന്നും നമ്മൾ പഠിക്കുന്നില്ല. അപ്പം ഞാൻ പറഞ്ഞതിന്റെ അർത്ഥം, ദീസ് ആർ ആൾ നോട്ട് സിമ്പിൾ, വെരി വെരി ഡിഫിക്കൽട്ട് തിങ്സ്. പണ്ട് നമുക്ക് എളുപ്പമായിരുന്നു, കാരണം പണ്ട് സ്പാനിഷ് ഫ്ലൂ വന്നപ്പോൾ കുറെ പേര് മരിച്ചു, കുറെ പേര് ജീവിച്ചു. അതിനെപ്പറ്റി അന്ന് ഈ മെത്തഡോളജി ഒന്നും ഇല്ലായിരുന്നു. എങ്കിലും ശ്യാം കോട്ടിലിൽ കാണിച്ച ആ ഒരു 1969 സയൻസിലെ ആർട്ടിക്കിള്, ആക്ച്വലി ദാറ്റ് ഈസ് ആൻ ഐ ഓപ്പണിംഗ് ആർട്ടിക്കിൾ. എത്ര പേര് അത് കണ്ടെന്ന് എനിക്ക് അറിഞ്ഞുകൂടാ. അന്ന് പറഞ്ഞ കാര്യങ്ങളൊക്കെ ഇപ്പോഴും റിലവൻ്റ് ആയിട്ട് നിൽക്കുകയാണ്. എനിവേ, ഐ എം നോട്ട് ലെങ്തനിങ്. നമ്മൾ കോവിഡിനെ പറ്റിയുള്ള ഡിസ്കഷനാണ്. കുറച്ച് പേരാണെങ്കിലും സാരമില്ല, എത്ര പേര് ഇന്ന് വരുമെന്ന് നമുക്ക് അറിഞ്ഞുകൂടാ. എങ്കിലും നല്ല ഡിസ്കഷൻ, ലൈവ്ലി ഡിസ്കഷൻ കൊണ്ടുവരിക. ഈ ആദ്യത്തെ 2 സെഷനെ പറ്റി ഞങ്ങൾ പറയാൻ പോകുന്നത്, ഞങ്ങൾ അത് കുറച്ച് വർക്ക് ചെയ്തതാണ്. കഴിയുന്നത്തോളം ഞങ്ങൾ സ്ട്രേറ്റ് ഫോർവേഡ് ആവാൻ നോക്കിയിട്ടുണ്ട്. വളരെ ന്യൂട്രലാണ്. ആ ഡേറ്റ ആസച്ച് കാണിക്കുന്നേ ഉള്ളൂ, വേറെ കോൺട്രവേഴ്സി ഒന്നുമില്ല. ഒരു കണ്ടൻഷനിലേക്ക് ഞങ്ങൾ പോകുന്നില്ല, ആ ഡേറ്റ ആസച്ച് കാണിക്കുന്നു. അപ്പൊ ഞങ്ങളുടെ ഒരു പരിമിതി ഞങ്ങൾ പറയാം. നമുക്ക് അങ്ങനെ വലിയ ഡേറ്റ, ഇപ്പം ബിജു സോമൻ എന്നൊക്കെ കുറച്ചുകൂടെ ചിലപ്പോൾ എക്സ്പോസർ ഒക്കെ കാണുമായിരിക്കും. നമുക്കങ്ങനെ ഡിജിറ്റൽ ഡേറ്റ അനാലിറ്റിക് പ്ലാറ്റ്ഫോംസ് ഒന്നും നമുക്കില്ല. നമുക്ക് പഴയ സ്റ്റാറ്റിസ്റ്റിക്കൽ മാനുവൽ മെത്തേഡ്സും പോക്കറ്റ് കാൽക്കുലേറ്ററും ഒക്കെ ഞങ്ങൾക്കുള്ളൂ. അത് വെച്ചുള്ള ഞങ്ങൾ ആസച്ച് കാണിക്കുകയാണ്. അതുകൊണ്ട് ദയവ് ചെയ്ത് അതിൽ നമുക്ക് we will explore and we will think about the alternatives and also come to everything to be brought up into an academic line of thinking. Thank you very much for coming, and 9 o'clock everybody has assembled. Thank you a lot, and a special thank to Dr. Biju Soman for coming and chairing us. അതർ ആൾക്കാര് നമ്മുടെ ജഗദീഷ് സാർ വന്നിട്ടുണ്ട്, പ്രദീപ് ഉണ്ട്, എല്ലാവരും ഉണ്ട്. അപ്പൊ ഡിസ്കഷനിൽ പങ്കെടുക്കുക. ശാരദ വന്നതിൽ ഒരു ഗ്രേറ്റ് താങ്ക്സ്. ഓക്കെ, സ്വപ്ന.
Good morning, respected delegates. Now we are starting with experience of Kerala with the COVID-19 pandemic morbidity. So this is a quote by the Nobel laureate economist and psychologist Daniel Kahneman during the early period of the pandemic. This is an exponential event. That is, we see things doubling every 2 days, every 3 days, every 4 days, and people, certainly including myself, don't seem to be able to think straight about the exponential growth. The same is happening with us also. We are also wondering, we did not have any exposure to such an event in the past. So India, the second most populous country, in the second position in COVID situation also, the people stood together to manage the pandemic along with the government. And to an extent, we successfully managed it. The pandemic is leaving much for us to learn, because we did not have any precedents, and several opportunities were opened by that, and we learned many things from this pandemic. So the additional responsibility of the healthcare professionals and academia is to generate knowledge through scientific research and evidence generation. Research brings new evidence and new information every day, and it is an important responsibility. Evidence needs to be translated into policy and into action. So the objectives of our session is to describe the pandemic in Kerala in terms of pandemic behavior. So this session is exclusively for concentrating on the morbidity, progression as evidenced by waves and test positivity rate during 2020 to 2021, transmission dynamics in the community in terms of geospatial distribution and hotspot formation and containment zones during May-June 2020, disease outcomes in terms of hospitalization, to highlight the lessons learned from this experience as policy directions for future pandemic preparedness. This is a brief historical glimpse, the panorama of pandemics. From time immemorial, there were several pandemics. Most of them were of viral origin, but some zoonotic pathogens were also there. They are having a pandemic potential. The global pandemic situation in chronological order during the last 50 years, we can see that COVID-19 started in 2019, and which is having the highest caseload and mortality. But fortunately, the case fatality rate is very less. And it is from this chart, it is evident that this is the most affected by several countries, almost all countries in the world so far. The origin of the COVID pandemic, as we all know, it started as a cluster of viral pneumonia, started in Wuhan, China in December 2019, and within no time it spread all over the world. In January 2012, within no time, China sequenced the novel coronavirus as the 7th member of the coronavirus family. They have isolated it. Then on January 13, the first case was identified outside China in Thailand. And on January 20, 2020, WHO declared corona as Class B notifiable disease and a global emergency of international concern. And on February 16, it was named as COVID-19, that is coronavirus disease, which was identified in 2019. On March 11, the most important event, WHO declared COVID-19 as a pandemic. At that time, there was almost 1 lakh caseload affected in 114 countries and around 5,000 deaths. So at that time, the situation in China, the first case was started, the first COVID series started as Wuhan seafood market in China during December 2019, and the media called it as the Wuhan pneumonia. And on December 31st, they have reported several cases, including 27 cases of COVID pneumonia. And immediately they have started containment measures, including lockdown. Initially, they have closed the market. Later, Wuhan went into lockdown. Then within no time, the case were increasing. The case doubling time was very short, from 548 cases on January 26th to 70,000 cases on February 18. And on February 16th, they have started convalescent plasma therapy, and they have said that it is showing promising results. And at present, there are almost more than 600 million confirmed cases of COVID-19 at the current time. In India, the latest statistics, we have 44 million confirmed cases. We have in Kerala, we have started control measures at the earliest. And the first case of COVID-19 in India was identified from Kerala in Thrissur on 27th of January. And the government started rapid response in the form of guidelines and airport screening and other measures. The second and third cases were also reported shortly. Then Indians were evacuated from China by special air flights, special Air India flights, and people coming from COVID-infected countries were put under home quarantine. And in February, several people were under quarantine in Kerala. And there were very limited testing facilities. Only 12 centers were doing the testing at that time. Then we have started preventive measures, including social distancing, personal hygiene, screening, and contact tracing. And almost all of us will be remembering this picture, the COVID patient flow chart during that time. And this is the current situation of COVID-19 in Kerala. We have reached almost 6 million total confirmed cases. So, in this session, we are trying to assess the burden of COVID-19 in India by tracking the COVID-19 trajectory through the phases of transmission, the first and second waves and the TPR, transmission dynamics like geospatial distribution and the hotspot dynamics, and disease outcome in terms of hospitalization. This is the first phase of transmission, first wave. It has started by the end of January and sustained throughout the year almost to the end of December. And it has peaked during the time of September. And till the time of May or starting of the June, the curve was almost in a stationary phase. And from June to August, it is starting to rise in an exponential manner. And it has reached almost more than 2 lakh cases by September. And afterwards, the peak came down and slowly going down. By the end of December, it has settled almost at the level of 1 lakh. Then in the second wave, started from January, it is a continuation of the first phase and came down slowly and reached at a lowest point during March.
So now, sorry for interruption. What's the source of this data?
So this is from the COVID dashboard, Government of India, Government of Kerala.
Okay, fine.
Then cases started to rise during March and peaked during the time of April, May. And again, it came down to a point at June, again started rising and almost remaining stationary for about 2 to 3 months, then started coming down again very low to the end of December. And after, we have tracked this much only, but we know that after January, there was also a rising. And this is a combination of the comparison of reported cases during the first wave and second wave. And several events were happened during that time. Literature also says there are several corresponding events were there, like the monthly number of cases of COVID-19 in Kerala during 20 to 2021. So the first case was identified during the last of January. Then during the time of lockdown, immediately after the starting of the pandemic, we have started our lockdown measures, different containment measures. Then lockdown measures were continued till middle of the May. And after this lockdown and the restrictions were lifted, cases started gradually rising and almost remain in a lowered wave pattern till about end of the February. And the vaccination of general public started during this time at the 2021 February end. And we can see the lowering of the curve corresponding to that event of vaccination. Then second lockdown has initiated, but afterwards again the curve started peaking, coming down by June, again started rising, then lowering during August, again a rapid rising in September, and now it is gradually going down till December. So these two events were corresponding to the identification of the alpha and delta variants. Then coming to the test positivity rate during 2020 and 2021, and as expected, these TPR rates were very high during these 2 periods. And one major reason for that is that several literature was also identified it as when all over India the testing was very low. Kerala continued its high level of testing rate, and that contributed to the rise of the mean TPR. So this is the comparison of 20 districts with COVID burden in 2020. Here we can identify that 4 districts from Kerala were placed in these top 20 districts with COVID burden. That is, this slide we have taken this slide from some other sources. It's not worked out by us. This is the geospatial distribution comparison of reported cases during the first wave and second wave district wise. So we can see that the most affected, almost all of the districts were affected by reporting of several COVID-19 cases. Then this is the hotspot dynamics in terms of difference in percentage. And here also, during the May-June, centralized lockdown measures were there and identification of the hotspot and containment measures. But after the lockdown, the restrictions were relaxed and the local containment measures were there, and the local self-government agencies were managing the hotspot and the containment. So during 2021, corresponding to September, very large number of hotspots were there. And now it is lowered. And now containment hotspot identification is very less. And this is the hospitalized cases per month district wise. We can see that as expected, Trivandrum, Thrissur, and Kozhikode were having very high caseload because many hospitals were there also. So hospitalized cases were more. Then coming to discussion, from this chart, we can see that the monthly number of cases of COVID-19 in India and in Kerala in 2021, it is almost going in the similar fashion. And this is, we have taken from literature, source Jaya et al. From Tropical Medicine of Infectious Diseases journal. So this during the lockdown period, both the curves are very similar in fashion. And afterwards also, those are in similar fashion. But when it is coming to the September to December, the curves of Kerala and India are different. Then regarding the test positivity rate, some newspaper agencies have reported that Kerala conducted over 79,000 tests for every 1 lakh people on particular one day. And Maharashtra on the same day tested 40,000 people per 1 lakh of its population. And by comparison, Uttar Pradesh, among India's largest state, only did 29,000 per 1 lakh. So this increased number of testing was one reason for reporting of increased TPR. So as a conclusion, we can see that Kerala had a hard hit by COVID-19 pandemic. The first phase was managed successfully, which contributed to the delayed peak of epidemiological curve. The second wave was delayed due to successful mitigation strategies, but prolonged due to epidemiological characteristics of the pandemic, ease of the restrictions, and relaxed attitude of the people. These are some of the literature. Thank you.
Thank you, Dr. Subna, for that very elaborate and clear presentation. Rajamohan sir suggested that we'll continue with the mortality presentation also, then we'll open up for discussion.
Thank you. I would just present some glimpses for 10 minutes, and half an hour we will have a discussion. Mortality we expect to be a true reflection of the progression of the morbidity. That is the epidemic in the community and all those things. Unfortunately, we are missing a lot of information at the mortality level. That is all noise and cacophony occurring across the world. So it was actually a concern in the beginning. This is actually in 2020, by April, May, BMJ appeared. 1/3 of the COVID hospitalized patients were dying. A very shocking thing. And, this was at the time when biologicals were not that much liberally used. Dexamethasone was not that liberally used. People were still hunting around azithromycin and the other one, that is hydroxy. And everybody was in real darkness. Later on, what happened was mortality reporting systems have started functioning efficiently. What is the most dependable mortality system, reporting system? It is definitely the civil registration system. I think Dr. Jagadish and Pradeep Kumar and Viju all will agree to that. That is the most dependable because there is a penalty, it is by law, a lot of reasons are there. But we health people will not get enough information from that because they only get the cause of death analysis, and even we all know that underlying cause of death is not mentioned in many certificates. So, but still, that is the most dependable. Then, of course, the model-based estimates started coming. And our department's own reporting, that is our surveillance system reporting of mortality. Then model-based estimates started, Amit Banerjee, Amit Bava, latest papers on JA, and the latest 2022 paper on Lancet. Beautiful intellectual exercises, but how far this capture the true mortality is a real question. And of course, the last, I am hearing it first, this excess mortality business. And WHO initiated that. Originally, it was started from Lancet, BMJ only. BMJ, there was an original paper in 2020 itself, May, June, about excess mortality concept. They started that, academic discussions. Later on, by 2021, everybody has started serious because, all these burial ground issues, even in Bangalore, they have done a good work. And the media has started half scientific papers by all those people. And ultimately, WHO ended up in a very scientific mortality estimate based on, again, model. They put it in the dashboard. India, they said that, the first line they said, India has 20% of underreporting, even in civil registration system. They quoted many papers. Of course, the government of India was very much irritated. They started putting press release. Academia also disagreed with the WHO estimate. And finally, WHO has to retract that. Anyway, that is that excess mortality. WHO, now you go, there are beautiful Excel data available. They have developed some P-score, some modeling, some statistical juggleries, all those things. Now, COVID date, after adjudication, the cause of death analysis, I told you, this is actually based on cause of death analysis by physician group in the NHS, in BMJ. That is what I showed you. That actually is the most reliable data about what we need. What is the current state of mortality? Actually, I have, for comparison purpose, I have converted it into deaths per million population. You can see that the lowest deaths per million population is in Wayanad. I do not know why it is like that, because we expect at this point of acme or maximum culmination of the pandemic, we expect almost all areas to be equally involved. And why is it? Because people are going to Mangalore and dying? We don't know. Those people in Wayanad or Kasaragod only knows the reasons. But this is actually, when we comparing it per death per million population, we find that Trivandrum has the maximum deaths. And Kasaragod has the lowest.
Sorry to interrupt, sir. This is COVID deaths.
COVID death, purely COVID death. This is the current COVID death. Actually, after the release of all current COVID. You may actually, Jagadish only, they can comment on it because they may know a lot about these things because they were always working on these things. And because for comparison purpose, I have only converted it to deaths per million population. Now, so it shows that the Wayanad is the lowest affected, Kasaragod is the lowest affected. Actually, in between, Kasaragod was in the limelight having the maximum hit by COVID. I do not know why this is the picture. Anyway, so age group, again, age structure was available only very late for total picture. And when we started the analysis, we got 36,568 cases only of death. Later on, they pumped in a large number and made it into 70,000 after the Supreme Court verdict and all those things. So we have analyzed this age group, and of course, there is nothing unusual in it. The death is heaping up towards the elderly group. And when we look into the very specific age groups also, the maximum deaths is happening in the above 60-year age group, and below 40-year, very negligible deaths. So there is nothing unusual in these things. These are all very robust epidemiological observations. And actually, we tried to do a standardized standardization with a standard population, which was taken by the projected population of Kerala, which we collected from the Department of Demography. But because, I couldn't satisfactorily make any conclusion because the comparisons are not there, because they are also not doing it. So the deaths per million population is the best rate for comparison. Then gender distribution, of course, I do not know, because only one transgender death. Is it because of the poor reporting? Oh, we don't know, because this is actually out of 32,000 deaths. But 70,000 deaths, I don't know. Ajahn only knows that, because they have just released the total deaths, maybe for the legal purpose and claim purpose. For our epidemiological analysis, we don't know about it. How many transgenders are there or not? Actually, we don't know. There is a hypothesis that transgenders gives protection against COVID mortality. We don't know. Coming to the case fatality rates, actually case fatality rate is a robust indicator for that time, that purpose. Because case fatality changes. It changes according to the place, it changes according to the time points. So for that time, that purpose, it is a very good indicator that is widely used across the globe. There are a lot of criticisms about the, originally actually in Lancet, there are more than 12 or 15 papers discussing the denominator of case fatality. What should be the denominator? Whether it should be test positivity or whether it should be infection, etc. Anyway, these are all very good academic exercises. We have just calculated the confidence intervals also, because we calculate the confidence interval, everything. Not much information we are getting. But, the overall case fatality rate for India has been calculated as 1.32. And Kerala has been always, even with any method of calculation, it was always below 1.2. That is the success indicator of our COVID control, the Kerala state's COVID control. Please, if you have any dissenting opinion, please come out, because there are a group who are criticizing about the glorification of Kerala efforts on COVID control. That is very active in social media and all those things. But fact is a fact. This I am saying out of our calculations and data. We are ready to get corrected at any time. But this is a valid point. We could bring down the case fatality even less than any other part in the country, because our deaths were actually second only. Maharashtra had the worst hit, but ours was the second. COVID case also, ours was the second. Maharashtra had the maximum. But this factor, that case fatality rate was always, we could be low. Then comorbidities, unfortunately, the information is not available. 2020 December, please correct Jagadish and me if I'm wrong. 2020 December, they have done 2 analyses, put in open domain. I don't know what is there with them. I don't know. Every day death audit was happening. Whenever I was contacting my own friends, colleagues, they were saying, sir, today I have a death audit. Every day death audit was happening, but nothing is there in the open domain, because we researchers, we only want to get whatever is available in the open domain. So according to this is the comorbidity status. The total deaths available, I think it was about 500 or something. Sorry, it was about 2,000 something or. And of course, there is nothing new in it. Diabetes, hypertension, coronary artery disease, CKD, all we know. So the background death rate also, comorbidity also, I looked by 2 important documents. One is the 2019 MCCD report by the Department of Vital Statistics bulletin. They have released the 2019. They have not released the 2020 yet. And I inquired them. They said there are some confusions about total COVID death, maybe. So they have not released it. Please correct me, Jagadish, if I am wrong. And the second one is the national report. The national report they have released for 2020. And actually that gives about 300 to 400 excess deaths than our deaths. But that is a small accommodatable difference only. So this is actually from the, I think from the DHS, as per the audit report of DHS, then the national report from Kerala state, same thing. The age structure is same thing, and mortality, age specific mortality, all same. Nothing new, no special for COVID. But an interesting observation is that all-cause mortality has increased little, but non-COVID death mortality has come down. That is an important observation. And this again, age distribution. So I don't want to go much into the issue of excess mortality now, neither to the epidemiological and statistical aspect, nor to the media report things, because we don't have gold standard data. Of course, once the MCCD report is released for 2020 from our place, then of course we can look into that. That is my feeling. Of course, the discussion was initiated by media. Excess mortality is not an issue for Kerala alone. It is a universal phenomenon. Actually, I told you BMJ, first scientific article on excess mortality came in BMJ. Then only, even after 6 months only, WHO also became serious about it. And I think there need to be some work done on it rather than these models, because model, all you know, no model is perfect. And in model always, there are a lot of model assumptions. What you input is actually, yesterday we have seen EAG, garbage in, garbage out. All the model limitations are there. So actual data, when actual data is there, why should we go for model-based estimate? We can, it will only be complementary. So what we need to do is, we have to do the death audit process, and we have to get the data from the civil registration systems, because that is perfect. That cannot be. Of course, there may be some missings, there may be some delay occurring, but whatever it is, that is near total. And I think, so when we come to this is the excess mortality. I told you to 2020-22 latest Lancet publication. They have analyzed the excess mortality from, because excess mortality is a very popular concept now. Everybody is interested in it. All the armchair statisticians and analysts, data analysts, they are all interested in it. So they have compared Bihar, Uttar Pradesh, Madhya Pradesh, and Kerala. You see, there is a considerable amount of excess mortality according to that article. They have done some, because TAN, but is actually Tamil Nadu based analytic group, which you may be knowing. That I don't know about that institute. They have done some good work, and they have brought some papers on excess mortality in India. Actually, these people, Lancet people, this author has collected data from them only. So, you know, media, we should thank to media, because whatever it is, the concept of excess mortality has been brought out by the media, and we should thank media. And media, actually, most of the media clippings from Hindu and other Herald, Hindu, and also even New Indian Express, they were all concentrating on that during the 2021 beginning and 2020 end. So thanks them. Now coming to the conclusions, what we can learn now. Still now, lot of data gap is existing. Of course, they have released the total death. We believe it. 70,000 and odd, we believe it. We have to check with the civil registration system. That is not completely out. Second thing is, I think my feeling is that either the death audit information has to be released for researchers and public, or if not done, they have to do it. Because yesterday Manoj was saying a beautiful sentence. You know, the Mumbai model, I thought Kerala model is the best model. Actually, sincerely, I was believing that. But when we talk with other people outside Kerala, yesterday Manoj was saying Mumbai model, you know, the COVID control model by Mumbai, how they have done it. Because that gentleman, when he took charge of the COVID control cell, first thing he did was, he smashed the central COVID war room. And he made totally decentralized it to the regional units. So, you know, strategical operations, they are very important. And we have to think about these things. Of course, we have done very good work. We have to learn from other states. Whatever they have done, what is available in our place, we have to listen with humility. Of course, we have done good things. They also appreciate it. There is no doubt about it. So rather than reacting emotionally, We have to react scientifically. And coming to other aspects, so that is why I said we should start this death audit and we should do the medical certification of cause of death training. Because that Epibio group has done that, there was WHO patronage, but then they stopped it. Now again, that Senthil has again restarted it. The national, the St. John's Medical College, Bangalore, that group, their group has restarted it. I think a medical certification of cause of death training is a must. Because unless you focus on the underlying cause of death, how can do proper cause of death ascertainments? If you don't do the cause of death ascertainments, whatever analysis you are doing, it is full of misclassifications. That is the issue. So we have to go for that. And perhaps I would rather say, rather than the centralized death audit, we have to do it at the institute. What prevents us from doing it at the institutional level? Our medical officers are all very competent. They are very conscious about the data. They know about the basis of data. They learn it in community medicine. They apply it. But they are not allowed to do it in the institutional level. But when we approach the senior administrator, they say, what prevents it? They can do it. Why they are not doing it? Like that they will say. And at last they will say, we are doing our job. Why they are not doing their job? Like that, the responsibility is under. But we have to make it as a culture of institutional level analysis of the data we are creating and making it visible for discussion, academic discussions. I would say like that. And as you know, I don't know, the near miss cases, that concept, because the one department which has worked relentlessly and untiringly was the critical care medicine departments. Even in private sector, the way they were working. And in Kerala, mortality is less because I sincerely believe, I don't have a data to show, but I sincerely believe that the liberal use of steroids, because I was tracking it. Even before the steroids have come into the IDI recommendations, many physicians in Kerala has to do that. Chandini may have their own comments about their experience. That might have been one reason why we could prevent that. And the surgery capacity of ventilators, wonderful management. There was no shortage of ventilator. Of course, government was very supportive. Government, our credit goes to the government. But still, our doctors have done that. And that is why, so the concept of analyzing near miss cases, interesting cases, at least we have to go into, and that also should come as an exercise for professional people. Then, the granularity of data, I need not tell you about it because you are all data managers. How far we can, there should be a policy. But Jagdish, I am saying that there should be a policy. I know you have been the health service, how to the quality of health service and health system was in your head throughout your career and profession. But these policies we have to make about granularity, to what extent data can be shared, at what level, and analyzable data, how it can be given to others, like that. Anyway, I don't want to say more comments. I think a good discussion should happen because those who are come here, they are all people who have a hand on it. So please discuss, and our Biju is here. Biju's passion is digital surveillance. We have him in that section, but here also he can contribute. Thank you very much. Now we have a VIP here. Yesterday, CP Vijayan sir could not come. Make the open. I forgot that.
Thank you, Rajmohan sir. First presentation, I could hear, Swapna's presentation, I could hear only half of it. I am Rajmohan sir presentation, I am strongly endorsing your view that cause of death certification, yes, that has to be, I think we are planning to have a training program, it's not, that has to be done because that is the cornerstone of all the death analysis. So we have to do that. About the COVID cases, I think there will be active discussion. Thank you. Thank you.
Thank you, sir. So I don't, Vijay sir and Rajmohan sir join the test.
Yes.
Yeah, please.
It doesn't.
Okay. Okay, friends. Now I thank Rajmohan sir and Dr. Supna for setting the stage for discussions.
Sir,
And-
Rajmohan, sir. Sorry. So that death per million, I was just wondering if it is related to the density of population in the districts. I think because when I glanced through it, it has something to do with the density of population. Trivandrum and Alapi has highest density of population. Wayanad, Idukki, they have got the least. So I'm just wondering if that is related. Thank you.
Thank you, Dr. Saido. And this open for discussion and the very purpose, as Rajmohan sir has rightly pointed out, the purpose is not to criticize or to boast on our achievements, but we have gone through a very historic moment, whether we realize or not. This COVID, which caused around 6 million deaths, and now also we have lingering problems and all. So the very purpose of this meeting is to look back and learn from our experience. So that's why actually I thank the organizers for calling all of us here. So let's discuss openly and then come up with the learnings. Yeah, Dr. Sanjeev.
Just to add to what Dr. Sairu was saying, often when we take these statistics, I see in terms of COVID that we use the convenient figures. So when it comes to death per million, if you apply the same parameter for all states of India, then UP and Bihar would be having the lowest deaths per million. But when that number comes up, we say that they are underreporting deaths and, those states are not doing death reporting properly. So that is why the death per million is lower. But when we are comparing across districts in Kerala, the same logic doesn't come across. So often we use very different parameters to analyze our own data within the state and outside, comparing outside the state. So I think there is some need to look at it in a uniform way.
Yeah, no, I agree with you, Dr. Sanjeev. And one more thing, like now there's a lot of discourses happening in the literature, in the medical arena. In Nature, there are a series of articles. When we are looking at all the figures during COVID, we have the count figures. Morning, sir. So we have the count figures, but what about the denominator? And the denominator, we are using the projected denominator. Whether the projected denominator for the state level or national level can be used for studying a state or district, that's the main question. And as Rajmohan sir was stressing on the CRS, actually during this kind of pandemics, the reporting, the birth and death and migration, all those parameters will change. So we need better denominators. And the COVID, like after HIV/AIDS, actually, we learned quite a lot of things and we have improved our system. The universal precautions were brought in and so many new blood banks were in place and all. Likewise, after COVID also, it has posed so many questions. One of the main question is the way we synthesize evidence. Till very recently, we were focusing mainly on RCTs. But during COVID pandemic, people started using all the medications without proper trials. And it has brought in so many good things, but still the denominator thing, actually all the figures which you are looking at, we have to be a bit more conscious about, even I would say that death per million, what is the denominator and how the denominator was taken, whether we have accounted for everything. Yes, ma'am.
The first wave, we had only 7 deaths. The second wave, we had 78. And the primary cause was bronchopneumonia. And the associated comorbidity for most of them was gestational diabetes. Even though, as you said, we didn't have actual protocols whether to use certain drugs in pregnancy, we found that pregnant women were getting more susceptible and declining very rapidly as well. So we started using remdesivir, even though the Solidarity trial and everything did say that it was not very useful. We actually used it and we found, we've actually published that as well, that in pregnancy it was found to be of benefit. So maternal mortality Kerala state has been analyzed for COVID as well as the near miss.
Thank you, ma'am. Other opinions?
Sir, Sir, when counting the deaths, COVID deaths in India, we should have a proper definition of death in definition of COVID death. Actually, our Supreme Court once said that any death that happening within 13 days, 30 days after diagnosing COVID is a COVID death. That definition has some issues. It has very high sensitivity, but the specificity is very, increasing the sensitivity will reduce the specificity. So it will include a lot of unnecessary deaths or other deaths that is happening not due to COVID. So that aspect should also be considered.
Yes, there are issues actually, but we were all in the sort of on the war fighting mode, and this is something which we were doing in a travel of uncharted waters, like sort of things and all. So we have to have some definitions to start with, and there should be mechanisms, and all over the country, actually all over the world, if you look at how they harness evidence, some countries went for it, some countries were a bit reluctant, and what happened in Sweden or in UK or in US, and so even there is no lack of resources, but everybody was taken on a suddenly, actually this kind of huge surge of patients coming to the hospitals, overburdening the healthcare system. And at that situation, some of the decisions, as Sir was telling, actually the initial models, although the mathematical models, all were wrong. And why they were wrong, actually now we have to look back and try to correct those things and all. Yes, sir, please. Sir. So this mic.
I don't know how to comment on the COVID as such, but some of the figures, I think it would have been better if you could have plotted against the log scale. Log scale.
Yeah. Yeah, we can definitely improve quite a lot.
Sir, Dr. Jain here. First of all, I congratulate all the COVID warriors and our experts who tirelessly worked out during the nearly 2.5 years of this pandemic. But my worry is, as yesterday's speakers were pointing out, when we provide statistics with this sort of diligence, what we have done, Rajmohan sir and team has done a wonderful work. And we are providing proof for what has happened in Kerala originally. This is the original statistics. And sir was reaffirming that the CFR is lowest in our state. But when we interact with colleagues of other states, they believe the statistics in their states as original. So in that case, whatever be the CFR, we cannot even be compared with states like Chhattisgarh or say Bihar. For example, whatever the CFR may be, total death is 71,000 in Kerala, whereas that of Chhattisgarh is just 14,000 and that of Bihar is just 12,000. So the politician, especially that was the talk yesterday. The policymakers are always deciding what is the future. So if you have access to them, you can convince them. Otherwise, what happens? This is the proof that we have 71,000 deaths in Kerala. And they stamp Kerala as comparatively failed model by them. And they will be interested in arguing that when elections and such things come, that we have done the best. This is our best model. Whatever the CFR may be, we have prevented deaths of these number of people in my state. So how can we, unless all other states publish data so diligently, I fear what would be the repercussion of this.
So we can't do much interpretation on this count data, especially when we are screening. Oh, we were not doing screening, actually. It's a sort of people who are coming to convenience screening. People are coming to seeking healthcare. Actually, they were screened. Ideally, in a pandemic situation, even in a pandemic situation, now it's being evident that we should have gone for random screening. And even the number, like we have screened 7 lakhs and they have screened 50,000, but how can we rely on it? But they have done a random screening of 50,000, then we should rely on that. That is the essence. So, but here we are not to argue whether we have done right or wrong. But if we come across a next pandemic, how best we can be prepared? And surveillance is a major issue. I think next section we'll be discussing on it. But looking at the mortality and morbidity, this count data is how best we could have utilized those data, and that is the question here. And I'm requesting Dr. Jagdishan to give his views on because most of the data has come from health services. No?
In fact, I retired from directorate 2 months back, and so I cannot speak on behalf of directorate. But I think they'll be joining.
It's
Oh.
Audible. As Biju was saying, it is only learning from our experience, learning what happened really happens. Because we don't want to compare with other states, and why should we? If whatever we do, there should be a purpose. See, we are talking about definition. See, people make different definitions for different purpose. For example, you know about the disability classification. The McBride disability classification system is only for claim purpose. It is not for our medical academic purpose. A medical academic purpose, he has a functionality and quality of life indicator, other SF-36, many other things. Similarly, here also, this definition is basically for claims, and because the social support to people is more important, and suffering need to be mitigated. That was the reason. That is my feeling. I don't know. Anyway, Dr. Sunija has come. Madam, very warm welcome and thanks to you. And Jagadish, you can uninhibitedly say, because you are the doyen.
No, so it's good that yesterday we had 2 sessions. One, Dr. Manoj, an overview of COVID scenario of the country, and that very well set the platform. And afterwards, the vaccine scenario of the country was presented. And today, these 2 presentations, one on the general this pandemic scenario of Kerala and the mortality analysis by Rajmohan. So this very well set the platform for discussion. And I think some more data can be presented by the directorate control room. Since from the very beginning, we set a very good control room and a very good data management system, and so that we can go further ahead in all these 3 phases of the pandemic. And we all know that we did very well in the first half of the contact tracing, keeping under quarantine, and I don't know whether these when these small clusters and large clusters emerged, the strategy which we followed, that all these need to be further analyzed, since we have to pick up the learnings from this pandemic, and we have to make our system further strengthened for addressing the further pandemics. And regarding the excess mortality rate, since Kerala is having a better civil registration system, maybe last 2 years there was underreporting of civil registration, but people will report their death and birth, they will report, and maybe this 2 times excess death may be an excess calculation. I think it is an excess. All over it is, but Kerala, we cannot just compare Kerala with other places. And since we have a very good system of reporting, very good system of community awareness is there, very good this financial backup system is there. So I don't think this 2 times excess I never expect. And since we have a very good civil registration system, our demographer is also here. So maybe after some time we can make whatever the rate is, the excess rate we can calculate, and so it's good. And but what we need is further analysis of many of these different phases in detail, including the case management aspects in the hospitals, surveillance. So maybe 1 week long detailed workshop would be required, in which detailed presentation, discussion, and further learnings and other things would be required. So let me stop.
Yeah. Yeah, one good thing with mortality data is that actually nobody can challenge on the mortality data. But as Rajmohan sir has rightly pointed out, we don't know the exact cause of death. Actually, we have to bring in this verbal autopsy thing. But till recently, verbal autopsy by physician was only considered as quality data. But now there are a lot of tools like this health metrics group. They have come up with smart VA, which can be using the tablet-based questionnaire. Health workers can do that, and using tariff method, we'll get the cause of death and all. At Achita Menon Center, we are doing a trial. Actually, we are doing trial in Adiyanur as well as in one block in Wayanad to see whether the health worker coded verbal autopsy will be suitable in Indian situation. Actually, if that comes, actually all our deaths can be verbal autopsy can be done using this tool, smart VA tool, by the health workers, and that will give us more reliable data on mortality. Yes, ma'am.
Sir, even if our deaths are more compared to other places, we cannot consider our efforts as futile, because we are dealing with a population. We are a state with highest number of or highest proportion of elderly population, and also Kerala is the diabetes capital of India. So obviously there is a high chance of mortality in Kerala, but that doesn't indicate that we don't have the system, or we were not having the right efforts. We were having the right efforts. That's the reason why we could perform very good. But maybe mortality may be due to other comorbid conditions as well as because of the higher elderly population in this area.
Thank you, ma'am. I agree with you. Like in Kerala, if you take any infectious diseases, because of our environment and because of this high density of population, because of the continued habitual pattern, because of the intermixing, any infectious disease in Kerala will be like a wildfire. It will affect quite a lot of people and all. Even a viral fever, if it occurs anywhere in Kerala, within the next week, actually, it will be spreading all over Kerala. And that's true in Kerala. And then we are confronted with COVID, with many of us were not having immunity against it, and it had its own cause. But our efforts were not futile. Actually, we had a much bigger problem than many other states that we had to, and our expatriate population, actually quite a lot of people were coming and all. So we have more challenge, more huge challenges, or more difficult challenges than many other states. Yes, sir. Yeah.
Sir, my point is, the total number of deaths actually reported in Kerala is around 71,000. And that the daily or routine reported deaths was around 36,000, as Rajmohan sir pointed out. And Kerala is the only state which has added as per the Supreme Court mandate, these appeal-based deaths to the total death tally, which you can find if you go to the MOHFW website. No other state has added those deaths to their total death tally. For example, for Gujarat, the total number of deaths reported is still 11,000. And as for certain court papers and which I could glance through, the number of deaths or the appeal-based deaths where compensation was given in Gujarat was more than 1 lakh. So all these deaths have not creeped into the statistics of these states, and that's the reason why their CFR has not raised as to it should be. For Kerala, it was 0.5 to 0.6 for some point of time and reached close to 1.1. But for all other states, it's almost remained the same. So it's not point in comparing all these states because our policies has been different. That's my point on that.
Thanks, Dr. Rajan. Actually, we need not compare across other states actually where they hardly had any surveillance and hardly have any major public health system there and all. And there were a lot of cooking data, a lot of suppression of death, etc. that occurred, and we could see through newspapers and all. But let's concentrate on Kerala for this section, actually, how we could have improved. Actually, all our deaths, actually, it's good that even lately we have accounted that as COVID, but whether all those were COVID, we don't know actually. That's the importance of verbal autopsy, which Sir was suggesting. And verbal autopsy should be done within 2 weeks of death. Actually, if we can incorporate that into our healthcare system, we'll have better results. Pradeep sir.
Oh, I have nothing more to add that one. Because usually in the IDSP, we were familiar with the 3 types of surveillance. As mentioned yesterday, syndromic surveillance, presumptive surveillance, and lab surveillance. But in the case of COVID, we saw only confirmed cases. So that is lab surveillance. So I think in the case as he mentioned, there is a problem with the definition. I think all the cases are lab confirmed cases. So there is no question of definition, deviation from the definitions. Then other points, I also agree with almost all points raised here, except in case fatality mortality, in case fatality rate, in India it is almost 1.35 and in Kerala it was mentioned as 1.2 and we are boasting. Is it right thing? Because if you compare without comparing with other states, how can do that? But as Biju mentioned, the quality of data from the other states may be very poor. And there may be some states with a lower mortality rate also. We don't know. Then another thing is about the quality of data. Before that, about the mortality, civil registration system, we can depend upon the, most probably can depend upon the number of deaths. But the cause of death is will not be there in the civil registration system, because when I see, now I am working with the one project with the IMA, where I looked at the death certificate issued from the various centers. I couldn't find any real cause of death. They have written as cardiorespiratory arrest or diabetes, etc., etc. So in the civil registration system also, we cannot depend upon the actual cause of death. That requires verbal autopsy, maybe by the health workers, and further verification by the medical officers, etc. And maybe done in a subgroup analysis may be useful also.
Thank you, Pradeep sir. I also agree with Pradeep sir. Like I have looked into civil registration system in Trivandrum, and actually probably we can take the date, the age, and the sex of the person, and but not anything beyond that and all. But now there were discussions on whether the case fatality rate is low here, and whether it is because of the management. Sir, are you done? No?
Yeah, no, I have one more point.
Yeah, please.
There is about the quality of data we are getting. We have to suspect the quality of data. So, for example, when I was working in the health service department some long time back in 2011 or 2, we will get a rapid increase in fever in the month of June, just after the beginning of the monsoon. But usually, if you look at the IDSP data, we may not be able to capture the rise. But when the media people will come, they will report that the fever has increased 10 times, 10 to 15 times. Then after that, the data quality will improve a little bit. So we have to suspect about the quality of data also. Thank you.
Yeah, probably we'll take it up in the surveillance system. And I'm requesting Chandini ma'am to comment on the clinical management, because if our case fatality rate in Kerala was quite low, is it because of the clinical management? You are working in the critical care.
Thank you. Clinical management, as in any other disease, Kerala, I should say, I may be wrong, but that's what my belief. Kerala, the updates are more frequent. And all that is happening across the globe, new information, evidences, and the guidelines were revised. But it's all according to the WHO guidelines and our national guidelines. It's not that we are moving away from. But one important point that was stressed from the very beginning, we said that steroids are effective when there is desaturation happening. But all our guidelines, we were emphasizing exertional desaturation. That is, if the person walks for some time and there is a saturation drop. It's not that when the person sitting and monitoring with the pulse oximeter. That point, this exertional desaturation, you shift the patient to the ICU. And it was strange. And there was a good association with the health service and medical college during that time. The training was happening across state. And all the clinicians are also keen to know what is happening, how best we can do in patient management. But our important challenge was we were not that equipped. That is true across the world in managing this critically ill patient with ICU facilities where we needed ventilators, ventilators and monitoring.
Yeah.
And that much capacity was not there nowhere. And Kerala also has to work so hard for that. But that expansion of ICU facilities are also compared to other states because we were communicating with our friends in Delhi, Bombay, all those places. And that was also better in Kerala. And there were a lot of resistance in working in the ICU. There were anxiety, stress, everything was there among the colleagues. But that some points might have helped us. And people were more willing to accept newer information. Though there were a lot of confusion with hydroxychloroquine, azithromycin, ivermectin, all these discussions were going on, but those new evidences that come in steroid use. And one important point we were emphasizing on exertion desaturation for shifting the patient to hospital care and ICU. I think that has worked in Kerala. And clinicians willingness to accept newer evidences, newer information and guideline change, and everyone was ready to update. And all those sessions, training sessions on update versions of
The
guidelines.
online training sessions. were very-
Everyone was attending, and Zoom platform has also helped us a lot, and the availability of facilities to join the training.
Thank you. Thank you, madam, for highlighting that coordination between health services and medical education and the ongoing series of training program which clinicians were attending. And we are about to wind up with Mohan sir. Actually, do you have some thoughts on this actually session?
I think the test positivity, wait 1 minute. 10 positivity rate, Sunija has come. Sunija, you want to make?
Good morning, everyone. Actually, Pradeep sir പറഞ്ഞതെന്ന് തുടങ്ങാം. നമുക്ക് പണ്ടുണ്ടായിരുന്ന ആ റിപ്പോർട്ടിംഗ് സിസ്റ്റത്തിനേക്കാളും ഒരു ബെറ്റർ റിപ്പോർട്ടിംഗ് സിസ്റ്റം നൗ വി ഹാവ്. We have a very robust online reporting system, the LDMS system, lab diagnosis and management systems. Though the name is lab diagnosis and management system, it captures everything from the field and from the testing laboratory. So the only thing the concerned district can do is they can remove the duplicates and triplicates. What I mean is, when they do antigen test, they enter it as positive. The same person may be tested for RT-PCR also, or CB-NAT also, in case of death or such cases. So those positives, duplicates and triplicates can be removed from the district, compile the data, and send to the state through the portal itself. At the state level, we do the compilation only. So I think the data is of better quality now, and maybe my limitation of thinking, I can't think of anything better than that. Thank you.
Thank you, ma'am. Actually, right now, actually, Epidemiologist Center is interested by ICMR to look at the COVID test data at the national level. So we were looking at the data, and on a day, it comes to around 5 lakh entries. And there were many issues there, but we haven't started in real sense, but we are slowly working on it. And so.
Thank you. In fact, I remember the first case of COVID came and Thrissur, just close to the university, in 2020, January 30th. And on that day, probably around 11 o'clock in the night, the entire the health stream, the minister, health secretary, and I was also there. And the meeting went up to 2 o'clock. So that was the initial response of Kerala. The first case in India came. And then after a few weeks, university conducted an international conference on COVID. And I remember many people said this is going to be a pandemic. And most of us thought, no, it will not. But then subsequently it became. So that is the history. And one biggest thing, probably what I should say, the biggest thing is that knowledge explosion happened. Because we did not know anything about COVID, but from various sources, lot of knowledge came. In the media was saying so many things. Many of them may be correct, may not be correct, exaggerated. But then all of us were in the business of creating, disseminating knowledge. And probably if we have won this war, it is because of knowledge and knowledge alone. And in such a very short time, we had a lot of knowledge. And vaccine is part of that. Then India did not have any facility to manufacture the ventilators. Now we have enough facility. We were always importing these kits, PP kits. Now we are exporting PP kits. 200 crores of vaccine made in India. And also when the government said lockdown, the entire country went into lockdown. So we were responding to that. So COVID has given us a lot of things. The ability to fight not only pandemics, many other diseases also. Now we are capable. So this is a bad lesson as well as a good lesson. And we are here because of that. And we will have programs like this. Every medical college in India should have an emergency medicine department, decision by the National Medical Council. Why? I think it's because of COVID. Right? It's because of COVID. So such decisions are also coming. So these are the positive points I'm thinking. Thank you.
Thank you, sir, for that very valuable insights. And with that, let's continue the discussion after a couple of presentations on surveillance. Rajmohan, sir, can we conclude this session?
So let us continue with the next session. What worked and what could not work for the surveillance system in Kerala. So I request Dr. Ajan MJ, Junior Administrative Medical Officer Planning DHS, and Dr. Sunija S, Director, State Public Health Lab, to present the session, and also request Dr. Biju Soman and Dr. Anuja, Professor and Head, Department of Community Medicine, GMCT, to chair the session.
Please come in, please. Okay, friends, let's go on to the next session. Actually, it's on surveillance. And as we all know, surveillance is the issue. And if we have learned anything from COVID, that's on surveillance. As our Honorable VC has pointed out, it's time for reflection. So not to argue and quarrel, but to reflect upon what worked and what didn't work. And if no, what is the reason and all. And we were not alone in this peril. Actually, almost every country in the world has faced a lot of issues, and all their models in the initial models were wrong. Even now, actually, we were also following up a COVID trajectory, and we were running a online real-time dashboard. When Kerala started pushing in a lot of the backlog cases, then all our models, our estimations go away. Because that happens actually, not only in Kerala, but that happened in many other countries. What worked and what did not work, actually, we have the people right here, actually, people who are really involved in the containment and the prevention aspect of that. And we have people from medical colleges to look at it from an academic sector as well. So, ma'am, who is a graduate? Ma'am, you are going?
I consider it as a very honorable, actually we have been given a choice to present this surveillance aspects, as Rajmohan sir said. So dignitaries of the dais and experts on the dais, this is a golden opportunity. Actually, Dr. Meenakshi, who was given the responsibility, is attending another state level meeting, and DHS is also attending some other meeting. That's why myself and Dr. Ajan presenting these surveillance details. In 2020, January 30th, when the first case of COVID-19 was confirmed in Kerala in India, much before that, the system has sprung into action when there was no news about the epidemic spreading to various countries. So we set up state level control room, then district level control room, various multidisciplinary teams to handle the situation. Then there were, control rooms in the district, call centers, laboratory setup. All these things happened simultaneously. By the time the first case reached India, actually, we didn't have any testing centers in Kerala. We had to send the sample to NIV Pune. But by February beginning itself, NIV set up testing laboratory at NIV Alappuzha unit. And after that, we could set up many laboratories and a very good laboratory network in the state. And side by side, all the infrastructure development, skill development, and the management all together, we could do in a very better way. So in today's session, Dr. Ajan, one of our junior public health expert, who was working 24/7 in the state control room with the other teams in the state, he'll be presenting about the surveillance in general, and I'll be concentrating on the laboratory surveillance. Thank you. Over to Ajan.
Thank you, ma'am. First of all, I would like to thank the university for giving me such an opportunity and the department to present this tremendous work the whole system has done during the past 2 years. So I'll be presenting regarding the major aspects of surveillance which I have taken during the past 2 years. It's a pretty long period. The system has undergone so many changes during this period. So I'd like to brief it with the major points. And this COVID-19 surveillance system was, this was a new surveillance system as it was a new disease. It was one of the intensive works which has happened during the history of the healthcare system, the public health system itself, and is the longest running surveillance system for the aspect that if we think about the pandemics, there are not too many pandemics that has been documented to this extent, because the last thing which we know was around 100 years back, and we don't have so much information regarding that available with us now. So we'll be describing the COVID-19 surveillance system in Kerala, and we'll like to critically evaluate the surveillance system in terms of its attributes, the strength, weakness, and opportunity and challenges. With its origin being debated still now, the COVID-19 was declared a pandemic by the World Health Organization on March 2020. But long before that, Kerala had reported its first case, and first 3 cases were reported before that, and Kerala was the first and only state to have COVID-19 cases during that period. And till date, around 608 million cases have been reported globally, and 6 2020. And the first guideline was released on January 26, following which the first case was reported. And later the testing guidelines and all changed so many times with risk-based testing strategy for all those persons returning from other countries based on the risk criteria set by from time to time by the Ministry of Health and WHO. And the public health campaign called Break the Chain campaign was launched by March 16, 2020. Universal usage of masks was used by April 7. And pool testing and other testing methods was started by in the month of April. Gene expert was introduced. Then sentinel surveillance. Sentinel surveillance proved very much crucial for the surveillance system in Kerala. That was started in May. That group, sentinel surveillance group, was expanded, including other more parts of the community by June. And antigen testing, which formed a major pillar for testing in Kerala by July. The slide format is a bit different from my laptop, that's why it's a bit disorganized. We used to collect the COVID-19 positive patient details daily through a lab diagnosis management system, which is an online portal which captured all the cases which got tested all over Kerala. And one of the reasons why Kerala used to report cases during these timelines, because whenever a person get tested, it automatically got captured to the system, which is not present anywhere in any part of India, I believe. And other informations which we collected as directed from the state from time to time, which depended upon the scenario or specific directions from Government of India. And this surveillance information was sent from district surveillance unit, collecting data from each primary health center or community health center or major hospitals. It is more or less through an email-based data reporting. And this information was stored in a secured Google Drive, and we used to analyze the state COVID control room as well as the district COVID control room used to analyze this and present this data on a daily basis during the crunch times to district collectors as well as the principal secretary and health minister, and these presentations were sent to till the office of chief minister. This data was as told, this data was analyzed on a daily basis, and daily bulletins were released during that period, which continued till April 2022. That is the longest running period, which we started from January 2020 and published on daily basis till April 2022. The various streams of surveillance which are undertaken is the field surveillance, which I have already mentioned, which include the community surveillance with the help of rapid response team members. This is something which is different from or which we have, in part we were successful in containing COVID, or the activities were mainly with the help of the rapid response team members of the rapid response team members are present in each wards, which included volunteers, health volunteers, as well as ashas in those wards. And they also helped in the contact tracing. And contact tracing, if I could describe, for the initial part, as Jagdish sir said, it was by presenting the route maps, but slowly we could understand that as the number of cases increased, that was a bit difficult, and that was decentralized. But on the later part, we encountered a difficulty in continuing the contact tracing, because all of them were contacts only, and it posed a difficulty. And during the later part, it reached a roadblock. Then infection control practices and protection of health force, healthcare worker positivity was also look through for the initial part, that is during the first year till vaccination. The healthcare worker positivity was looked upon, and policy decisions were taken as to what all things need to be done, whether there is any training, reinforced trainings were given based on findings that certain districts had more cases and all. So that sort of a feedback was also given. Then travel surveillance is yet another major unit which worked doing surveillance in the airports and subsequent contact tracing in the community. Then hospital surveillance. Travel surveillance included all, as you all know, all persons entering the state of Kerala had to register in a COVID Jagrada portal. For the initial period, the permissions were had to be given from the police department, and later an acknowledgement type of approval came. And but till date, this at the national level there is Suvidha, Air Suvidha, and in Kerala there is COVID Jagrada portal. But for the time being, it's not that frequently being used, since all the restrictions have been weaned off. Then the whole genome sequencing as well as the genomic surveillance. The genomic surveillance started in the mid of a first wave, where it was the testing was being done in NAV Pune. And the later part of the first wave, all the WGS samples were sent to IGAB Delhi. And owing to delay in results, we incorporated the spike protein study, where the testing was being done at RGCB Trivandrum and VRDL Kozhikode. And the later part of second wave, RGCB was identified as the sentinel lab for Kerala. And surge samples and random and cluster samples were sent there. Breakthrough or reinfection samples. And sentinel samples from selected labs and international travel samples. And during the third wave, testing was also, WGS testing was also started in Institute of Advanced Virology in Trivandrum. And the strategy for WGS was the random samples with CT value less than 25 from the following categories, and was sent to INSACOG recognized designated labs. The sentinel samples from 11 sentinel labs, and the samples from clusters, severely ill and international travel samples. The follow-up action undertaken was, it traced back the variant of concern, but the major difficulty was the whole genome sequencing results were very much delayed. And by the time we got the results, all the persons might have completed their quarantine period. And that was a major difficulty. And to look out for any breakthrough infections in nearby areas among completely vaccinated individuals, look out for any outbreaks in those areas. And we send the samples of contacts of those persons with variants of concerns also for whole genome sequencing. Another major surveillance undertaken was the hospital surveillance. Hospital surveillance mainly look for the occupancy related data in government hospitals, private hospitals, and field hospitals. Field hospitals means the domiciliary care centers, COVID first line and second line treatment centers. The occupancy related data give us information regarding how much of the active case was being hospitalized, how much of them were in ICU or ventilator, so that the bed enhancement were planned and was done accordingly. There were 3 streams of reporting. The private hospital reported through the state health agency, DHS and DME through their separate teams for that they reported. And the peripheral, the field hospital, CFLDC, CSLDC, and DCC, all these reported to the district control rooms as well as the state control room, and final consolidated at the state control room and reported to the higher ups. We actually calculated data regarding normal beds, oxygen beds, ICU, and ventilator, so that all the serious case data as well as the normal admitted cases. That sort of an information was we could plot. But one major drawback was that patient-centric line list data was not available, which was very hard to get also. So this was an aggregate data only we could gather. Then maintaining routine surveillances and other special surveillances were also happening during this period. Mucormycosis became a threat in between, and we had surveillance for that. MISC also was there for a short period. Post-COVID-19 syndromic surveillance started, but it couldn't go further on. We couldn't go much further on that. Then other communicable disease surveillance was also happening through all these times. SARI ILA surveillance was also happening. Clusters were defined. COVID-19 clusters were defined during this period. And as Jadisa was saying, there were large community clusters, institutional clusters, such sort of definitions existed. And that sort of a surveillance also existed for a pretty long time. During these periods, only two Shabarimala pilgrimages happened. So mass gathering surveillance also happened, during which testings during the period of 2021, there was rapid antigen testing conducted on a random basis and on symptomatics at Shabarimala. Then there was at that period, RT-PCR was mandatory for all the attending pilgrims. And during 21-22, it was not that mandatory because vaccination was already undertaken. So vaccination only was made mandatory. Then 3 serosurveillance also happened during this period in Kerala. And ICMR also conducted 4 serosurveys. And the last serosurvey, which was conducted in August-September 2021, the seroprevalence rate was around 80% in all except antenatals and children. And now I will be glancing through the major events which happened at various timelines. The first period, that is January 20 to March 5, 2020, because this was the period where Kerala had 3 cases only. And the state control room was set during this period, where 18 multidisciplinary teams were constituted, and district control rooms and call centers were also established. The screening of passengers from all international airports and seaports were established. Intersectoral coordination meetings were convened, and guidelines for testing, quarantine, admission, and discharge were published for the first time. As already mentioned, this time, testing and quarantine guidelines, the time duration set was different during that period. And COVID-19 was declared as a state-specific disaster during this period because Kerala only had COVID-19 during that period. And COVID-19 testing facilities were starting to get established during this period. The second is March 6 to May 4th. May 4th only because this was the period during which nationwide lockdown was established, and after this only partial unlocking happened. And the surveillance activities at entry points were strengthened, and it was mandatory for all the incoming passengers to have them registered at the Jagrata portal. And route maps of cases were published to enhance surveillance and contact tracing during this period. The nationwide lockdown was enforced, as already mentioned. And we had COVID care centers for people coming from abroad as well as from other states to get them admitted. And CFLTCs, that is the COVID first line treatment centers, were established for the first time. And at those times, we had COVID hospitals, established COVID hospitals for treatment of category C patients. The human resource scaled up, testing facilities scaled up, and sentinel surveillance was also started during this period. And Kerala Epidemic Disease Ordinance was published on March 27, which laid down mandates and certain guidelines where the district administration could take so many control measures. The community health volunteer groups were established at LSD levels for ensuring adherence to quarantine measures. And the psychosocial support was also initiated, which inquired the healthcare workers as well as the patient regarding their psychosocial care needs. From May 5th to December 31st, there was surge in the number of repatriates as well as the return flights were coming to India. The category B patients were starting to get admitted in CSLTCs. For those patients without any facility for home isolation, domiciliary care centers were established. Home isolation of COVID patients were started during this period as the number of patients increased. And the testing targets, daily testing targets were increased to around 80,000 during this period. And district specific targets were issued to all districts so that based on their case load as well as the population, this testing load was given to them. And sectoral magistrates to enforce the social distancing and COVID protocol based on the feedback from the surveillance. The sectoral magistrates were employed by the revenue department, and strict legal actions were taken against persons spreading fake news through social media and those violating quarantine. And COVID-19 step kiosks were also established during this period where a person can go and get tested at these centers. These are also established at Sabrimala Pilgrimage Center. And all persons entering the state through trains and roads were screened using scores at all points of entry. And at the end, towards the end of this 2020, a new strain of SARS-CoV-2 from UK was reported, and screening and contact tracing of passengers from UK was augmented. And rapid antigen testing facilities were started at PHCs and CHCs for symptomatic patients and persons from containment zones.
Excuse me, Dr. Rajan, how many more slides do you have?
10 more.
Please try to.
Yes. So since describing the surveillance, there are so many, that's why. Okay. During 2021, as the number of cases started increasing, we again reinstated the Back to Basics campaign, that is COVID appropriate behavior campaign. And Delta wave genomic surveillance was also initiated. And during the month of April to May 2021, again the cases started increasing, or was known as the second wave all over India. The weekend lockdowns and subsequent complete lockdown was started. And during this period, a TPR-based containment approach at the local self-government level was taken, which is followed by a weekly infection population ratio, that is basically incidence based control rates were used. And the declaration of deaths, online declaration deaths were also taken during this period. During the year 2022, Omicron surveillance, that is the third wave, happened during this period. International travelers tested positive were given an option for home isolation, which is contrary to what Government of India said. Home isolation for COVID-19 positive asymptomatic international travelers. The isolation period was changed to 7 days, and testing was changed to purposive testing because vaccination has already reached 80 to 90%. And a threshold action matrix was created to categorize districts based on to enhance hospital infrastructure testing, etc. And this is in short what happened during the past 3 years, where we can see so many ups and downs. The first surge happened during October. Following that, we could see a surge during April to June. Following that happened in September, October 2021. And again, the Omicron wave during February January, February 2022. And this is the total cases, total deaths and case fatality rate. The maximum number of cases were reported in 20 to 50 age group. And the males had higher case fatality rate compared to females. And the age group also 60 to more than 60 years had the highest case fatality rate. With the districts, as already Rajmohan sir already shown, so I am not going to describe that. Coming to the attributes, the COVID-19 case definitions and ease of compilation was it was more of simple nature. The guidelines changed so many times, so even though we can say that that was flexible, that created some sort of a confusion in the periphery also. But we could counter that by repeated trainings and repeated day-to-day meetings on a day-to-day basis with the district control rooms. Coming to the data quality, since it was an online reporting system from the most peripheral point, that is from the labs, the data quality cannot be argumented because it was from the point of testing itself, the data was entered. And if at all any issue existed, we contacted the district control rooms and give feedback to the concerned labs. And representativeness was there as all the units were reporting to the state, and timeliness was also ensured. Coming to the last section, that is the SOC part. The strength, the online platform for COVID testing and reporting was a major strength, which captured almost all cases till that antigen testing kits were made available. That might have a bit diluted this. And then creation of platforms for streamlined and transparent sharing of information between health system and general public. The person getting tested can directly download the reports from these portals. Then the COVID Jagrata portal helps to monitor the surveillance data till the peripheral most point, even though it creates a bit of a confusion between two data sets for some point of time. A well-established health infrastructure at the field level and upgradation of the infrastructure at healthcare institutions, and decentralized surveillance system with supportive supervision from state and district units, and intersectional coordination, political will and data-driven policy, and constitution of different teams for different sort of surveillance activities. The major weakness was fatigue, because the same group of healthcare personnel were involved for all these surveillance activities. The urban health system lacked enough manpower for effective surveillance, and the delay in whole genome sequencing, multiple surveillance systems, comparability of data is always difficult. And there was no free flow of data during the initial period, which was a weakness, which we could counter with COVID Jagrata and LDMS systems. The opportunity was that we gained the experience, the hospital infrastructure got improved and lab network got improved. We could use the same systems for the other future activities. The online meetings and online trainings were much useful, but we have to use that with caution also. Public and administration are now much more aware of the preventive and promotive strategies, and media also took initiative to discuss this. The major challenges were surveillance and decentralized testing in hard to reach areas, the responsive behavior change among the public, and no media policy to handle to the media. Then training for program officers such in media management, effective contact tracing on the later part, and lack of consistent coordination with other department staff who were involved in surveillance. And the proper monitoring and validation of data and trainings on large data management can be taken as a recommendation, and seroprevalence studies in the post-vaccination era, and a need for a sub-district or block level public health unit for more coordinated surveillance can be the various recommendations. With that, I would like to conclude my presentation. Thank you.
Thank you, Dr. Rajan. Now let us break for the tea and we'll continue the rest of the session after the tea break. All are requested to reassemble by 11:05. Thank you. Attention, please. All are requested to reassemble the hall, please.
Okay, friends, welcome back. And I'm requesting Madam Sunija to start the presentation. It's a very short presentation and we'll have a very short discussion afterwards, as we have accepted.
So when Kerala reported the first case of COVID in January, on 30th of January, we had to send the samples to NAV Pune for the diagnosis. And we never had a diagnostic lab we have PCR laboratories and at RGCB, at State PH Lab, and in our BRDL, but we didn't have test kits and reagents at that time, and we were forced to send the sample to NAV Pune. Even otherwise, when dangerous pathogens are reported, we have to get a confirmation from the NAV Pune. So first 72 samples were sent to NAV Pune. Even before sending the samples, or even before report of the first case, we have given sample collection standard of operation procedures and all those guidelines to the field. So that was not a problem collecting samples. When 3 of our students returned from Wuhan, and suspected they were having symptoms and suspected of COVID-19, the samples were immediately sent to NAV Pune. And we started the active contact tracing, and with the contact tracing, the need for testing increased exponentially. So NIV Pune set up a testing facility in NIV Alappuzha unit by 3rd February. And NIV Alappuzha unit provided all the support for samples sent from state to NIV Alappuzha unit. And the government have taken all the possible steps to set up further diagnostic laboratories in all the districts of Kerala state. Initially, ICMR considered all the VRDL laboratories which are in their network. And the state demanded that we have other laboratories also in the state which are able to do the COVID-19 testing. And in March 2020, ICMR approved 6 laboratories for doing RT-PCR testing. So we arranged something like a hub and spoke model for COVID testing for samples collected from all the districts in the state. So for example, Pathanamthitta district was given State PH Lab as the designated laboratory. Trivandrum to GMC Trivandrum, like that, with the 6 RT-PCR laboratories in the state, we transported samples to these designated laboratories. So the 6 laboratories included 3 medical colleges, State Public Health Laboratory, RGCB Laboratory, and the Inter-University Laboratory at Kottayam. And the effort continued, and we could set up 28 RT-PCR laboratories itself within a short span of time, so that each and every district having a testing facility in the district itself. And ICMR provided all the support for the testing laboratory, right from the training to material supply to quality assessment. Then testing methods based on ICMR guidelines. We started all the testing various test methods like RT-PCR, CBNAT, TrueNAT, antigen, etc., based on ICMR guidelines only. And nuclear amplification based tests included RT-PCR, CBNAT, TrueNAT, RT-LAMP, etc. And rapid antigen test was introduced later. Along with routine samples, epidemiological studies were also carried out by sentinel surveillance samples, augmented samples, and antibody surveillance. And I think Kerala is one of the states who has, done these testing strategies in a very good manner. Because laboratory surveillance data always give a very authentic data which helps to tackle the epidemic situation. And in Kerala, when the epidemic evolved, so did the laboratory testing capacity also. And there was a beautiful private partnership, public-private partnership, which is still continuing. The laboratories in the private sector, which conforms to the ICMR guidelines, were given approval for testing RT-PCR and other tests. The nuclear amplification tests were approved for the laboratories having NABL accreditation only. But for antigen testing, approvals given to the private laboratories by the state government, provided they have a tie-up with the RT-PCR laboratory in the state. And another thing which was done for the public interest was that the rate was fixed for each and every type of test. For example, in the initial phase, the RT-PCR rate was about 3,500 rupees, when the other states were charging around 5,000 rupees. Later on, the rate revision happened 2-3 times. And at present, I think it is around 300 rupees for RT-PCR and 100 rupees for antigen testing. And this facilitated testing in a smooth manner in the private sector also. Now, the state level COVID lab management team was set up to facilitate the ICMR approval process. It was a tedious process, and the team included Director State PH Lab, one assistant professor from Medical College side, Dr. Tony, then one of our SR, Dr. Aparna. They were fully involved in the process. A dedicated email ID was given in the advisory itself, so that the institutions, whoever starting the process, applied in with mail ID, and we will check all the requirements given by the ICMR advisory. If they satisfy all the guidelines, approval will be given based on approval from ICMR. So Sri Chitra was the mentor institution for this process. So the checklist will be verified and will be given to Sri Chitra, where Dr. Kavita Raja Madam was doing the final vetting or final verification of the infrastructure facilities, trained manpower, all those things, and it will be communicated to ICMR. Based on that, ICMR will give the approval for the private lab. Then the state will formally inform them that your lab is approved for doing RT-PCR testing or whatever test they have requested for. So with this, we could set up a wide network of testing laboratories in the state, which included RT-PCR laboratories, antigen laboratories, and all those things. And totally, we have nearly 100 RT-PCR laboratories, majority in the private sector, which we can imagine because most of the major laboratories are in the private sector. In the government sector, as I said earlier, all the BRDLs, other GMC laboratories, public health laboratories, inter-university laboratories, and central institutions like Sri Chitra, RGCB, MMC, and Central University of Kasaragod was given approval, so that the facility was available everywhere. And based on the testing strategies and other guidelines from Government of India or ICMR, we used to issue guidelines and advisories to the district to perform testing. For example, for mobilization of patient, antigen test can be done and the symptomatic patients can, ILI, SARI patients can be isolated immediately to the hospital, or if they are antigen positive and not very symptomatic, home isolation, all those things done based on the test result. And another requirement was that the private lab should use only the kits and reagents approved by ICMR, which are available in the website of ICMR. And if there is any violation, that was a doubt if the private labs are violating or not. If there is any violation from the private laboratories, an initial warning will be given from the state. And if they don't, rectify within the stipulated time, their registration will be cancelled. And 2 or 3 labs we have given warning. And most of them rectified and their registration continued. But one laboratory we have to cancel the registration. Later on, they rectified everything, informed ICMR, and they are also continuing now. Another important, very crucial factor was sample data management. And initially, the data flow was maintained by Google Sheet. By sharing Google Sheet to the district will be updating the sample collection details and the patient details, everything by using Google Sheet. And this at the state level, it will be verified and updated, but there will be some delay in getting the data, and the compilation also takes time. So in May 2020, one of the tedious process was the collection of travel details, the interstate details and the international travel details. You may be remembering the evening data disclosure by our Honorable Chief Minister, which includes interstate travel persons numbers and international travel persons numbers, all those things. So that data collection was very tedious while using the Google Sheet. So by May 2020, government developed an online portal, the health monitoring portal or the Health Mon portal for real-time management of data. The access was given to the designated persons in the district as well as the state level at the state control room. And an API, an interface was also established for the transfer of data between the state and ICMR. This has reduced the double burden of data entry in both the portal. The ICMR portal was there from the beginning itself. And by October 2020, a modified and upgraded version of the state portal came into effect, which was developed by NIC. The present LDMS portal or the lab diagnosis and management system, which is much user-friendly, stable, speedy, and easy to analyze the data for sample data entry and lab data entry. And another particular feature is that internal login at the lab user end to approve the test result after verification. You can verify the test result entered into the portal and you can approve it, or you can ask for a correction from the state level, then re-enter the data. The designated district and state authority were given the data access. Apart from the basic details, other statistics including vaccination and travel history, contact details, etc., were symptomatic, asymptomatic, all those details were available in the portal. Another key feature of LDMS portal is that the result access to the general public was given so that they can scan with a QR code for travel purpose, etc. For state level compilation, daily compilation and reporting of COVID data, a state level reporting unit was set up in State Public Health Laboratory. That was because, just like Dr. Ajan has already described, the state control room was flooded with activities and they were not getting a breathing space. And just for compilation, a state reporting unit was, because the data is mainly from the laboratories, a compilation unit was, state reporting unit was approved and it was set up in the State Public Health Laboratory. Currently, this activity is done by IDSP. So the team will download the data from 1 p.m. to 1 p.m. every day. 1 p.m. data will be downloaded and will be compiled based on the compilation or the summary of data received from district. As I said earlier, there will be duplicate and triplicate entries in the portal based on the tests done in different times. Like at the time of hospitalization, an antigen may be done, after that an RT-PCR may be done, or at the time of death, CBNAT or TrueNAT may be done to dispose the, release the body early. So the data include the number of samples tested, new positives, cumulative positives, last 24 hours data, etc. So based on the net speed, there will be problems every day, like the downloading the data and compilation. Every day we used to give the data before 4 p.m. and the data will be given to Principal Secretary Health. After verifying the data, it will be given to the Honorable Health Minister, from there to the CM and our control room. Approved data will come to the control room and it will be given in the dashboard. That was the flow of activity related to that. And state level reporting of COVID daily data to the government. Then compilation of weekly data was also being done. This was mainly done by one of our SR from Community Medicine Department, and I'll be verifying and submitting the data to the government. So as Chandini Madam has already told, the health services team and the medical education side was working hand in hand. And, the desiccation on both sides was not a matter at all. And there were sincere effort from both sides, from the community medicine department, from the infection control. I should mention Dr. Aravind also. We used to call him for various needs, and Dr. Ajan control room, and all the district surveillance officers, all the VRDL HODs, and I should mention Dr. Sharda Madam's name specifically, because she was the state nodal officer for microbiology that time, and she was so supportive. And another person is Dr. Suganan sir from NIV Alapura unit. He used to do all the licensing with the NIV Pune unit, and will give the feedback. Whenever in doubt, we will contact him. He will communicate with NIV Pune and give the feedback. All the technical issues we used to contact Dr. Sharda Madam, and we get the feedback from her. She was so active, and we were under a lot of stress also. Every time we get call from from our health ministry, from the national level. So everybody was working something like 24/7 during that peak time. Okay. Another very important activity was material supply management coordination. Because initially the test kits and the reagents were given from ICMR through NIV Pune. So the state was under lockdown, and KMSCL would send vehicle to Bangalore airport or Chennai airport. It won't come to our Trivandrum airport. And on road, they will collect the test kits and reagents and supply to various laboratory. And we were at State PH Lab, we were given the responsibility of maintaining the stock position of these reagents and test kits and inform back to ICMR. And one IAS officer from national level, National Disaster Management Authority, he used to monitor all the stock position in various states. So weekly we have to update the stock position to, national authority. And after a few months, ICMR approved the states to procure reagents at state level. So KMSL has started the responsibility of, procuring the test kits and reagents. side by side, viral transport medium was an important part of sample collection and transportation. Initially, there was lot of problems associated with the availability of viral transport medium from national level. They will give a allotted number to each state. So state public health lab was already producing viral transport medium for H1N1 surveillance and dengue surveillance. So we enhanced the production. There was a dedicated team of lab staff, experts to produce the viral transport medium, pack it and supply to. We developed a supply chain in the lab itself with the help of KMSCL. The courier agency will come to the laboratory every day. They take the packages from the laboratory and supply to each district based on their requirement. So there was just 3 persons in the viral transport medium production unit, the media section. We enhanced it to 15 numbers, all coordinated by one scientific officer, very dedicated person, Sri Jayachand. He is trained from CMC Vellore and Sri Chitra. So complete dedication was there, and we prepared around 24 lakhs number of regular VTM, that is 2.5 to 3 ml regular VTM and 0.5 ml modified VTM for the pool testing. Actually, the amount will come in crores because in the beginning, the cost was around 200 rupees per vial. Later on, now it is very low, like 15 rupees or 20 rupees per vial. When it was available in the open market, it was freely available in the open market by the middle of, from the middle of, I think 2021 middle onwards, it was freely available. Otherwise, we used to prepare it from the state PH lab, and during the COVID peak, second wave, we requested Sri Chitra Center for supporting us for production because it was not freely available. They also helped us.
Excuse me, ma'am. We are running behind the time, so
Yeah,
time allotted is also
just 1 or 2 slides. So also the support, I should mention the support given from the other line departments like fisheries, veterinaries, and agriculture department, because during lockdown, their laboratories were idling and they were having PCR machines and extraction machines. These machines were mobilized and placed in many of our institutions as additional equipments, and the sole equipment itself for some of the institutions, and they supported us like anything. After the peak of the COVID, after lockdown period, we returned the equipments. And I should mention Dr. Apanna and Dr. Tony, they coordinated all the activities for mobilizing these activities and supporting me very well. Now, the HR support of the law. Actually, I'm very thankful to NHM and KMSL for the material supply as well as the HR support. The NHM director asked me to compile the requirement of HR from various RT-PCR laboratories and compile it and give it to NHM. And the HR was approved, and we could get research officers, lab technicians, lab assistants, and cleaning staff and data entry operators. That was a big support because initially we were, testing like 300 to 400 tests per day, which enhanced to 35,000. From there to 1 lakh, 1.5 lakhs tests per day. And this data entry was very, very important. And the priority should be given for entering the positive results first, then only the negative results. From the private side, we face certain problems because they used to enter the positives only. So when we take the TPR will be high in some areas. So we gave a warning and they also rectified. They posted more data entry operators. And that's in a nutshell about the laboratory surveillance which happened in the state. Nearly more than 5 crore tests were done, around 67 lakhs positives reported. And as I told you, the duplicates and triplicate entries could be removed. I think on the laboratory side, we were better off. Thank you.
Thank you, Dr. Sunija and Dr. Ajan, for taking us through a 3.5 year journey of this struggling with the pandemic. Now we have an surveillance system as well as a lab network. So even now the COVID surveillance is going parallel to IDSP surveillance. Even in medical college during the third wave, we used to report around 1,800 to 2,000 cases from all the medical colleges together with the 150 plus deaths. Now it came down to last week we reported 156 cases and 48 deaths. So do we need to continue this parallel system of reporting even now? It is high time to integrate with the IDSP. That we have to discuss. Second thing is now all the major hospitals are having facilities for RT-PCR testing. Now, even though it is established for COVID diagnosis, now since the COVID cases came down to such a low level, how we can utilize this established facilities for other disease diagnosis and management, and ventilators and other oxygen facilities, everything established in all the medical colleges. So are we utilizing now? If you are not utilizing it, it may go unusable way. So that also to be thought of, or it is to be given as a recommendation from this group or something. So how we can effectively utilize the established resources, permanent resources, what we got or what we gained while we tackling with pandemic. With these words, this is open for discussion. I think experts are there. If you add additional points, Sarah, madam. One or two. Yeah, one or two comments.
Thank you, Ajan and Dr. Sunija, for making such a broad presentation of what we did during last 20 years. This control room may be first time in the history of Kerala, such a long period, 2.5 years, still continuing. And so very well presented these structures which we evolved and the method of functioning and all. Thank you so much. And but we need to make some further analysis part into it. And different phases, you already break it into different phases, and already we all know that. And so morning also we had 2 presentations, and what I suggest, sir, Rajmohan sir and respected VCs here, since this is first time in history such a thing happens, and so we need further follow-up workshops on COVID, what worked well, what not worked well, and maybe KUHAS, the Public Health Institute, the Public Health School, and SSRC or Public Health Wing of the Directorate can further organize workshops, follow-up workshops, maybe a 2-day workshop, one for surveillance and lab surveillance, another day for the material management or clinical care management, or maybe a series of workshops and discussions to be planned. And we should assimilate our learning principles or learning systems from these pandemic management, and what not worked well, or where we failed, or where we were not that competent enough, all those areas to be identified. And this is my humble suggestion. And once again, thanking the whole team for making such brilliant presentation.
Congratulations for the comprehensive presentation and also the chairperson's remark. I just want to remind us of the TPR, the terror word that used to hold us all every day. TPR, actually we should have looked at the denominator, from whom we collected it, whether we collected it from asymptomatic, whether we collected it from symptomatic, because that is related to the local context. When we had enough of antigen kits, we may have surveyed lot many. So that is a learning point which needs to be remembered. An unnecessary thrust given to a rate without considering its local connotation and ramifications. Thank you.
Thank you. One. Yeah, just 1 minute, sir. No, I think that we had a wonderful session, and we know how Kerala has built up the surveillance, both the cases as well as the lab test. But when we are looking back, how we could have improved that. Probably one of the corner principles of prime principles of surveillance is inclusiveness and transparency. Although quite a lot of things were being done, as Dr. Sairu has pointed out, we were not given the denominators. Actually, so the denominator of even the TPR calculation, etc., should be given to the public or to the research group and all, because quite a lot of things were going on in the background, but even the research community or academic committee were not taken into confidence on that. So that aspect, if we can, next time when we are facing such a thing, actually, if we can make it more transparent and accessible to everyone, that would be good. Second thing, regarding the denominators, it's high time that in Kerala, we have to, probably we can call a group of demographers to come up with the proper denominators. A state level projection or district level projections might not be sufficient. For example, what's happening in Wayanad, what's happening in tribal areas or in coastal towns and all, probably we have to look at the disintegrated growth rate and we have to come up with a composite, at least a projected figures for these denominators. That's what we should be looking forward to. With that, I thank the organizers for giving us this opportunity. Thank you.
Actually, I should thank the Health Services Department for coming up and making a wonderful presentation. And this is what the university really intended. And this is just a beginning only. We will be having continuous activities like this. As it has been said, we will have multiple workshops. We know that the Health Services Department in Kerala is doing an amazing work, but I don't know whether this is really seen by the academic community, whether it is really seen by the world. So we will see that it will be seen all around. And we can have publications, we can have multiple presentations so that the whole world see what we are doing it. And that responsibility university takes. Thank you.
Thank you, sir. We are really short of time. We are getting into a very important session for the university, faculty, and the students. That is impact of COVID on health science education. As all of you know, for the last 2 years, a small group in the KUHS headquarters was doing relentless work under the leadership of Honorable Vice Chancellor, PYC. Then everybody was involved in that. And we are presenting actually that in a very nutshell today. And we hope most of the teachers are here. We expect a good discussion. Thank you very much. I request our Honorable PVC, Dr. Vijayan, to be in the chair, and also our Joint Director of Medical Education, Dr. Ajay Kumar, to be on the chair and coordinate the activities in the presence of our Honorable VP. Dr. Iqbal will be presenting.
Dr. Iqbal is the Dean of Student Affairs in Kerala University of Health Sciences.
എല്ലാവർക്കും നമസ്കാരം. രാജ്മോഹൻ സാർ സൂചിപ്പിച്ചതുപോലെ മുൻകാലത്ത് നമുക്ക് മാതൃകകളില്ലാത്ത പ്രതിസന്ധിയാണ് ആരോഗ്യ വിദ്യാഭ്യാസം നേരിട്ടത് കഴിഞ്ഞ 2.5 വർഷങ്ങൾക്കിടയിൽ. അതിൽ വളരെ കാര്യമായ കൂടിയാലോചനകൾക്കും പ്രവർത്തനങ്ങളും കൊണ്ടാണ് നമ്മൾ ഈ പ്രവർത്തനങ്ങൾ തരണം ചെയ്തത്. അത് ചുരുക്കി അവതരിപ്പിക്കാൻ ശ്രമിക്കുകയാണ്. ഈ പ്രസന്റേഷൻ പ്രിപ്പയർ ചെയ്തത് ഡീൻ അക്കാഡമിക് ഡോക്ടർ ബിനോജ് ആണ്. അദ്ദേഹത്തിന് ഇവിടെ എത്താൻ കഴിഞ്ഞിട്ടില്ല. ഇതിൽ ഒരുപാട് കോൺട്രിബ്യൂഷൻസ് യൂണിവേഴ്സിറ്റിയുടെ വിവിധ വിഭാഗങ്ങളിൽ നിന്നുള്ള കോൺട്രിബ്യൂഷൻസ് ഉണ്ട്. അവരെല്ലാവരെയും അക്നോളജ് ചെയ്തുകൊണ്ട് ഞാൻ ആരംഭിക്കുകയാണ്. Actually, COVID response started early in KUHS because the night of January 30th, 2020, when the first case of COVID was reported in India, which was happened to be in Trichur Medical College, immediately a high-level meeting was conducted, chaired by the Honorable then Health Minister, Srimati Shailaja Teacher, and in which our Honorable VC has attended, which was the opener for all the activities on COVID in the state. And later on, before the COVID was declared a pandemic, university conducted a international conference, which was a brainstorming session on the possibility of COVID being a pandemic, and which was attended by stalwarts like Dr. B. Iqbal, who was the chief of COVID advisory committee to the government, and Dr. Koji Mitsumoto and Dr. Sunil Chako. There was an important advisory committee formed, and which all affiliated colleges of the university were instructed to form COVID Jagrata Samitis, college level, which monitored and reported events related to the pandemic in their respective institutions. University level COVID Advisory Committee was constituted to monitor and coordinate COVID-19 control activities in individual colleges, which was chaired by the Honorable Vice Chancellor, and Dean Student Affairs was the convener of the activity, and all other statutory officers and public health experts. Many of them are present here. Suma Madam, Sairu Madam, Shankar Sir, and many other experts in public health in the state were members, and we held regular meetings online after working hours and deliberate long hours about the strategies to be taken in different colleges in different situations during COVID. And we issued necessary instructions and guidelines to colleges from time to time. And there is another university level COVID vigilance committee, which was to monitor the COVID activities, COVID defense activities in the university headquarters. The registrar chaired the meetings of the university, which again was in the online mode. And I convened the meetings, and from that members are starting from JR, Joint Registrar, who is present here, Geeta Madam, as well as security staff, from all floors of the university. Members are present who used to monitor the movements, activities, which is anything that is abnormal, anything that is not conducive to the defense of COVID was reported, and immediate action was taken. And also we coordinated with the health people, health authorities like healthcare workers, health inspectors, and all. And according to their instructions, we made changes to our sanitization practices, hygiene practices, the canteen working, and all those things, and issued necessary instructions and guidelines to staff from time to time, and coordinated with the local health authorities and organized testing and vaccination campaigns also. On the administration front, office functioned following COVID protocols, except during the lockdown period, and work from home facility was initiated and successfully conducted. A remote login for KUH's office suite was enabled. Financial assistance given for the staff to procure laptops to enable work from home. All meetings were conducted using online platforms, and all payments of the university to the university were made online. The Academic Council and Governing Council gave approval to establish an online learning platform. Moodle, which is an open source platform, was selected as the preferred learning management system. And we have sensitization programs were conducted for faculty on online learning platforms in general, and Moodle in specifically. And technical support was given to institutions to adopting these learning management systems in their colleges. The effort of the team in the IT department of the KUHS under the leadership of Harilal sir should be mentioned here. And 750 trainers were from faculty, 740 faculty trainers were selected in the first part, who trained in turn the faculty in their respected colleges, and the Moodle or other online platform classes were conducted successfully. Webinars were conducted on a regular basis on COVID-19 related topics. Academic sessions were conducted on health problems, medical education technology, and research facilitation. Around 50 webinars or continuing medical education programs were conducted in 2020-21 itself. Some examples of the programs conducted by university: practical challenges in pandemic prevention, the case of vaccine use. This is a webinar attended by the Honorable Vice Chancellor, Dr. N.K. Arora, who addressed us yesterday online, and Dr. Sanjay Madhav Mehendale. Another webinar chaired by our Honorable Vice Chancellor and participated by Dr. N.K. Arora, Dr. Rajmohan, and Dr. Raju, who is the Director of Health Services. Another session about the work stress and well-being was the keynote speaker was Dr. Arun Kishore, associated as consultant in NHS UK. When you come to the examination, so much work has been done in the examination section. So much complaints are also there, but of course we try to do a lot of work on the examination front. The whole, under the leadership of the controller of examinations, the whole team worked day and night to make examinations adapted to the COVID situation. Decentralized evaluation camps for theory paper evaluations were started and permitted hybrid mode for practical examinations. For example, the external examiner was permitted to be conducting the Viva or practical in online mode, and permitted scenario-based case discussion if clinical material was not available or not sufficient. And there was of course, we agree that there was an inevitable delay in conducting exams, especially during the first wave of COVID. But we have some silver lines among these. For the second MBBS practical exam was conducted in 2020 June itself, using novel mode of conduct of examination. That is, direct microscopic use was replaced by slide projection for examination. And restarting offline classes, the special permission was given by the Honorable Chancellor and also the government for starting the classes as early as December 2020, where majority of almost all other colleges or university in other universities started after many months later. And remote digital evaluation was introduced in 2021. Evaluators can value theory, in which evaluators can value theory papers online at university certified valuation centers set up at each institution. And shorten the time taken to publish the results. Efficient use of expert manpower was made use of, and avoids unnecessary travel and wastage of time. To ensure the availability of trained manpower, all pending, this is the one of the major things thrust given by the university, to complete all pending final year examination as early as possible, and results published on a war footage. Certificates sent online to State Medical Council to start internship of medical students as early as possible. Provisional issue certificates issued to over 2,400 students who completed their CRRI, and CRRI of final year students started during lockdown period as per schedule without any delay. Convocation, initially online convocation was conducted, and around 9,500 graduates are conferred degrees on 25th April 2020, and degrees and certificates issued through post. Convocation in 2021 was done in a hybrid mode, and the admission process was facilitated by migration certificates prepared through a digitized process. Started an online facility for downloading the certificates, and online submission documents were provisionally accepted, and additional time allotted to complete the registration process. During the COVID period, students were under immense stress because of the delays in examinations and difficulty in accessing through online mode, and so many different problems. And through the student support guidance program of the university, we organized a lot of programs to relieve the stress of students. Academic guidance and support was provided for students, especially in colleges where results were found to be poor initially. So direct intervention was done in such colleges, and college level grievance and redressal committees were established. Initially, there was only a grievance redressal mechanism in the university only, but during the COVID period, we established this mechanism in every college, so that students can approach the college itself for initial grievances, and establish an online facility to address the grievances of students. Effectively handled the surge of grievances, especially during the first year of COVID. There was a huge surge of cases for the Board of Adjudication, which was handled effectively even without having a single offline session. Online sessions were conducted frequently, and the cases were disposed of effectively. And also one more point is we started physical education departments in all colleges during in the end of towards the end of the COVID period, because this is very important because the students were not having enough physical activity during that time. So to tackle that issue, we have addressed this physical education. I established these departments where there is no qualified physical education teachers available. An interested faculty was given charge and the physical education activities are started in those colleges. MPhil clinical epidemiology course was started during COVID period in the online mode. Certificate programs conducted by the university schools were converted to MOOC courses, massive online open course format. Courses were hosted on the course online KUHS online platform. Public portal in the university website started by name Podujanarogya Vijnanam, in which there were materials and courses on COVID-19 and other common health problems. District-wise list of all students of KUHS submitted to the district administration, out of which more than 8,000 students were recruited to the Sannadha Sena and utilized on different COVID defense activities in the state. So these are some examples for the COVID activities conducted by the NSS volunteers in the state. Apart from NSS volunteers, in most of the colleges, the college union and other student members have actively participated in the community services programs. Now, we had a gap in the university exams conducted during the period of lockdowns from March 2020 to June 2020. Then we conducted the practical of second MBBS. Again, there was a gap for up to October. Then we restarted in November. Again, little gap was there in the second wave period. Then the universities examinations actually was conducted during the COVID period has relatively normal pass percentage. The before COVID pass percentage, last 2 years before COVID, it was 78% around, which came down slightly to 76%. But after COVID, again, it is picking up, but that data is not complete. When you look at the stream-wise results, you can see that almost all departments or all of the streams, the results were almost at par with the previous results, except in nursing and paramedical. When you compare the meetings conducted before the COVID, actually the attendance of meetings improved in online mode. You can see that all the online meetings are having a higher percentage of attendance in academic council, governing council, everything. And in board of education also, the online meetings, the number also increased. The participation of students are also increased, especially in 2020, where around 300 cases were handled that year itself. And there was a surge in PSSD cases in that period. And the university conducted a COVID documentation survey in which questions were sent online to all institutions in August 2022. We asked about restarting of offline classes, vaccination status of faculty and students, COVID infection rate of faculty, students, and non-teaching staff, details of university examinations. So totally, we out of 300 and something, 14 colleges, we received 220 responses. The responses are a little low from medical colleges, and half of the nursing colleges responded. Almost 98% of faculty and students were vaccinated. First dose were 98% and second dose more than 96%. Data about the third dose is not complete. And most of the colleges reported a delay in restarting offline classes due to COVID outbreaks in their respective colleges. But practical examinations were conducted relatively smoothly in most colleges. Only few colleges had difficulty in conducted or delay in colleges for practical examination. And most of the colleges completed arranged separate exam facilities for COVID positive students as per the instructions of the university. So we learned some lessons from the COVID pandemic about education. Online education can complement but not substitute conventional health science education methods. So after the COVID, so most of the online activities have ceased. But considering the plus points of the online method, we should be thinking about the partial, at least reintroduction of online facilities, online teaching in a partial way, especially in the newer methods like flipped classroom models, which turns out to be very successful. This kind of activities may be restarted or initiated in all colleges. And work from home can be effectively tackle official challenges during a crisis. We learned that work from home is not only for during the COVID period, but it can complement the routine work. Mostly we can meet deadlines. Whenever there is an emergency, we can do this continue, especially people have this infrastructure now. Most of the people, faculty work and students, staff working in the university have infrastructure for online working. So this is a good option. We can think about continuing, and online meetings may be more efficient in some situations, especially if the online meetings are properly adapted to the situation, because the same transition of meetings directly into online mode may not work properly, but tailor-made into the specific requirement of the situation. Where BSD is a very good example of that. BSD, Board of Adjudication meetings we conducted online. The student will be given an opportunity to present his complaint digitally. He can prepare a PowerPoint presentation and present it online. And then everybody can see the complaint or grievance in advance. And then it is easy for us to take a decision, informed decision, and dispose the complaint on a timely manner. So in such way, the hybrid meetings also are good, giving a good result related to attendance. So we need to focus on to continue in that mode. In conclusion, resources were limited and previous experience was non-existent during the pandemic period. But with a clear vision, strong leadership, and motivated workforce and cooperation from all institutions, KUHS could tide over a most tumultuous period of crisis in its first decade of existence itself. Thank you.
Thank you. Thank you, Dr. Iqbal. That was an excellent presentation. The presentation shows that when most of the educational institutions in the state was remaining closed, the KUHS was not remaining idle. Hectic activities were going on there. And even though the demand from the side of the student was not to have examinations because of the reason of COVID, we insisted that no dilution was permitted and the examinations went on. Immediately after the first lockdown, it was a real challenge that the 2017 batch second MBBS practical examination started in June 2020 itself. And our Vice Chancellor gave a brave leadership. And we could conduct that complete practical examination by taking a long time. It was completed in November 2020. And the students are residing in different parts of the state. They were given permission to appear for the examination from the nearest available institution. The nursing stream was utilizing this permission to a large extent. Similarly, as it was evident from the slides, almost all the examinations were conducted, and even though there was a total lag of nearly 9 months, 9 to 10 months, we could reduce it to nearly 5 months. So that's was not presented. It's not. Yes, that we will discuss, and if there are any questions, we will discuss later. Okay. Do you want to say?
Anyway, thank you, Dr. Iqbal. We all know that COVID was a challenge. Kerala University of Health Sciences managed it in a very good way. And while I was the principal and vice principal during that period, I faced a lot of problems. And at any time, I can contact the VC. Personally, he knows. Even at 1 o'clock in the morning, I used to call him and made some clarification regarding how to manage these students. Management of students was a real problem. Actually, Kuhas has given a very good direction how to manage it, especially conducting examinations and classes. So sticking on to the COVID protocol, Kuhas managed these condition codes in a very nice way. Thank you to all the office bearers and the administrators for doing this. Thank you. Any discussion if it is needed? Okay.
Telemedicine, what was the role of, maybe it is not coming under the purview of medical education, but since it is not being covered, just if somebody can give few words, the role of medical colleges in telemedicine during COVID time.
I think
during medical college, whether it was patient care side, maybe coming as a problem.
I think college e-Sanjeevani ano other e-Sanjeevani. I think all madam.
No, to my knowledge, telemedicine and the Sanjeevani were working in all medical colleges because the departments which have to function has been told already declared, and the patients could register. And information or management points were given to them. That is going on throughout the COVID period. Now it has come down. That's all.
One second, sir. Actually, facilities for telemedicine is actually was a very expensive method in the previous years before this online facilities are available. So I used to go to while I was working at Aleppi Medical College, I used to have telemedicine link with the government hospital Ernakulam and one government hospital Wayanad. So that time it was very sophisticated and expensive. And now that actually the technology has grown to fully tap the potential of telemedicine actually. And this must be a lesson actually, not directly related to medical education or health education, but it is very good for the patients for continuing. And maybe that is one of the major lessons taught by the COVID. Not complete replacement of conventional treatment, but of course, to a large extent, we can, especially in mental health and all, it may be a great boon for the patients.
So I'm Indu from community medicine. The query, it's just a comment in continuation of yesterday's discussion on translation of policy and how academic institutions I mean, a lot of research is happening in institutions under the health university. So can we have a harmonious relationship between the health system and the academic institution so that the identified research gaps, whether it be research from faculty or the postgraduate thesis now is not just restricted to MD. We have MD, MPhil, PhD, all courses of the university. So there is a set of areas where there is a research gap. Yesterday, there was discussion on rabies, COVID, another huge area, long COVID. I'm from community medicine. From the public health side, I think Kerala, this is the 25th year of decentralized planning. Lots of activities happen at the LSGD level. So can we identify certain priority areas from health system? I think yesterday we had the discussion on the emerging NCDs, leptospirosis deaths, preventive. So those core areas, relevant priority areas, I think that's one of the themes of the conference also. Can we have a set of such priority areas identified at the KUHS academic sites so that the upcoming researchers as part of the curriculum, because MD, MCH, for all courses, research is compulsory.
Of course, our faculty is the torch bearers. Yes, we can do that, definitely.
Actually, what Indu raised is a very, very important issue. Thousands of students are doing thesis on topics God alone knows, because there is no centralized decision. In fact, as a PG teacher, my PGs used to come. ഒരു 4-5 ടോപ്പിക് പറഞ്ഞു തരാമോ സാറേ? അപ്പൊ അതിൽ എന്നിട്ട് എന്തെങ്കിലും ഒരു ടോപ്പിക് ആരെങ്കിലും പറയും. And finally, so after some time, we realized that this was done 3-4 years ago by somebody, and then they will slightly change it. So all these things are happening. So we can have a list of areas where these theses can be done. We can have a priority areas, and so that you can give to students, so that it will be clearly targeted. Of course, doing a thesis is not a huge research, but we can do that. Maybe a big problem can be cut into multiple areas and given to a group of students. And finally, and the idea of doing thesis, which I understand, is it's a learning process wherein they know how to do a research, not that they are really doing research. So in that process, we can give topics. We can give, university can have the faculty, each stream can have list of topics where the students can work. And then, suppose there are definite areas you want the university to work. University is ready to do that. University can appoint fellows. In fact, we have appointed few fellows who are doing certain studies on certain areas. We are ready, and we have funds also. We can do that. We are ready to do that. But then the suggestions on which you have to do study, it is very clear, concrete. We are ready to do that. And now we have got more than 400 students join for PhD. And PhD also, they are searching for topics. They go to an entrance examination, they are qualified, and then they find out a guide, and they find out an area to work. So we can suggest areas. So all these areas we can do. And now a huge thing has come, the Chief Minister's postdoctoral fellowship, which gives every month 1 lakh rupees, a huge incentive. And that can be done by our, and initially it was for PhD holders. Now government has relaxed. Anybody who is having MD can apply for that. So all our postgraduates can apply for Chief Minister. And this year, there were not sufficient applicants. So not many people were given. Only few. From our stream, only 2 got. I think from engineering stream also 1 or 2 got. So we are not very much back. So all these possibilities are there, and universities are ready to do that.
I'm Dr. Geeta from School of Family Health Studies, Kozhikode, KUHS. From yesterday's discussions, and also what Dr. Indu was alluding to, one problem that we have is that we have so much of data which are probably actionable as well, but which remains confined to thesis, and which nobody, the world, other medical colleges itself do not know anything about. So it is just a thought whether KUHS could take a lead in amalgamating or setting up a resource of all research which has been done among the medical colleges and various other streams in Kerala, and also in helping the faculty to ensure that research findings are finding their way into policy. So these 2 things would be really wonderful if KUHS could contribute to that.
Okay.
Yes, we are going to prepare a repository of all the research works done in medical colleges for the last 10 years. It will be ready.
Thank you, sir. Let us continue with the next session. Let us hear from Mr. Jagajeevan, former Program Officer, Kudumbashree Mission.
I'm Dr. Anandalakshmi from Trivandrum Ayurveda College, Professor. I have one query regarding the, first let me congratulate the team for having such a great work during the COVID times, and the presentation was also very good, very informative. But I want to know whether that Moodle platform, which was explained, which we all did in our colleges, it was not taken well by our students, but they were all asking for Zoom and things we are using in daily basis, because they are more, having lot of students friendly way to deal with that platforms. So is it the thing which is only for Ayurveda, or do you have any data regarding what the feedback you got about Moodle from other systems also? Thank you.
This Moodle was suggested only because it is free of cost. You are free to use any other platform. And regarding this Moodle, there were so many complaints from several centers also, other than Ayurveda. But some of them opined that it is very user friendly also, because the difference is between the faculty who are friendly with these technologies. Some of them are very well versed in it, some of them are not. That's all. We could train some faculty, nearly 740 were given training. The best point regarding Moodle was it is free of cost.
Thank you, sir. Let us continue with the next session, that is care and support in the community, the LSD interface. I request Mr. Jagajeevan N, former Program Officer, Kudumbashree, and Dr. Divya to present the topic. And I also request Dr. Jagadishan, former Deputy DHS Planning, and Dr. Sairu Philip, Professor and Head, Department of Community Medicine, Government Medical College, Alappuzha, to chair the session. So record time to chair the session.
So this session, we know that Kerala is always in the forefront of community-based intervention. During COVID time, also it was like that, and during flood of 2018 also, so much of community interventions. So, so this topic, care and support in the community, the LSG interface during COVID time, Mr. Jagajeevan and Divya is making the presentation. Divya is making the presentation. Jagajeevan already introduced, he's an expert in community-based programs, whether it is public health program, whether it is other programs for the vulnerable sections, and he has a lot of experience in this Haritha Kerala mission, and has vast experience in throughout the country. He has visited many places regarding the community-based interventions. Divya, I don't know much about you. Anyway, you'll be making the presentations, and we'll have the discussion. Okay.
Good afternoon, everyone. So under the leadership of Jagajeevan sir, we were conducting a study on the role of LSGIs, local self-government institutions, in the pandemic management in Kerala. So this is one of the excerpts from that, how the care and support in community was implemented by LSGIs. What was the role of LSGIs in it? Coming to any crisis, like a crisis can be a pandemic, it can be a disaster, a natural disaster, or anything. So what is expected of a local self-government institution? So there must be a confidence building. And when you say confidence building to the community should be expecting that there should be assurance that they can overcome this crisis, and sometimes that their security needs and essential needs will be covered by the system, and there will be a system that they can approach when there is an emergency need. So how do the LSDIs provide this? And then the second stage is the rescue rehabilitation, of course, and in case of pandemics there will be prevention, and then the LSDIs are expected to address the social security needs and the care services for the community. And after that, how much ever this crisis has impacted their livelihoods, the panchayat is expected to support their livelihood in such crisis. So what do LSDIs needs to address such a situation? There should be information, and then there should be a system, of course, the infrastructural and the human resource elements, and then there should be resources in every domain, and there should be knowledge and skill in persons as well, otherwise also in the system there should be knowledge and skill around. And with all this, how do they do it? There should be community mobilization in the front. That is, there is an extensive community network, including Kudumbashree and all the CSOs, as we know. And then we should be coordinating the stakeholders. There are different stakeholders, and there is an information regarding how to act, what is the problem, and how to approach this. There should be this information dissemination, and there is information gathering about how the impact is going on in the community. So gathering the information and mobilizing the resources on the basis of that. So this is somewhat what is expected from an LSDI in case of a crisis. So coming to COVID, how do these principles were made into practice? We would see that. So in care and support of the community, the major domains we would like to look at is targeting response to the vulnerabilities, detailing and delivering services like the basic needs of the people, the medical needs, how the testing, tracking, tracing were done, and how the risk was communicated. And there were psychological breakdowns, and how did they support it with psychosocial support. And then coordination with different agencies and caregivers. Also integrating with already existing primary healthcare system. How did the LSDI interface was made between the primary healthcare system? And then there was a frontline healthcare workers, and at the local level, how did the panchayats or the LSDIs were able to protect them, how they supported them. And now there were special services in the community, like if you look at the vulnerable community, the most vulnerable of them were the bedridden people, and those were availing the palliative care services who were vulnerable. So there were special services targeting them. And then there are, of course, some success stories, and there were challenges as well. So we'll examine each one of them. The first one is targeting response to the vulnerable groups. So in the beginning itself, the LSGD, that is the local self-government department, published a guideline, and the guideline was explicitly saying that this is a list of vulnerable people we should be putting more attention into, and that included this list: elderly, palliative care patients, disabled persons, the SC/ST, the marginalized sections, the coastal area inhabitants, slum dwellers, those were inhabitants in the care homes, and then those were involved in the employment guarantee schemes at the rural and urban area. Also, the guest laborers. So targeting response to vulnerable groups, as we all know, Kerala has highest prevalence of NCD, as well as we have a greater proportion of elderly population. So it's definitely important to look at them, how to protect them in order to prevent this spread and reduce the fatality. So reverse quarantine was implemented in that sense. And when reverse quarantine was implemented, there were sometimes the other family members would have been affected with COVID, and these older persons or vulnerable persons, dependence on them will be isolated at home. It was the LSDI and the community participants like Kudumbashree volunteers, the frontline workers, who actually supported them. They monitored them constantly. They were looking at if they need anything else necessary in terms of food, essential medicines, and all the everything that they got restricted. That was provided by the LSGI at different domains. And now provided psychosocial support for isolated persons. As we all know, there were online services, the e-Sanjeevani was there, then psychosocial support care was there. And it was in the local level. The LSGIs and the community volunteers could go personally to them and attend them and support them at home itself with mandatory precautional measures, of course. And then this vulnerable groups, as we all know, were prioritized in the first round of the vaccination drive itself. And they were largely supported to avail the service by the LSGI members. Now, how LSGI was involved in this addressing this basic needs or testing, tracking, risk communication. As we know, it's already mentioned that how the health service is involved in that and how the directories was placed. But what is the role of LSGIs in this? When break the chain campaign, I would say these are the major components: break the chain campaign, then the contact tracing, quarantine and isolation, management of CFLTC and other health service delivery systems supporting the vaccination drive. We would look at each of them. These are few pictures. If you look at that, in the break the chain campaign, one of the major responsibility of the LSGIs were to spread awareness, to make the people support or mobilize them to do these SMS, we would say the physical distancing, mask and sanitizing. So this one is the LSGIs had installed hand washing kiosks and sanitation, sanitary, you know, yeah, so that was installed in all public places and departments, and it was mandated that the officials should be making physical distancing both as it was done in front of the shops, because those time there was a mandate that only at a particular time shops will be open, and there were mandates on that so they had marked the physical distancing separations. Now, one of the major features, or we would say in the LSGIs, it was that for every intervention happening, LSGIs were able to put more effort into that or resources into that and make need-based innovative innovations based on whatever is guided. So if we look at this one, when the Break the Chain campaign was introduced, the Tannimukam Grama Panchayat looked at it. Even if you say break the chain campaign, how do we mandatorily maintain that distance? So they actually provided one umbrella to everybody so that there will be a certain distance between the other person when you hold an umbrella. So this particular innovation was inaugurated by Minister Sri A.C. Moideen and then Finance Minister Sri T.M. Thomas Isaac. Now coming to the contact tracing, so Kerala was conducting extensive testing, and while the spread increased, it was difficult to find as much testing devices, and then they had to limit it to the priority groups. Once that was done, the most important thing to do was contact tracing. You have to find the contacts and quarantine them so that you could reduce the spread more. So the best thing LSGI is involved in the beginning itself, towards the beginning of the testing, there were no transportation services in terms of railway, and everything was closed. So most of the quarantine or isolation was done based on the contact tracing strategies done at the airports. And the LSGI members were totally involved in that. And LSGA is actually organized that with a proper system at the local level. They had a ward committee. Every cluster, every 50 houses were made into a cluster, and a cluster team was assigned to them. And then there were neighborhood groups. So this was a connected network, and they knew everybody in the neighborhood, and they could easily contact them, and they could convey the information to the medical officer and the existing system. So coming to the quarantine and isolation, as we know, there were different facilities, and of course, institutional quarantine and home quarantine. In institutional quarantine, one of the major responsibilities of the LSGIs were to identify the facility, the vacant facilities, or which infrastructure can be converted for the needs of this quarantine facilities. So there was already an effort done during the disaster management plans in the past, like for the Nipah and flood. So there was an inventory on which all facilities were available. So the LSGIs could actually make use of that for finding institution, and then they were supposed to provide the infrastructural services. And in terms of infrastructural services, it included everything from the electricity, food, water, the transportational facilities. If they want to shift the swabs or the samples to another facility, the transportational facilities, everything was provided by the LSGI members and the group. So for the home quarantine was like those who couldn't avail institutional quarantine when the number of spread was increasing. Home quarantine was advised, and for LSGIs, they could actually support them with the community participation, with, as we said earlier, with the facilitation of provision of necessary goods at doorstep delivery and psychosocial support. Now the management of CFLTC and other health service delivery systems. So how did the LSGIs manage the CFLTCs? In fact, at the local level, each CFLTCs had to make a managing committee in which the electoral members and the local level participants were part of the committee. And a collective decision was made from the directions from the health services. So here also, identifying the suitable venue was the first responsibility of the LSGIs, then ensure the infrastructural facilities, and then administrative support, as we already said, the ambulance services, the oxygen supplementation strategy, and the provision of food, because there were already community kitchens and Janagya hotels, those who were not able to collect that. The LSGI had a system to provide them at the facility. And of course, the waste management, then the non-medical waste management was managed by the Kudumbashree volunteers, worked with the LSGIs. Now coming to the support, the vaccination drive. For the vaccination drive, there was an initial panic regarding the vaccine, but the LSGI members and the frontline workers could actively participate in that, converse with the community and create awareness. So later community was mobilized, and the elected representatives and members could actually involve in the process and facilitate the vaccine allocation. For those who were bedridden and vulnerable, they were actually given priority in this, and the community participation could enhance that process. The coordination of different agencies and caregivers. If you see that LSGIs led this process at the local level with the advisory from the health service. There were a group of stakeholders in this, including the local self-government department, the health service, of course, and there was a Sannadha Sena, like there was a portal to register volunteers, those could enroll in the volunteer group and function as a part of the community participation. And then Shujitha Mission, who gave the technical advice for the waste management facilities. And then Kila, as we know, Kerala Institute of Local Administration, who were providing the capacity building and awareness building for this implementation of the strategies. Those were given to all the stakeholders, like the health workers, the elected members, who all were involved in this process. And then Kudumbasri. Kudumbasri is an extensive network, a community network that was involved in this process, and they provided the community support and a major role in the distress management in the process. And if you say it won't end with this many number of stakeholders, because it's a collective effort after all. So there were volunteers, there were volunteers from different groups, like youth organizations were there, different NGOs were there, charitable organizations were there, and there were residents associations, community organizations, and even religious groups were there. So we were not looking at what kind of organization is that, because it was a collective effort and LSDIs could actively coordinate between them. Now, there was other departments. How did they coordinate between other departments? There were revenue, police, social justice department, the civil supplies department, who were providing the ration subsidies and everything. So these coordination among them was also reflected in the news media, as well as the social media platforms were also utilized. So there was a large, extensive network and coordination in actualizing this effort. We would like to present how one or two stakeholders, how did they manage them? So the first one is the most important one seems to be the local self-government department, because the department was preparing and issuing the guidelines according to the government guidelines, how the LSDIs would implement this strategy. So they also monitored and evaluated, and the data generated from the ground was managed by them. And the LSDD department, if you look at, there were more than 100 government orders they managed to issue during this 1 year itself, in the 2020 to 2021. We actually looked at a list of government orders, and we can find that the volume of the function, the volume of the effort that they had put in. And COVID war rooms were one of the most important structure that coordinated this whole effort. So this is just an illustration of the COVID war rooms at different levels. And these were actually, this illustration was made with the help of the government orders and how they were supposed to make. So how they worked, where there was a panchayat level, district level, and state level. All level there was COVID war rooms, and from the local level, the information was passed to each level, and from the state level, they could coordinate it as the minutes from each day, and it would be collected there. And one of the major importance of COVID war rooms where they could make immediate decisions on what is the emergency happening at the ground, because that was collated every day and it was updated correctly. So coming to two other stakeholders, it was Kerala Institute of Local Administration and Kudumbasri. Kila, though they couldn't conduct face-to-face workshops and trainings during the physical distancing mandates and lockdowns, but they conducted many, they utilized the online platform. They actually came up with a web portal and did the workshops and online courses, all their activities. And Kudumbasri, which is the largest network in this, they actually supported with the manufacture of masks, sanitizers, face shields, and the community kitchen, of course, was, they were a major stakeholder in them. And community empowerment with different initiatives among women and children. And then the non-medical waste management, psychosocial support. They had a number of counselors among the Kudumbasri network. So the counselors among them could actively involve in the psychosocial support. And then, like the LSDI, Kudumbasri could also make innovative effort at the particular context, according to the need of the context. Now, coming to the integrating with already existing primary healthcare system and network. As we all know, the panchayat, or the local self-government system, has a certain level of autonomy that at the local level they can provide, they can mobilize the fund and use it to strengthen the existing primary system. So when such an emergency situation arises, the LSDS actually try to mobilize this fund, and with the government directives also, they could use more than the usually allocated fund towards this, and they strengthened the existing primary healthcare facilities with additional medicinal procurements, additional human resources, transportation, accommodation facilities for health workers, and whatever infrastructure facility needs arised. And then something else LSGIS did is there were already existing structures like ward health sanitation and nutrition committees, Arogya Jagrata committees, emergency response teams, which were already constituted as part of the disaster management plan earlier. So LSGIS actually strengthened them and reconstituted them. So in fact, along with the primary healthcare system at the local level, integrating with them other organizational structure arise. Those include the frontline health workers, and it was integrated and working with the primary healthcare system. Those are, if you see, Panchayat Jagrata Samiti, then below that a 5-member core group in the Panchayat itself, then Panchayat COVID war rooms, then there was a 24/7 help desk. Then there were ward level committees which were led by the ward member, and then rapid response team for each ward, cluster teams for every 50 houses, and COVID Jagrata portal. Each organizational structure was connected with the healthcare facilities and the healthcare professionals to address any emergency situation. Now, LSGAs, of course, were working along with this frontline workers, and if we see how they were protected. And in the beginning, when the COVID was coming to a crisis situation, the recruitment of healthy participants in the frontline workers, it was a necessary need. And then they were given training and awareness regarding the situation with the help of health services and KILA. Then one of the major interventions were that they were allocated specific geographic area. So once a group is allocated for a specific geographic area, there is no chance that that a spread would initiate between different areas. So that was somehow managed, and then distributed sufficient protective gears. So the Panchayat could allocate fund for this. And then the frontline health workers were given top priority in immunization drive. In case if the frontline workers are infected, they were given immediate and efficient care facilities. When we looked at how the vulnerable people or how vulnerability was targeted, we said the most vulnerable were the group palliative and terminal care facility allocate use patients. So in the beginning itself, LGD had asked for a database from each panchayat that they should give a list of these vulnerable people, and then the LSGS conducted such a survey at each panchayat, and for those who with renal failure, those who are in need of dialysis, those who undergone organ transplantation, and cancer patients, like so the terminally ill people like that. And then based on the survey, in coordination with the health service, they actually came up with specific interventions and care guidelines for the families. So LSGS could facilitate these interventions, and they could procure and distribute essential medicine to poor patients who couldn't afford them. And then they were given psychosocial support. So home care were given for those dependents were going to quarantine facilities or isolation or in need of them. And there were provision of cooked food or raw food delivered to the home. So these are some of the examples, like household level monitoring and services are described in this one. So there were different facilities provided, and if you see the second one, there was this stigma around persons who were died of COVID, and even if the mandates, I mean, there were guidelines that COVID won't spread from dead bodies, but this family of an old lady restrained from taking part in her funeral, and then the LSGI members and the primary healthcare workers had to involve in that and conducted. Now, there were different innovative efforts, as we have said. Those arise, the needs arise from the local level. So at the Cochin Corporation, there was this effort that it is called auto ambulance. 18 auto drivers with the Corporation Auto Drivers Association came up with this idea, and the Cochin Corporation, along with a funding organization, provided this facility. And this auto ambulance, the idea is that they would provide the transportation facilities for those who are COVID positive, and they would also take part in the provision of necessary food materials and medicine procurements. So,
Excuse me, ma'am, your time is over.
In 2 minutes. So the other one is Otsikar initiative from another Grama Panchayat. This is the idea that the oxygen cylinder is installed in this particular vehicle. It will be allocated or given to those who are in need of, or those who are suffering from low oxygen saturation according to the physician's guideline. Now, with all this, there are certain challenges and problems. Like there were in the initial stage, the Kerala State Disaster Management Authority, LSGI, and District Disaster Management Authority, there was an interface that given guidelines. So since these are multiple agencies with regulatory powers, there was a weak coordination among them, which was a challenge. And then there are different departments within the LSGI itself. There was a weak information flow within the LSGI. And then though in the rural area, like how decentralized governance was implemented, in urban area, it was a challenge that the LSGIs couldn't coordinate with the health services. So even when we see this, there is this idea that we know that it is important to have a stronger decentralized governance system in the public healthcare sector, which is essential to address the evolving health challenges in future as well. So with this experience, we actually gain some of these skills and knowledge, including building community participation, experience in monitoring and evaluation, coordinating with other departments, local resource mobilization, and management of people-centric operations. So what we suggest or recommend is that from these experiences, it is important to revamp the already existing structure and organizational framework of the primary healthcare system under the leadership of local self-governments, because we have already seen a framework and how efficiently it worked. And to cover these challenges, initiatives should be taken, and such a system would enable the state in actualizing, as we envisage, a people-centric system which is led by people. Thank you.
Thank you, Divya. Actually, pandemic is a time of uncertainty. And it was said in the beginning that you have to travel faster than the virus in order to win the virus. ഇവിടെ ഇന്നത്തെ പ്രസന്റേഷന്റെ ഒരു സമ്മറൈസ് ചെയ്യണമെങ്കിൽ എനിക്കത് 5 പോയിന്റ് ആയിട്ട് സമ്മറൈസ് ചെയ്യാനാണ് തോന്നുന്നത്. I feel that the uniqueness of Kerala's local self-government is that it has got financial decentralization. Local specific problemത്തിന് financial decentralization പ്ലാനിങ്ങിനുള്ള potential. So maybe ഇതിന്റെ ഒരു സംഗ്രഹമായിട്ട് എനിക്ക് പറയാനുള്ള, during pandemics, how LSGs intervene are firefighting areas, flexibility to bring about changes, forging collaborations, focusing on efforts. And I think that is the gist of it. And I think Jagjeevan sir, എനിക്ക് തോന്നുന്നു തദ്ദേശ സ്വയംഭരണ സ്ഥാപനങ്ങളുമായിട്ട് ദീർഘകാലം 10-25 വർഷത്തിലേറെ ആരോഗ്യ വകുപ്പിന്റെ പ്രതിനിധിയായിട്ടും കുടുംബശ്രീയുടെ പ്രതിനിധി, ഹരിത കേരള പ്രതിനിധി, അതിലുപരി ഒരു പൗരൻ എന്നുള്ള നിലയിലും ഒത്തിരി കോൺട്രിബ്യൂഷൻസ് നൽകിയ ആളാണ്. ചോദിച്ചപ്പോ ഇനിയും കൂടുതലൊന്നും പറയുന്നില്ല എന്ന് പറഞ്ഞു. So I will put forth a question to him and open the floor for discussion. The question I have for him and also for the audience is, from my experience with LSC, I feel that ഒരു കോമ്പിറ്റൻസി ഒരു മെഡിക്കൽ ഗ്രാജുവേറ്റ് മാത്രമല്ല, എല്ലാ ഹെൽത്ത് പ്രൊഫഷണലും in Kerala should know how the LSD works and how their involvement can bring about changes in the local level. What is your opinion about that?
ഒന്ന്, നമ്മുടെ ലോക്കൽ ഗവൺമെന്റ് എടുക്കുകയാണെങ്കിൽ, പഞ്ചായത്തോ നഗരസഭ എടുക്കുകയാണെങ്കിൽ, ഏറ്റവും കൂടുതൽ പ്രൊഫഷണൽസ് വർക്ക് ചെയ്യുന്ന ഒരു സ്ഥാപനമാണ് LSGI ഇന്ത്യയിൽ. അത് മെഡിക്കൽ, അഗ്രികൾച്ചറൽ, വെറ്റിനറി, എഡ്യൂക്കേഷൻ, സോഷ്യൽ സെക്യൂരിറ്റി, അല്ലെങ്കിൽ സോഷ്യൽ ജസ്റ്റിസ്, വിമൺ, ഇതിലെല്ലാം വർക്ക് ചെയ്യുന്നത് ഹൈലി പ്രൊഫഷണൽസ് ആണ്. പക്ഷെ ആ പ്രൊഫഷണൽ സ്കില്ലിനെ നമുക്ക് ലോക്കൽ ലെവൽ ഡെവലപ്മെന്റ് നീഡ്സിലേക്ക് കൊണ്ടുവരാൻ ഇപ്പോഴും സാധിച്ചിട്ടില്ല എന്നുള്ളത് ഒരു പ്രധാനപ്പെട്ട ഗ്യാപ്പായിട്ട് നിൽക്കുന്നു. അതാണ് ഒന്നാമത്. രണ്ടാമത്തത്, നമ്മൾ ഇന്നിപ്പോ ഒരു ലോക്കൽ ഗവൺമെന്റ് എടുക്കുകയാണെങ്കിൽ, ഒരു വില്ലേജ് പഞ്ചായത്തിൽ ഏറ്റവും കുറഞ്ഞത് ഒരു 600 മുതൽ ഏറ്റവും കൂടുതൽ ഒരു 1500 വരെ ഒരു വില്ലേജ് പഞ്ചായത്തിനകത്ത് ഓർഗനൈസേഷൻസ് ഉണ്ടാവും, കമ്മ്യൂണിറ്റി കളക്റ്റീവ്സ് ഉണ്ടാവും. എന്ന് പറഞ്ഞാൽ ഒരു പഞ്ചായത്തിനകത്ത് എല്ലാ വിഭാഗം ജനങ്ങളും ഏതെങ്കിലും ഒരു തരം കളക്റ്റീവിനകത്ത് അംഗമാണ്. ഒന്നുകിൽ റെസിഡൻസ് അസോസിയേഷൻ, അല്ലെങ്കിൽ പള്ളിയുടെ കമ്മിറ്റി, അല്ലെങ്കിൽ അമ്പലത്തിന്റെ കമ്മിറ്റി, അല്ലെങ്കിൽ പെൻഷനേഴ്സ് യൂണിയൻ, അല്ലെങ്കിൽ അഗ്രികൾച്ചർ, ഏതെങ്കിലും തരം ഒരു കളക്റ്റീവിൽ വന്നിട്ട്. കോർപ്പറേഷൻ, ഞാൻ ട്രിവാൻഡ്രം കോർപ്പറേഷനെ കണക്കെടുക്കുമ്പോൾ ഏകദേശം 9500ഓളം ഓർഗനൈസേഷൻ അങ്ങനെയുണ്ട് ലിസ്റ്റ് ചെയ്യപ്പെട്ടത്. അപ്പോൾ ഈ കളക്റ്റീവിനെയും, ഞാൻ നേരത്തെ പറഞ്ഞ പ്രൊഫഷണൽസിനെയും, അതോടൊപ്പം തന്നെ നമ്മുടെ ലോക്കൽ ഗവൺമെന്റ് ഇലക്ടഡ് റെപ്രസെന്റേറ്റീവിനെ എങ്ങനെ ഇഫക്റ്റീവായിട്ട് കൺവേർജ് ചെയ്തുകൊണ്ട് ഒരു ഹെൽത്തിന്റെ ആംഗിളിൽ ഇന്റർവെൻ ചെയ്യാം. ഇത് നോക്കുമ്പോൾ ഞാൻ കാണുന്ന യഥാർത്ഥ ഗ്യാപ്പ് എന്ന് പറയുന്നത്, എന്നോട് ക്ഷമിക്കുക, പൂർണ്ണമായും ക്ഷമിക്കണം, എന്നെ തല്ലരുത്, നമ്മുടെ പഞ്ചായത്ത് ലെവലിൽ വർക്ക് ചെയ്യുന്ന ഡോക്ടേഴ്സിന് അല്ലെങ്കിൽ മെഡിക്കൽ ഓഫീസർക്ക് ഈ ഇൻസ്റ്റിറ്റ്യൂഷൻസിനെയും ഈ പ്രൊഫഷണൽ കേപ്പബിലിറ്റിയും ഇഫക്റ്റീവായിട്ട് ഇന്റഗ്രേറ്റ് ചെയ്ത് ഒരു പബ്ലിക് ഹെൽത്ത് ആംഗിളിലേക്ക് ഗൈഡ് ചെയ്യാൻ പറ്റുന്ന കേപ്പബിലിറ്റി ഇല്ല. അതാണ് ഒരു പ്രധാനപ്പെട്ട ഗ്യാപ്പായിട്ട് ഞാൻ കാണുന്നത്. ആ കേപ്പബിലിറ്റി ഗ്യാപ്പ് അഡ്രസ് ചെയ്യണമെങ്കിൽ അതനുസരിച്ച് മെഡിക്കൽ എഡ്യൂക്കേഷനിൽ ട്രാൻസ്ഫർമേഷൻ വരണം എന്നാണ് ഞാൻ വിശ്വസിക്കുന്നത്. ഞാനിത് പറയുന്നത് ഡീസെൻട്രലൈസേഷന് ശേഷം, അല്ലെങ്കിൽ കേരളത്തിലെ പഞ്ചായത്ത് രാജ് നിയമം നടപ്പിലായി പഞ്ചായത്തുകൾക്ക് കൂടുതൽ കഴിവ് വന്നതിന് ശേഷം, അല്ലെങ്കിൽ ആ സമയത്ത് സർവീസിൽ കയറിയവരാണ് ഇന്ന് നമ്മുടെ ഹെൽത്ത് സർവീസിന്റെ ഏറ്റവും ടോപ്പ് ലെവലിൽ ഇരിക്കുന്നത്. അങ്ങനെയാണെങ്കിൽ യഥാർത്ഥത്തിൽ സംഭവിക്കേണ്ടത് ഇന്ന് കുറച്ചുകൂടി ഇഫക്റ്റീവായിട്ട് ഇന്റർവെൻ ചെയ്യാൻ പറ്റണം. പക്ഷെ എന്തുകൊണ്ട് പറ്റുന്നില്ല? അതിനൊരു ഗ്യാപ്പുണ്ട്. ഞാൻ ഗ്യാപ്പ് ഉണ്ടാവുമെന്ന് പറയാൻ കാരണം, ഓരോ പഞ്ചായത്തും അവിടുത്തെ ഡെമോഗ്രഫിക്ക് അനുസരിച്ചും, അവിടുത്തെ ജീവിത രീതിക്ക് അനുസരിച്ചും, അവിടുത്തെ എൻവയൺമെന്റ് അനുസരിച്ചും ഉള്ള ഹെൽത്ത് ഇന്റർവെൻഷൻസ് വ്യത്യസ്ത രീതിയായിരിക്കും. ഇടപെടൽ രീതി വ്യത്യസ്തമായിരിക്കും. ആ ഇടപെടലിനുള്ള പ്ലാൻ ഓരോ പഞ്ചായത്തും ഉണ്ടാക്കും. ഒരു ബ്ലോക്കിൽ തന്നെ ചിലപ്പോൾ 8 പഞ്ചായത്ത് ഉണ്ടെങ്കിൽ 8 തരത്തിലുള്ള ഇന്റർവെൻഷൻ പ്ലാൻ ആയിരിക്കും. ആ 8 തരം ഇന്റർവെൻഷൻ പ്ലാനിനെ ടെക്നിക്കലി ഗൈഡ് ചെയ്യാനുള്ള കേപ്പബിലിറ്റി ബ്ലോക്ക് തല PHC ഓഫീസർക്ക്, മെഡിക്കൽ ഓഫീസർക്ക് ഉണ്ടാകും. ഒരു ജില്ലയിൽ 12 ബ്ലോക്ക് ഉണ്ടെങ്കിൽ 12 ബ്ലോക്കിൽ നിന്ന് വരുന്ന ഹെൽത്ത് റിലേറ്റഡ് ഇഷ്യൂസിനെ ടെക്നിക്കലി മാനേജ് ചെയ്യാനുള്ള കേപ്പബിലിറ്റി ഡിസ്ട്രിക്ട് മെഡിക്കൽ ടീമിനുണ്ടാകണം. അതേസമയം ഒരു സെൻട്രലൈസ് ചെയ്ത് ടാർഗറ്റഡ് ആയിട്ടുള്ള ഹെൽത്ത് സ്കീം നടപ്പിലാക്കുമ്പോൾ അതിന്റെ മോണിറ്ററിങ് ആൻഡ് ഇവാലുവേഷൻ വളരെ ഈസിയാണ്. അപ്പോൾ ഒരു ഡീസെൻട്രലൈസ്ഡ് ഗവേണൻസിനകത്ത് വളരെ വ്യത്യസ്തമായി ഉണ്ടായി വരുന്ന പ്രോഗ്രാമിനെ ടെക്നിക്കലി ഗൈഡ് ചെയ്യണമെങ്കിൽ അതിന്റെ ഓരോ ലെവലിലും ഉണ്ടായിരിക്കുന്ന പ്രൊഫഷണൽസിന് ഉണ്ടാകേണ്ട കേപ്പബിലിറ്റി, പ്രൊഫഷണൽ സ്കില്ലും കൂടുതൽ ശക്തമായിരിക്കണം, കൂടുതൽ മെച്ചപ്പെടാൻ. അതിന് പറ്റുന്നൊരു സംവിധാനം ഇന്നില്ല എന്നുള്ളതാണ്. ഒന്നുകിൽ ഇല്ല, അല്ലെങ്കിൽ അത് ഫംഗ്ഷൻ ചെയ്യുന്നില്ല, അല്ലെങ്കിൽ ആ ഫംഗ്ഷൻ ചെയ്യിപ്പിക്കാനുള്ള ആൾക്കാർക്കാനുള്ള കേപ്പബിലിറ്റി ഇല്ല. ഇത് അഡ്രസ് ചെയ്യുക എന്നുള്ളതാണ് ഏറ്റവും.
ജഗ്ജീവൻ പറഞ്ഞ ഈ കാര്യം ഇറ്റ്സ് സ്ലോലി ഡെവലപ്പിംഗ് എന്നാണ് എനിക്ക് തോന്നുന്നത്. നൗ സെഷൻ ഈസ് ഓപ്പൺ ഫോർ ഡിസ്കഷൻ.
ഇത് പറയുന്നതിൽ അഗൈൻ ഞാൻ ഫുള്ളായിട്ട് ഉൾക്കൊള്ളുകയാണ്. അതായത് ഈ പറഞ്ഞത് ഒരു പരമാർത്ഥമാണ്. ഇത് ഇപ്പോ വേണ്ട രീതിയിൽ, വേണ്ട പോലെ, വേണ്ടത്ര നടക്കുന്നില്ല എന്നുള്ളത് ഉറപ്പാണ്. പക്ഷെ ഡോക്ടർ ജഗദീശൻ പറഞ്ഞ മാതിരി ഇതിലേക്കുള്ള ഒരു പ്രയാണം എവിടേക്കോ ഒറ്റയ്ക്ക് നടക്കുന്നുണ്ട്. അപ്പൊ ഇത് കഴിഞ്ഞ ഒരു മാസമായിട്ട് വൈസ് ചാൻസലറുടെയും പ്രോ വൈസ് ചാൻസലറുടെയും എല്ലാം ശ്രദ്ധയിലും പരിഗണനയിലുമാണ്. ഒറ്റയ്ക്ക് നടക്കുന്നതെന്ന് പറയുമ്പോൾ ഡോക്ടർ പഴയ ഡെപ്യൂട്ടി DHS അറിയാം, പതിറ്റാണ്ടുകളായി സഹകരിച്ചു പോകുന്ന ബ്ലോക്ക് പഞ്ചായത്തുകളും മെഡിക്കൽ കോളേജ് ഡിപ്പാർട്ട്മെന്റുകളും ഉണ്ട്. ഹെൽത്ത് സർവീസിലുണ്ട്, മെന്റൽ ഹെൽത്തിലുണ്ട്. പക്ഷെ നമ്മൾ ഈ നേരത്തെ പറഞ്ഞ കാര്യം ഉൾക്കൊണ്ട് ഒരു പരിപാടി ആസൂത്രണം ചെയ്തുകൊണ്ട് വരികയാണ് അക്കാഡമിക് ഡീനും എല്ലാ ഉയർന്ന ഓഫീസേഴ്സും. അതായത് നമ്മുടെ MBBS പഠന രീതിയിൽ ഇന്നലെ അതിനെപ്പറ്റി ചർച്ചയുണ്ടായിരുന്നു. ഒരു ഇന്റർഫേസ്, ഒരു ജനപ്രതിനിധിയായിട്ടോ അല്ലെങ്കിൽ ഒരു അഡ്മിനിസ്ട്രേറ്റർ, ഡിസ്ട്രിക്ട് കളക്ടർ, ആ ഒരു ഗ്രൂപ്പ് അവരുമായിട്ട് എങ്ങനെ സംസാരിക്കണം എന്ന ഒരു ഫോർമൽ ട്രെയിനിങ് ആവശ്യമാണ്. രണ്ടാമത്തെ കാര്യം, ഞങ്ങള് മെഡിക്കൽ കോളേജിലോ അല്ലെങ്കിൽ ഹെൽത്ത് സർവീസിലോ ഇരുന്ന് തീരുമാനിക്കരുത്. ഇപ്പോ നമുക്ക് ലഭ്യമല്ലാത്ത ഒരുപാട് ഇൻഫർമേഷൻ ഉണ്ട്. അത് ഏത് ഇൻഫർമേഷൻ പ്രയോറിറ്റൈസ് ചെയ്ത് അന്വേഷിച്ച് ഉടനെ കണ്ടുപിടിച്ച് നടപ്പിലാക്കേണ്ടതുണ്ട് എന്നത് ജനപ്രതിനിധികളോട് ചോദിക്കണം, ഈ രംഗത്ത് വർക്ക് ചെയ്യുന്നവരോട് ചോദിക്കണം, പിന്നെ സർവോപരി ഇതിന്റെ ആവശ്യക്കാരോട് ചോദിക്കണം. അപ്പൊ ഇത്തരം കാര്യങ്ങളുമായിട്ട് ഇപ്പോൾ സ്കൂൾ ഓഫ് ഫാമിലി ഹെൽത്തുമായിട്ടും സ്കൂൾ ഓഫ് പബ്ലിക് ഹെൽത്തുമായിട്ടും ചർച്ച ചെയ്തുകൊണ്ട് ഉടനടി പ്രഖ്യാപനങ്ങളിൽ വിശ്വസിക്കാത്തതുകൊണ്ട് അതിനെപ്പറ്റി കൂടുതൽ പറയുന്നില്ല. ഒരു പ്രോസസ്സ് ഇനീഷ്യേറ്റ് ചെയ്യപ്പെട്ടിട്ടുണ്ട്. അതിൽ ഞാൻ ഡീപ്ലി ഇൻവോൾവ് ആണ്. കുറെ വർഷമായിട്ട് ഇപ്പൊ സേരുവിനും ഡോക്ടർ ജഗദീശിനൊക്കെ അറിയാം. നമ്മൾ ഇതിൽ ഒറ്റയ്ക്കും തെറ്റയ്ക്കും ചെറിയ കാര്യങ്ങളൊക്കെ ചെയ്തിട്ടുണ്ട്. പക്ഷെ അതൊന്നും വിളിച്ചു പറയാൻ മാത്രമുള്ള കാര്യങ്ങളല്ല. പക്ഷെ സംസ്ഥാന തലത്തിൽ യൂണിവേഴ്സിറ്റിയുടെയും ഹെൽത്ത് സർവീസിനെയും DMEയും കൂടെ നിർത്തി LSGA ആയിട്ടും മറ്റ് കളക്റ്റീവ്സ് ആയിട്ടും ജനപ്രതിനിധികളുമായിട്ടും ഒരു ഡയലോഗ് പ്രതീക്ഷിക്കാവുന്ന ഒരു സമയമായിട്ടുണ്ട്.
Thank you, sir. Before the lunch, we have to just.
ഈ സന്ദർഭത്തില് ഒരു രസകരമായ ഒരു അനുഭവം ഞാൻ പറയാം. ഈ LSGയുടെ കീഴില് പ്രൈമറി ഹെൽത്ത് സെന്ററുകളൊക്കെ വരുന്നതിനൊക്കെ മുമ്പ് ഞാൻ എൻ്റെ പോസ്റ്റ് ഗ്രാജുവേഷൻ കഴിഞ്ഞിട്ട് എന്നെ ആദ്യമായിട്ട് ഗവൺമെന്റ് പോസ്റ്റ് ചെയ്തത് മൂന്നാർ പഞ്ചായത്ത് ഡിസ്പെൻസറിയിലാണ്. മൂന്നാർ MD റേഡിയോളജി കഴിഞ്ഞിട്ട്. അപ്പോൾ വളരെ സന്തോഷകരമായ പോസ്റ്റിംഗ്. ഞാൻ അന്ന് എല്ലാ തിങ്കളാഴ്ചയും പഞ്ചായത്ത് ഓഫീസിൽ പോകും. എന്നിട്ട് അവിടുത്തെ പഞ്ചായത്ത് പ്രസിഡന്റും സെക്രട്ടറിയും അടക്കമുള്ള ആളുകൾ ഇരുന്നിട്ട് ഈ ആഴ്ച ഏതൊക്കെ സ്ഥലങ്ങളിൽ ക്യാമ്പുകൾ നടത്തണം, ഏതൊക്കെ സ്ഥലങ്ങളിൽ പ്രശ്നമുണ്ട് എന്നുള്ള ആലോചിച്ചതിന് ശേഷം അങ്ങനെ ചാർട്ട് ഔട്ട് ചെയ്യുമായിരുന്നു. അവിടെ ക്ലിനിക്ക് കുറച്ചു നേരം ജോലി ചെയ്തതിന് ശേഷം ബാക്കി, അപ്പൊ അതിനകത്തൊരു വെസ്റ്റഡ് ഇൻട്രസ്റ്റ് ഉണ്ടെന്ന് വേണേൽ പറയാം. മൂന്നാറിന്റെ എല്ലാ ഭാഗങ്ങളിലും എത്താനുള്ളൊരു ആ പ്രായത്തിലുള്ള ഒരു വെസ്റ്റഡ് ഇൻട്രസ്റ്റ്. പക്ഷേ ലുക്കിംഗ് ബാക്ക് അതൊരു നല്ലൊരു കാര്യമായിരുന്നു എന്ന് എനിക്ക് തോന്നുന്നു, നല്ലൊരു ഇന്റർവെൻഷൻ. വാസ്തവത്തിൽ നമ്മുടെ ഈ ഡോക്ടർമാർക്ക് പഞ്ചായത്തിലും പ്രൈമറി ഹെൽത്ത് സെന്ററിലും മറ്റുമൊക്കെ ജോലി ചെയ്യുന്ന ആളുകൾ അവർ ഇൻഡിപെൻഡന്റ് ആൻഡ് ഓട്ടോണമസ് ആണ് എന്നൊരു വിചാരത്തിലാണ്. ആൻഡ് ലോക്കൽ സെൽഫ് ഗവൺമെന്റിനെ സംബന്ധിച്ചിടത്തോളം ഇവരുടെ പുറത്ത് നിയന്ത്രണം ഉണ്ടെന്നുള്ള ഒരു തോന്നൽ, അല്ലെങ്കിൽ ഈ ഡോക്ടർ എന്താ പറയുക എന്നുള്ളതിനെ കുറിച്ച് ഡോക്ടറോട് അപ്രോച്ച് ചെയ്യാൻ പറ്റാത്ത രീതിയിൽ. അപ്പം ഈ ഡോക്ടറെ നിയന്ത്രിക്കാൻ ചെന്ന് കഴിഞ്ഞാൽ ചിലപ്പം കിട്ടില്ലെന്ന് വരും. അതേസമയം ഡോക്ടറുമായിട്ട് ഒരു സമന്വയത്തിൽ പോവുകയും, പ്രൈമറി ഹെൽത്ത് സെന്റർ ഉണ്ട്, വെറ്റിനറി ഉണ്ട്, അതുപോലെ തന്നെ അഗ്രികൾച്ചർ ഉണ്ട്. ഇപ്പൊ കഴിഞ്ഞ ദിവസം ഒരു മീറ്റിംഗ് പറയായിരുന്നു, വാസ്തവത്തിൽ ഈ സൂണോസിസ് പ്രശ്നങ്ങളൊക്കെ ലോക്കൽ സെൽഫ് ഗവൺമെന്റ് ആണ് ചെയ്യാൻ പറ്റുന്നത്. കാരണം അവരുടെ കീഴിലാണ് മുഴുവൻ ശക്തിയും ഉള്ളത്. പ്രൈമറി ഹെൽത്ത് സെന്ററും വെറ്റിനറിയും ഒക്കെ അവരുടെ കീഴിലാണ്. അപ്പൊ അതിന്റെ ലീഡർഷിപ്പ്, അല്ലാതെ വെറ്റിനറിയും മാത്രം വിചാരിച്ചാൽ, പ്രൈമറി ഹെൽത്ത് സെന്ററിൽ ഡോക്ടർ മാത്രം വിചാരിച്ചാൽ ചെയ്യാൻ പറ്റില്ല. ഇവര് രണ്ടുപേരും തമ്മിൽ ഒരിക്കലും കമ്മ്യൂണിക്കേറ്റും ചെയ്യില്ല. They will not communicate. They are not communicating. They will communicate to their director. അതേസമയം ലോവർ ലെവൽ കമ്മ്യൂണിക്കേഷനുള്ള ഒരേ ഒരു ഏജൻസി LSG ആണ്. LSG അതിന്റെ ഓണർഷിപ്പ് എടുക്കുകയും അവരെ ഫെസിലിറ്റേറ്റ് ചെയ്യുകയും ചെയ്തിട്ടുണ്ടെങ്കിൽ ഇത് ചെയ്യാൻ വളരെ എളുപ്പമാണ്. ഞാൻ ആകെ 3 മാസമേ മൂന്നാറിൽ ഉണ്ടായിരുന്നുള്ളൂ. ബട്ട് ഇറ്റ് വാസ് എ ഗ്രേറ്റ് എക്സ്പീരിയൻസ്. ഞാൻ ജസ്റ്റ് പറയാം.
Thank you, sir. Thank you, Mohanan sir and Shaji sir. ഒരു ഹംബിൾ സബ്മിഷൻ ആസ് കമ്മ്യൂണിറ്റി മെഡിസിൻ HOD, നമുക്ക് വളരെ സാധ്യതകൾ നമ്മുടെ കരിക്കുലത്തിൽ ഇപ്പോൾ ഉണ്ട്. എല്ലാ കമ്മ്യൂണിറ്റി മെഡിസിൻ ഡിപ്പാർട്ട്മെന്റിനും ഒരു റൂറൽ ഹെൽത്ത് ട്രെയിനിങ് സെന്ററും ഒരു അർബൻ ഹെൽത്ത് ട്രെയിനിങ് സെന്ററും മാൻഡേറ്ററി ആയിട്ടുണ്ട്. ആൻഡ് ദേ ആർ ബീയിങ് അണ്ടർ എ ലോക്കൽ സെൽഫ് ഗവൺമെന്റ് where we work together in a platform. അതോടൊപ്പം ഫാമിലി അഡോപ്ഷൻ പ്രോഗ്രാം which asks to adopt 5 families per student and follow them up for 5 years. ഈ വർഷം വന്നേ. ഇത് രണ്ടും ഈ മേഖലയിൽ വളരെയധികം സാധ്യതകളാണ് തരുന്നത്. അപ്പൊ സാറിനോട് എനിക്ക് റിക്വസ്റ്റ് ചെയ്യാനുള്ളത്, ഈ urban health training centers, rural health training centers അവഗണിക്കപ്പെട്ട നിലയിലാണ് ഇപ്പൊ കിടക്കുന്നത്. Nobody gives a priority to it from principal level or from the DHS ആ ലെവലിലും ഒരു in between. I request the KUHS to take stock of the situation and provide a very facilitatory platform for training all our medical students so that the family adoption program and their hands-on experience with the LSG is possible.
Thank you, Sairu. We have to stop.
ഇതില് ഞാൻ ഒരു ഒറ്റ പോയിന്റ് പറഞ്ഞിട്ട് നിർത്താം സാർ. പിന്നെ ഈ പറഞ്ഞ പോയിന്റ് ഇപ്പൊ മോൻ സാർ പറഞ്ഞതും ഷൈ സാർ പറഞ്ഞു, സൈരു മേഡം പറഞ്ഞതില് അധികം വൈകാതെ തന്നെ തൃശ്ശൂർ വെച്ചിട്ട് ഒന്നല്ലേ കുഹാസിൽ വെച്ച് അല്ലെങ്കിൽ കില്ലയിൽ വെച്ചിട്ട് ഒരു മീറ്റിംഗ് കൂടിയിട്ട് നമുക്ക് വി ക്യാൻ മെറ്റീരിയലൈസ് ഇറ്റ് സിൻസ് ഡോക്ടർ ജോയ്സ് ഹിയർ. ബിഫോർ കൺക്ലൂഡിംഗ്, താങ്ക് യു ഫോർ മേക്കിംഗ് വെരി കോംപ്രിഹെൻസീവ് പ്രസന്റേഷൻ ദിവ്യ ആൻഡ് ജഗജീവൻ. അതിൽ ഒരു ചാലഞ്ച് പറഞ്ഞ ആ ഒരു ഏരിയ അർബൻ ഹെൽത്തിന്റെ അതൊരു റിയൽ ചാലഞ്ച് ആണ്. I was from the health side, I was the team leader for the critical containment zone 2, പൂന്തുറ അടങ്ങുന്ന. അപ്പൊ അതിന്റെ ഒരു ഡിഫിക്കൽറ്റീസ് പൂന്തുറയിൽ ഏറ്റവും പ്രോബ്ലം ഒക്കെ വന്ന സമയത്തുള്ള അർബണില് വി വർ മാനേജിങ് വിത്ത് ദി 13 അർബൻ UPSCs. അപ്പൊ അർബണില് ബേസിക് ഒരു സ്ട്രക്ചർ ഉള്ളിടത്താണ് LSG ആയാലും ഹെൽത്ത് സർവീസിനായാലും കോർഡിനേറ്റ് ചെയ്യാൻ കഴിയുള്ളൂ. അർബണില് വി വർ നോട്ട് ഹാവിംഗ് ഓർ സ്റ്റിൽ വി ആർ നോട്ട് ഹാവിംഗ് എ പ്രോപ്പർ സ്ട്രക്ചർ. NUHM-ന്റെ PSC അർബൻ PSC എന്ന് പറഞ്ഞാൽ അതിന് ഒരുപാട് ഡിഫിക്കൽറ്റീസ് ഉണ്ട്. We should develop these urban primary healthcare system with the 15th Finance Commission grant. അത് കമ്മിങ് 4 years നമുക്ക് കിട്ടാൻ പോകുന്ന വലിയൊരു ഗ്രാന്റ് ആണ്. ലാർജ് എമൗണ്ട് മണി ഉണ്ട് അതിനകത്ത്. നമുക്ക് we should develop a appropriate system through a consultative process with health LSGയും NHM ചേർന്നിട്ട് ഡെവലപ്പ് ചെയ്യണം. Then we can പിന്നെ cut short that shortcoming. അതിന്റെ ഒരു പ്രോബ്ലം നമുക്ക് ഓവർകം ചെയ്യാൻ പറ്റും. So കഴിഞ്ഞില്ലേ സർ?
Thank you very much. Thank you.
Thank you. With this workshop, School of Public Health has organized an online pre-paper presentation. It's the time for distributing the prize. I request Honorable VC to distribute the prize. The first prize for the online paper presentation goes to Dr. Adira Rani Amma. I request Dr. Adira to receive the certificate from Honorable VC. The second prize is shared by 2 persons, Dr. Ashwati Rahul and Dr. Hari Prasad. Thank you, sir. So before the lunch, we have to finish one more session. The session is on the success story of vaccination and vaccine delivery platform in Kerala. The session will be presented by Dr. Indu PS, Professor and Head Department of Community Medicine, Government Medical College, Kollam, and Dr. Sandeep, Deputy Director, Program Officer for Child Health, DHS Kerala. And I request Dr. Anuja Yu, Professor and Head Department of Community Medicine, Government Medical College, Thiruvananthapuram, and Dr. Biju George, Associate Professor, Department of Community Medicine, GMC Kozhikode, to chair the session.
Good morning, all. COVID vaccination is actually a breakthrough activity which actually contained or reduced the morbidity and mortality due to COVID-19. So we will hear from Dr. Indu about how we successful enough to implement this program in our state.
Thank you, Anuja. It's actually a great discussion that is going on, especially in the, as the sessions go by, we see so much of futuristic actions coming up jointly from the university, the health service and all. Where do we stand in COVID? what we see in this is just, since we are discussing the numbers and the deaths, this is how the deaths were. The line shows the number of deaths since the beginning of the pandemic. And we are here the last week of September. This is as on 3 days ago. This was published, I think, on 22nd September by the WHO. This is from the weekly epidemiology report. And in here we can see in that lilac color, the Southeast Asia region, the highest peak of deaths, which was driven by the Delta wave in India. So though we see this, the Southeast Asia region in prominence, this is where our peak, the maximum deaths from India and Kerala, and that is where we are. And actually, that was the time when the vaccination has just begun. But before the full potential of vaccination could be achieved, came the largest ever Delta wave with the highest mortality, which is so. And I was talking to Sandeep right now. This is actually, the presentation is beyond anecdotes, but he was just telling. Yesterday, Sangeeta was talking about the deaths antenatal. So antenatals do have, I think today morning also there was a brief discussion on that during Rajmohan's presentation. Out of the 97 deaths or so that has happened in Kerala among the antenatals because of COVID, 92 were unvaccinated and 5 were partially vaccinated. Sandeep is here. So that's what vaccine does to the mortality pattern. If we look, I have purposefully, shown this because, among the public, among the media, there is a lot of discussion on what is this vaccine doing when people get a second-time infection, third-time infection. So before we move to the Kerala data, just a few evidences, not few, I think the data has. So all over the world, COVID cases do decline. Mortality rates do decline across all regions of the World Health Organization. If we go by the variant that's circulating across the globe, 99% is Omicron. Currently, when we say COVID, it is Omicron, Omicron, Omicron in almost all regions of the world. And we do have meta-analysis data. This is from 43 studies conducted from 18 countries, various vaccines, and comparing the primary CTs. Actually, most of us in India have received the 2 doses. A proportion has received 3 doses. Many other countries, 4 doses. And a few countries have moved to 5th. Across all this, what is happening with Omicron is that there is a reduced vaccine effectiveness against all outcomes. The infection, symptomatic disease, severe disease, and hospitalization compared to the ancestral strain. But for severe diseases, the effectiveness remain higher, and that is why that mortality line is still low even when the cases go up. And it is all evidence show that there's a steep decline in efficacy against infection, and the first booster dose improved vaccine effectiveness against severe disease. I think that is very much evident. I'll show the graph from all studies. So even when the protection declines with the booster, it goes up. This is relative vaccine effectiveness. It's rather crowded because I wanted to show all. At the lowest part is any infection. These are the studies and these are the plots. So at any infection, it's all 40%, 50% in all. That means people continue to get infection, but symptomatic disease, slightly better. Severe disease, see, it's at 70% and above. And against death, that protection is very evident. And these are some of the actual numbers, the Canada studies. Against hospitalization, 83 to 88% effectiveness. And from USA, 80%, at least 80% effectiveness against severe disease. And we do have the bivalent vaccines now, including Pfizer and Moderna have developed that. Bivalent vaccines, as we know, has both the ancestral strain, the original SARS-CoV plus the Omicron. And most of the studies done so far do show an advantage, an incremental advantage over the conventional vaccines that we have all taken. But whether we should, and some countries have started using it, but whether to go for that or not is a different question, because as we know, the hybrid immunity is more than some projections say 90% or higher, even much higher than 90% of the Indian population has been exposed to COVID by the natural infection. That, along with the 2 doses of vaccines, have achieved a good amount of immunity. So in case further, like, I think it also depends on the mortality profile that a decision on the 4th dose will come in India. So right now we have the data from Kerala on the 3 doses. I now invite Dr. Sandeep, who is the Deputy Director in charge of he was sitting here and I was answering to nearly 30 calls. He was counting the number of calls.
Morning. This is the roadmap of vaccination. That is, vaccination started in January 16th. January 16th in 2021. Actually, the process started much earlier. That is in 2020 December, November or December. Initially, we collected the data of the name and hospital and phone number of all health staff in government and private sector, including Anganwadi workers, field staff, and etc. Then we collected the details of the frontline workers, including police staff and other ration shop and others. And the vaccination first started on 16th January 2021. That is only for the healthcare staff, healthcare workers, HCW, which includes the all doctors, hospital staff, field staff, public health staff, Anganwadi workers, and ASHA. And during the process continued, and next one is in 2nd February. 2nd February, it was extended to frontline workers also. That means the police staff and other staff, which are constantly in coordination, touch with the public. And then first March 2021, that vaccination started for all aged above 60 years and 45 to 60 years with the comorbidities. And next is expanded to all persons aged 45 years and above. And also in May, that aged 18 years and above from the private sector or from the state procured vaccine. And from June 21st onwards, vaccine is open to all above 18 years. And during the period also, the 2 more categories are included. That is, first one is that vaccination lactating mothers approved in 19th May, and also that pregnant women on 2nd July. And the process continued, and even the precaution dose started in 10th January 2021. And the process is still continuing, that now the vaccine is available for all age groups above the 12 years, 12 to 14 years, the Corbevax, and 14 to 16 years, the Covaxin, and above 18 years, Covaxin or Covishield. And also in some private hospitals, that Sputnik V is also available. And this is the another program in between the vaccination. Previously the precaution dose is available for those above 60 years and health staff and HCW only from 1.5 months back. That is July 15 to September 31. The precaution dose is open to all public above the 18 years of age. This is the total dose administered. Actually, we administered 5 crore 73 lakh doses in the state, which include 2 crore 91 lakh dose first dose, and also 2 crore 51 lakh second dose, and the precaution dose is only 29 lakhs. And also that there is no gender difference, that is male and female vaccination. Slightly the female vaccination is little bit higher, That is because of our population structure also, the females are slightly more than that of the males. Same was reflected in the vaccination also. And also vaccination by age group, and the other one is district level vaccination that does not represent the percentage. That is this is the population is more, the vaccination is higher. And this is the summary of the vaccination done so far. That is healthcare worker, frontline workers above 60 years. That is 100%. Some it is more than 101%. The problem with the denominator, because the vaccination, the denominator is not clearly known. We took a estimated population of 2021 from 2011 census. And the total 18 plus age group, the first dose is around or near 100%. And the second dose is 89%, and precaution dose is very low, that is 13%. And also interestingly note that the healthcare workers, the first dose and second dose, first dose is 100%, second dose is 92%, and precaution dose is only 50%. And 15 to 17 age group, 86% took first dose, and 61% took the second dose. And 12 to 14 years, that's 79% first dose, and around 47% took the second dose. That vaccination program, the 12 to 17 years is ongoing program. We are continually giving the vaccine to all. And this is the percentage. There is a huge variation between the districts. Example, the precaution dose, that a certain district is very low and certain other districts is relatively higher. This is for the precaution dose. And the COVID vaccination coverage above 16 years, that is the highest one. It also in some districts like Kozhikode, the precaution dose is only 25%, and Malappuram is only 21%. This is the total sessions conducted. That is the one session means one vaccination session. Total number of sessions conducted during the last 1.5 years is around 550,000. That is a very huge number, because we do not have any additional staff. The existing staff like JPHN, around more than 5,000 number of JPHN staff nurses administered all vaccines in the government sector. Private sector, they had a 1 lakh, more than 1 lakh vaccination sections, but the total number of doses administered in private sector is less. There's some problem with the slide. That is total, out of the total doses, around 5 crore, that is 4 crore 86 lakhs is Covishield, and around 72 lakhs by Covaxin, and Sputnik is very low, 72,000. Corbevax is 12 lakhs, and Covovax. Covovax is similar to Corbevax. That is a surface antigen, genetically engineered surface antigen, but it is available only in certain private hospitals. That is similar to Corbevax. And this is our extensive system of cold chain. Even before the start of the vaccination, the cold chain was strengthened. The Government of India already supplied that adequate number of ILR, ice-line refrigerators, and walk-in coolers, as well as walk-in freezers, and also vaccine carriers. This is the total number of cold chain points. Cold chain points means mainly healthcare, mainly all are healthcare institutions where the ILR is available, and also DVS, district vaccine store, and regional vaccine store. We had 3 regional vaccine stores, Trivandrum, Ernakulam, and Kozhikode, and 1 district vaccine store in every district. And also cold chain points varies from around 50 to 110. The cold chain is strictly followed in government sector, because that from receiving the vaccine to the last point, it was strictly followed. And during the vaccination program, there was initial part of the vaccination, when the vaccination was started for healthcare workers, and when it is open to public, there is a huge crowd in the vaccination centers, and there is a supply of vaccine was limited. Limited means always there is some availability of vaccine, but every day the vaccination is total number of vaccination is around 1 lakh to 1 day to cross the 65 lakhs per day. And during that period, there is some areas there will be a deficiency of vaccine, and some areas there is adequate number of vaccines. So that the distribution was done very properly. Because when we receive the vaccine from Government of India at the airport, that the distribution list is already prepared, And even at the time of when vaccine received at the regional vaccine store, the district vaccine wars are already present in the vaccine store. And we will transfer the vaccine to transport vehicles, maintain the cold chain and transport to the district the same day itself. From the district vaccine store, it was transferred to the remotest hospital even within 12 hours. This was done very promptly. That is why the total dose of vaccine in the state was maybe around adequate for the vaccination. But during the last few months, the total the people coming to the vaccination center is very less, and the acceptance level for vaccination, especially the precaution dose, is very low. And even now that when we started the vaccination center, especially in the rural area, the total number of people coming for the vaccination is very less, maybe less than 20, and some centers it is a few, around 3 or 5. So that total number of vaccination centers is less in Kerala because that in each hospital, each healthcare institutions decide a certain day, convenient day for the vaccination. And also there is another problem, which is that all vaccines, Covishield is 10 dose vial, Covaxin is 10 dose as well as 20 dose vial, Corbevax is a 20 dose vial. If you open the vial, then that vaccine shall be utilized within 4 hours. If 3% coming for the vaccination, usually they will wait for 10. And in the initial phase of the vaccination, if they 10 people are not come for the vaccination, they will send home and ask them to come for another day. But at present, if they 5% come for a vaccination and if we are not providing vaccine and ask them to come to another day, they will go and never come back. So the wastage of vaccine is a little bit higher now. An initial factor of the vaccination that almost all vaccine received is completely utilized, and the wastage of vaccine is very less in there. This is what.
Thank you, sir, and thank you, madam, for a very nice presentation about the vaccination scenario. Now, a few areas for further deliberations. Sir was saying in the end that at present the people coming for vaccination, especially for the precautionary dose, etc., is very low. Should we change our strategies? Maybe should we actually integrate this vaccination along with the routine vaccination for the childhood and make one particular day for everybody? And what should be the strategies for the future?
Presently also this strategy was implemented in district because most districts that Corbevax, that is vaccination for children from 12 to 14 years and 14 to 16 years, and also those who took Covaxin or Covishield as a first and second dose, they can also opt for the Corbevax as a precaution dose. This Corbevax is available in all Saturdays in all healthcare institutions. But other days, there is some institution, there is a fixed date. It is a decentralized one. District decided which day the vaccine will be provided from all healthcare institutions. And also some large hospital, the vaccine is available in all days. Trivandrum, General Hospital Trivandrum, Pulanar Kota, and Ayurveda College, the vaccines are available in all days. But in other institutions, it is available only in certain days. But the Corbevax is available in all Saturdays. But along with the routine vaccination, it's very difficult because that one reason is that small children are coming. Usually, we will not provide another combine that vaccine section with other sections. So Wednesday is the routine immunization all healthcare institutions, and outreach sessions. Most of the district is Friday, but it is decided at the district level. That is for the routine vaccination. And one thing I forgot to include, one of the success in the program is due to a software, that CoWIN software, because the CoWIN software is mandatory to enter the minimum data at the vaccination site. Otherwise, they will not get the vaccination certificate. So every person is forced to enter the data. Otherwise, the people will come and ask that we are not receiving the vaccination. So that all the data was perfect because that CoWIN software. That is why it is a live one. It is open to public also. So every time we can look at what is the vaccination happening in Kerala for any Indian state, even at a single center.
One question to Madam. Madam, what will be the future for, let's say, precautionary dose? Will there be some further second booster doses, etc.? And also regarding the next generations coming, like people who migrate from 11 years to 12 years, and are there any plans to shift it to even like 5 years, 6 year, and other areas?
Thank you, Biju. Though it was we've learned a lot from COVID. From the vaccination point of view, the situation is still evolving because unlike the previous assumptions that 2 doses will be enough, we had to move for the 3rd dose. And in India, we call it the precautionary dose. But at the international front, they've already started using this term primary booster, 2nd booster, which is the 3rd and the 4th dose. And the data that I have displayed show all that. Regarding what is going to be the future, just like in polio, right? We thought it will be able to wipe out the virus. We called it eradication, and now there are repercussions. Smallpox, like another pox virus coming back. So at the from a long-term perspective, whether we should try to have those organisms along with Homo sapiens, but Homo sapiens should be protected with certain minimum, realistic goals. I think these are the questions in the long run. It also depends on what will be the effectiveness of mutants, the variants of concern, which are yet to evolve. Like one of the response to, I think, Mohan sir, Sumo madam, all were there when Dr. Gagandeep Kang responded to our questions on whether we will require bivalent vaccines. What she said was that right now, we have an adequate immunity level in India so that the mortality levels are in country. So though WHO advocated for the 4th dose, WHO also says it depends on the epidemiologic situation of the country. In India, most of us have, because the, country to country, the epidemiologic situations vary. Even when the data, there are lots of lacunae, the global data, the surveillance system, Kerala, among the other Indian states, are almost a near perfect surveillance system. And as Sandeep said, CoWIN portal has made the vaccination data near perfect from almost all the states of the country. So all that will matter, and we not exactly know what is going to be the future of COVID vaccine for the future generations or the current, children. But at the same time, if you look at the mortality pattern, that's why I showed the initial graph, which is a global picture. Definitely vaccines do make as we say, revolutionize the ways in which countries and societies learn to manage COVID and live with it.
Okay, thank you, Indu and Sandeep, for a very good presentation. I have to bring to your notice 2 points. One is, if we analyze, when we analyze the data of IP cases and deaths occurring in medical college, as per the presentation, almost 100% of the vulnerable population actually immunized with the first dose, and almost 90+% got 2 doses. But when we analyze medical college data, IP and death, 1/4 of the cases either unvaccinated or they don't know their vaccination status. So for these calculations, they may be using estimated numbers. Still, high-risk population are there who are actually really unvaccinated and they are at risk. So we need actually strategies to protect these people through vaccination. Second thing is Kerala zero surveillance. Data says that those who receive 2 doses plus a natural infection had very high immunity. Here we actually more than 90% actually got a natural infection, as well as more than 90% vaccinated with the 2 doses. Actually, the precautionary doses what the flows comments? Is it required? Should we need to continue it? Do we need adjust the interval? Because most of the vaccine, usually the immunity actually lasts for a short period, as far as I know about the COVID vaccine.
Shall I make it's really important. Actually, those two slides I removed later because of to reduce the number of slides. Tony is there. The Zero Survey data in Kerala, if we glue, I think the text is in the public domain. Those two had two infections. Infection plus 2 doses of vaccine. I think they had the antibody level, but the antibody levels wane off after a period of time. There are studies which estimated antibodies at 3 months, 6 months, etc. That is why the protection or effectiveness against infection, that first entry antibodies do matter. But in relation to how body responds or the severity, then the cell-mediated immunity comes to play. That is why the effectiveness of even the second booster may come down after a few months, but the severity of infections will come down. Definitely, Pete cell data on analysis, on oxygen requirement, ICU admissions definitely showed if we track it over the past few months, 6 months to 1 year or so, there is clear evidence that the vaccination brings down our hospital admissions rate. If we plot it along with the COVID numbers.
Thank you, Indu. The search never ends. Continue the search. We will stop here because we have to rush. Many people have to go faraway places. So thank you very much for the wonderful session. Sandeep, thank you very much for joining us. We will depart for lunch. Then after a quick lunch, you come back again. Afternoon
So
session.
all are requested to reassemble by 1:50 p.m. Thank you.
അങ്ങനെയല്ല അങ്ങനെ സൂ കട്ട് ചെയ്ത ഇറങ്ങി സംഗതി ചാർജ് കാണും
അത് വന്നിട്ടാ
അല്ല അത് കുഴപ്പമില്ല മറ്റേത്
All are requested to reassemble. Kindly. Session, health system response, a review of advisories. I request Dr. A.S. Pradeep Kumar to present the session. And I also request Dr. Rajashree R.S., Dean Faculty of Pharmaceutical Science, KUHS, to chair the session.
Good afternoon, everybody. In this post-line session, Dr. A.S. Pradeep Kumar will discuss on health system response to COVID-19. He is a retired additional director of health services, and now he is a visiting professor in Global Institute of Public Health. I welcome you, sir, to deliver the speech.
So good afternoon. Thank you, Dr. Rajashree, for the introduction. Actually, I did this work along with Adira Rani and Sindhu, who are the faculty members in the Nursing College Trivandrum. So as an introduction, I think after 1.5 days of long sessions, I can skip this slide. So I am directly going to the objectives and other things. My objective was to describe the health system response, which were released from the health department in the form of guidelines and advisories during for the prevention of and the control of COVID-19 in Kerala. So methodology is, I looked at the DHS website to gather all the guidelines and advisories for the control of COVID-19, which were published between January 26 to 2020 to 8th February 2022. And these advisories and guidelines are downloaded, summarized, and narrated briefly in chronological order. That was my objective. I am only asked to narrate the guidelines and advisories. But at the end, I have identified a few themes and given some discussion points also. So in the website, there were 224 documents. Among them, 173 were guidelines and advisories. Of them, 63% were public health related guidelines and advisories, and 36% were clinically related. Further classification, it can be 35% treatment and testing related guidelines, 23% departmental guidelines, 14.5% logistic guidelines, 11.5% general guidelines, 7.3% were surveillance and reporting related guidelines, and 1.6% were preventive guidelines. But actually the preventive guidelines were incorporated in other guidelines also. That may be the low proportion of that preventive guidelines. Then there were other 7% were also there. So there were other documents like IEC materials, then instructions and guidelines to the department, etc., etc. So the first advisory was published on 26th January itself. That was done as an immediate alert to the immediate response to the WHO alert and ICMR alert that happened just before that. And the first advisory or first guideline included definition of cases, methods of contact tracing, sample collection measures, description of infection prevention and control strategies, surveillance and contact tracing, and guidance notes to travel. So it was a very comprehensive one because the infection was the of this type was the first one. Then this was subsequently the health education materials were also prepared and in local language and disseminated. And this health education materials also comprehensive to inform not only to the healthcare worker, but also to the local public. Then the other guideline that was published in 1st January was on testing, quarantine, hospital admission, discharge, and follow-up of international travelers and their contacts. So instead of testing, all persons came from Wuhan with or without symptom. Actually, instead of testing everyone, we had a separate strategy of testing all persons who came from Wuhan with or without symptoms, and all symptomatic persons who came from the rest of China and the rest of the world. This was the initial strategy. All test positive persons were advised to admit in corona isolation ward for treatment and until the active stage of disease was over, and then also recommended 28 days of home quarantine. Then detailed instructions were further released on the same day itself on procedure for collection, storage, and transportation of samples. At that time, there was no testing laboratories within Kerala, and the test kits were not available. So these samples had to be sent to NIV Pune. So the transportation guidelines were also attached with them. Then medical boards were constituted. These boards were constituted in the medical colleges, general hospitals, and also in district hospitals. And then on 3rd February, WHO declared the epidemic as public health emergency of international concern. Then constituted state level coronavirus control room immediately with 18 subcommittees to undertake different tasks at the same time. And when contacts were under home or hospital isolation or quarantine or under treatment, the domestic animals and pet birds were not getting proper care. Then another advisory was published on 5th February, and that advisory recommended the animal husbandry department to take care of the animals, and also surveillance of animals in markets, locations of migratory birds and slaughterhouses, etc. Also, during that time, the students or in the same home were also not getting proper care. So the students were, and also there was a fear of transmitting the disease to the other people if the students go to school. So the students were advised, students and staff were advised to abstain from attending schools for 28 days, and to report if any develop any symptoms to the health institution, nearest health institution. Then the other guideline on the same day was on the surveillance of international travelers and drivers who had contact, and included advices for the safety of them and also the staff. So this was the guideline given to the tourism department to watch for the surveillance of international travelers and also the drivers and the staff who are coming in contact with them. Then in March, the testing, quarantine, hospital admission guidelines were revised because of the new information, and also actually the cases started rising in the March. Also, the WHO declared that the pandemic has affected 141 countries. So there was a need to revise the testing guidelines, and advisories were released for arrangements and sequence of activities at arrival gates, so the transportation to appropriate isolation centers through the sanitized corridors. So airport surveillance were started in March strengthened in March 2020, and then also there were advisories to to undertake COVID appropriate behavior in beauty parlors and salons, shopping centers, and shopping malls. Detailed advisories were also given to constitute COVID-19 cell at state level and district levels in all departments, and not only in health department. Almost all departments were given instruction from the government to undertake to start COVID cell control cells, and the health department gave guidelines for the functioning of these cells to control the activities. So the Break the Chain campaign was launched at that time. And the Break the Chain campaign with the slogan of SMS, sanitizer, mask, and soap. Then instructions were given to propagate the Break the Chain campaign, and all the departments undertook the activities. Then on 20th March in 2020 itself, the detailed advisory were given to LSTD. So considering its big potential, the LSTD were given a very detailed advisory to conduct awareness, to ensure cleaning of public places like malls, then markets, and similar common places, and sensitize people to disinfect masks and gloves, or the LST can undertake the disposal after collection. Monitor the people in home isolation, whether they are breaching the conditions or not, and also activate the existing various committees like ward health, sanitation, nutrition committee, and emergency response teams and other things. Then list out the availability of, then the LST were also asked to find out the places for quarantine isolation available in the local places, and they were also list out the health personnel, community resource persons, youth clubs, voluntary clubs, etc., for creating voluntary groups for the public health action. Then on 24th March, Government of India declared nationwide lockdown. At that time, the state government issued orders to withhold immunization of children below 10 years, and also gave instruction to reduce the number of antenatal care to 4. Then dental clinics and hospitals, they were also given instructions to cut short or avoid the procedures, those were not necessary, and also aerosol generating procedures. And residents associations were advised to cooperate with the disease control activities within their jurisdiction, and they were asked to undertake infection control practices in their establishments, common places, etc. Then by the end of the March, when number of patients and primary contacts who need hospitalization increased. A lot of patients were coming. A lot of people were affected with COVID-19, and their primary contacts were also a large number. Then the hospitals were not sufficient to keep them for isolation and quarantine. Then isolation quarantine shelters were identified in the form of CFLTCs, COVID first aid and treatment centers for the COVID category A persons, group of people, and COVID care centers for asymptomatic people. Then separate advisories also released to provide advices and suggestions to reduce mental health stress. By that time, there were people under quarantine for long periods of time. So the people, even if they were asymptomatic, they have to remain there. So they were under stress. And also there were economic pressures, financial conditions, etc. So the public health advisory was issued to give advices and suggestions to reduce mental stress among healthcare workers who were tirelessly working for long periods of time, and people in isolation, elderly, quarantine, etc. Elderly in quarantine, etc. Then there was a need for dedicated hospitals, COVID-19 hospitals. So the government issued guideline for converting the regular hospitals into COVID-19 hospitals. So for the conversion, a lot of planning and preparations and arrangements were required. And this guideline included everything. It was also a comprehensive guideline to how to convert regular hospitals to COVID-19 hospitals. So in April and May, there were other instructions from the government, because when the immunization were shut down and the TB services were shut down, the public health people identified some problems, health impacts of the shutting down. So 16th April, government decided to restart the routine immunization program to children in both private and government institutions, but under strict control, like break the chain protocol, using break the chain protocol, etc. And also instructed to restart TB control services by observing strict infection control precautions. Then cancer care treatment was permitted to start in May, and also ophthalmic patient care was also admitted. Then and by that time, there were more and more people were coming from outside. So again, advisory was given to intensify screening and testing, and also strengthen the quarantine. At that time, the home quarantine were allowed, because the CFLTs and COVID care centers were filled with asymptomatic people. So the home quarantine were allowed, and the quarantine period was reduced from 28 days to 14 days. Then e-Jagrita portal was established by the middle of May 2020. This was to document the entry of people from outside state and outside India, and it was helpful to ensure effective real-time surveillance, care, support to provide, and also track and institutional verification, etc. Then in addition to the airport surveillance, the surveillance started in the railway stations and also interstate bus terminals, and also borders, state borders. Then the authorities detected increased number of COVID cases among prisoners in the jail. So that advisory was given to prevent the screen the prisoners who were coming to the jail after parole, and also newly coming to the where the prisoners were started screening. Then in the taxi, drivers were started getting more infection. Then another guideline was issued to to separate the taxis into two cabins, one for the driver and other for the passengers. So double chamber taxis were recommended, and also recommended to avoid AC air conditioners within these taxis. Then in May last week, the school examinations started. So there were detailed guidelines for conducting the examinations to give protection not only to students, parents, relatives, transport vehicles, drivers, school officials, and teachers, etc. Then the second serological surveillance was done by ICMR, stratified sampling groups. The appropriate strategies were narrated in the guideline in very good manner, and the procedures and the type of test to be conducted were also included in that guideline. Then the disease spread was detected in slums, tribal areas, etc. In July 2020, sentinel surveillance was conducted in coastal slum and tribal areas to detect any highly transmitting centers. In July middle, the guest workers were started coming from other states, and so the other guideline was published to screen them and also for testing and quarantine. Guidelines were issued. Then home-based isolation of asymptomatic positive healthcare worker were allowed. Until then, all positives were hospitalized. Positive cases were either hospitalized or admitted in CFLTs, CSLTs, etc. But by the end of July, the healthcare workers were allowed to undergo home isolation if they are asymptomatic. Then by the first week of August, then a series of other guidelines were issued depending upon the situation, like airline accident in Kannur, then NEET examination, then Independence Day celebrations, elections, and also the assembly session started. So a series of such guidelines were issued in appropriate time. Navaratri celebrations, Shabarimala pilgrimage, etc., etc. Then towards January 2021, cinema halls and performance of indoor and outdoor art programs, conducting festivals, all those things were allowed. At that time, another guideline was issued. In February 2021, the surge of COVID cases started. The guidelines to stop spread, back the IEC activities in the name of Back to Basics campaign was launched, and to strengthen the sanitizer, mask, physical distancing, etc., etc. Again, the testing guidelines were revised on 9th February, and also the government instructed to increase the number of tests to 1 lakh tests per day. And in February 2021, guidelines were given to organize COVID-19 mass vaccination campaign. Actually, in December 2020 itself, the preparatory phase for vaccination started, and the guidelines were issued to make arrangements, and that was further strengthened in February 2021 for organizing mass campaigns. Yeah, then again, as the disease could not be controlled, the outbreak could not be controlled in March 2021. All the activities were strengthened, and all the citizens were requested to adhere with COVID appropriate behavior, and organizers of ceremonies and functions were instructed to ensure the adherence of COVID appropriate behavior. As there was resurgence of cases in April 2021, decided to apply augmented testing strategy in high burden districts. Test, track, and treat strategy was introduced. And at that time, the government instructed to test at least 2.5 lakh people in the next 2 days' time. Then when the travelers were international travelers were started coming, and they were advised to undertake RT-PCR test either before 48 hours before starting the journey or immediately after reaching the place.
Excuse me, sir,
Then-
time is over.
Then a few more slides. I shall try to complete in 1 or 2 minutes time. So new COVID quarantine and isolation guidelines are issued with a 5-tier COVID care pyramid. CFLTs for category A, CSLTs for category B, designated COVID hospital for category C, home care for asymptomatic patients with home facilities, and domiciliary care for patients asymptomatic without any home facility. Then the series, I am skipping those slides, and the vaccination started, and a series of guidelines were issued for proper vaccination, identification of the people above 60, above 45, above 18, etc., in varying times of period. Then in January, most of the cases were become asymptomatic or mildly symptomatic in the quarantine shelters. They were allowed again home isolation, and then outbreak variant due to variant viruses like Omicron came. So there were other set of guidelines to control the Omicron type of viruses. Then also the travel guidelines were strengthened. Then coming to the discussion points, I have found out 2-3 points only. So I shall narrate. The most important point I have to highlight is political commitment and bureaucratic leadership. As mentioned during the last 1.5 days, there were a few mentioning about this also. So all these guidelines and advisories also reiterate the political commitment and bureaucratic leadership right from the beginning, from the 26th January 2020 till the active phase subsided in by the end of December 2021. Then the initiatives within the health department. There were a lot of initiatives for surveillance activities and contact tracing, diagnosis and testing strategies, quarantine strategies, training for capacity building, awareness creation, medical management. Due to the positive time, I am not going to explain it. Then the other thing is interdepartmental activities with the help of the other departments. So there were some discussions, especially on the LSDD. So I am also skipping these slides. And coming to the conclusion, highest level of political commitment and bureaucratic leadership were obvious in the state, and the timely interventions were palpable. Guidelines and advisories released in time were helpful in setting standards, and efforts were taken to mobilize all government departments, clinicians, public health professionals, common public and academicians for proactive control measures and useful in curtailing the spread of pandemic in Kerala, having higher proportion of elderly and non-communicable diseases and large migrant population. Then larger scale community participation, responsible LSTI in activities, and positive media involvement were also contributed in the success story. Thank you very much. Thank you for the organizers for giving the opportunity also.
Dr. A.S. Pradeep Kumar has explained the guidelines and advisories released by the Health Department for the prevention of COVID in a chronological order. I understand that he has done a very exhaustive review to concise the data available and present in this meet. On behalf of the Kerala University of Health Sciences and on behalf of the organizers, I express our sincere thanks to you, sir. Thank you so much.
Actually, I didn't look at that. I didn't compare between the WHO guidelines and ICMR guidelines or NHS guidelines with the state guidelines. It was only a narration. Thank you.
Any more questions?
Yeah, yes. There was a cluster identification and management guideline in between that was skipped in between because of the positive. It is not there in the slide.
To what extent is the borderline 24 guidelines, to what extent the guidelines are followed or eliminated other than it can be easily done. You are having the control room for the stakeholders or let's say we can follow there are the number of guidelines you have taken and must take.
I think that the system can do that, follow up that one, and an outsider I may have limited. And another thing is what we can do. We have to do some qualitative study with the various departments to find out how far they are doing it. That,
not all a priority. And again, monkeypox came, then rabies came. Tomorrow, something else, scrub typhus or something else will come. So the system, I don't think will be able to do anything. Of course, academic community medicine departments can do.
So originally there was a system. Every 2 days, every 3 days, there was one. So what are the important points to be taken into consideration? What are the points to be considered for implementation? All those points were being regularly disseminated through the online meetings, and so that way that there was not much of a confusion, but still this many large number of guidelines, and that is again that should be learning some learning from that analysis.
Good. Thank you. Actually, LSD was producing their own guidelines. Revenue department was producing their own guidelines. Then police was having their own guidelines and implementation framework. A lot of activities are going on. Thank you very much, Pradeep sir. Thank you. We will move on to next.
Next session is on testing strategies and lesson learned. The topic will be presented by Dr. Sharada Devi, former professor and head Department of Microbiology, GMCT, and the session will be chaired by Dr. S. Shankar, Dean, Faculty of Allied Health Sciences, KUHS.
A very good afternoon to all of you. As you can see, Madam is as virile as a virus. Huh? So I don't stand between her and you, but let me place this particular topic in front of you. We have been discussing the strategy of testing, like whom to be tested. And now we will see the other side, the testing strategy. So I hope this is a very big topic. And one quote comes to my mind. God, if you think God you are, dust if you think dust you are. As many faiths, so many paths. This quote is from Satya Sai Baba. What is the context here? If you think lab test is complex, it is complex. If you think it is simple, it is simple. You may do many different kinds of testing, but ultimately the truth to be revealed is one, whether the virus is there or not. So how the virus was identified, how the methods were evolved, and finally, how the laboratory was taken to the home. All that story is what Madam is going to tell. Lab testing is very simple. As I am also a laboratory man, I am very happy to introduce Madam. I'm a pathologist and Madam is a microbiologist, two sides of the same coin. Lab requires only three things: qualified, experienced technician, a well-functioning, standardized equipment, calibrated equipment, and a quality controlled kit. If you have all these things three things in place, your test will be good. I am proud to introduce Professor Dr. Sarada Devi KL, probably one of our foremost virologists in the state. Madam has worked in this college for many years. We are very good friends and she is a good teacher. Over and above that, we have interacted in the middle of the night in the COVID pandemic over reports. I used to call at 1 o'clock, 2 o'clock, and Madam used to be in the lab. So that is the best award for a COVID warrior. And probably she will be the best person in the state to tell you about the testing strategies which we have evolved. What were the best outcomes, and if there are any pitfalls, what they were. Madam, over to you.
Thank you, Dr. Shankar. Good afternoon. Let me first of all thank University and Admon sir for giving me this opportunity. So these are my objectives that I'm going to do, but I'll be skipping some of this. The backdrop of testing strategies. What are the COVID-19 testing strategies in India from 2020 till March? Testing strategies in Kerala. Positivity rates, zero surveys, all that has been discussed. So I'll be skipping that. So the key public health policy is test, treat, and track. So what is the diagnostic testing plays a very important role in addressing the pandemics. So what is the role of the rapid and accurate diagnostics in controlling the pandemic? First of all, you have to identify, treat the patient, then you have contact tracing, epidemiological characterization, public health decision-making, surveillance, and conducting a rapid situation analysis. So coming to the comparison of testing strategies across the world, there was no testing policy in some countries across the world. Then there was second strategy is that only those who have symptoms meet specific criteria. For example, expatriates admitted to hospital, contacts, etc. Third one is testing of anyone showing COVID-19 symptoms. And last is open public testing, drive-through testing available to asymptomatic. So we can see that Afghanistan does not have any testing policy. while we are going to the open public testing, including asymptomatic. But when we analyze the pandemic, we can see that it has been evolved from strategy 2 to 3 to 4. Because first we were doing only those who are coming for international travelers like that. Now we have come to asymptomatic. So we have evolved along with the pandemic. We have evolved and come to strategy 4. So I have to tell a few words about what happened a decade ago. That is when we were supposed to face the H1N1 pandemic. That is in 2009. The public health system was paralyzed at that time because there was no molecular diagnostic testing for viruses. There were only few centers where they were doing molecular diagnostic testing. And we know our state also did not have maybe 1 or 2 centers only. So then the public health professionals were just watching how this pandemic was going across the world. So then they decided that we have to strengthen the molecular, because serology testing cannot be done for diagnosing these viruses for acute diagnosis. So they strengthened the molecular diagnostic testing. How did they strengthen? We were some of the government medical colleges, they established viral research and diagnostic laboratories, VRDLs. So in 2014-15, the VRDLs was established by Central ICMR in Government Medical College Trivandrum, Calicut, Thrissur, NIV unit Alleppey. So we had 4 centers. Calicut is the regional level VRDL, state level is NIV unit Alleppey, and we have 2 medical college level labs at Trivandrum and Thrissur. So when the pandemic came in January 2020, the public health government of India immediately scaled up the preparedness, and diagnostic assays were standardized and commissioned facilities. So you all know what happened. The first case came in January 30th to Thrissur, and till about March, only few days, March, because all the VRDLs were doing molecular diagnostic facilities. So you should know that we were doing molecular diagnostic facilities. Now some doctors, Anuja was asking about what all these facilities are being utilized. Yes, we are utilizing. Now all these VRDLs have rose to the occasion and doing diagnosis for HFMD, for monkeypox. All these are being done in these VRDLs and in our state. So there are only about 4 VRDLs in the state, but what our state has done, we'll see. So ICMR was the only from where we got all the test kits for doing, issued guidelines, then formulated testing strategies. ICMR has formulated testing strategies, issued guidelines. Everything was given by ICMR. And there were mentor institutes also across the country. For example, NIMHANS, AIMS, here Sri Chitra Institute, all these were mentor institutes. There were about 14 mentor institutes across the country, and they helped in establishing the molecular diagnostic facilities all over the state. And also the data was also maintained through the ICMR portal. Then one more thing, Honorable VC was saying what happened, what were the advantages that we had because of this COVID-19 pandemic. One is that according to the NMC 2020 guidelines, all medical colleges, government and private, if they want recognition, they should have a biosafety level 2 molecular diagnostic lab attached to it. And that too, private colleges. Now I am working in a private college. I know that they have to get NABL accreditation also. Government and ICMR is not insisting for accreditation, but private have to get accredited. So the quality is also assured. So it's a accreditation process is a very tedious process. So after I have gone to the private medical college, I saw that they were going for renewal, and how tedious is this process of NABL accreditation. But I think now our younger staff or faculty in microbiology department of all medical colleges will go for accreditation also, so that the quality will be assured. And September 2020, demand testing was authorized to the country. Rapid antigen testing came into place to declare a person as COVID positive. So now I'll be going straight to this. All of them have already talked about the first case. Let me come to January 30th. Then 2 more cases reported and it was diagnosed at NIV Pune. Then government of Kerala declared health emergency, but since there were no cases in February, they are withdrawn that on February 12th. And so the January 30th, and you can see by 10th March. So there is only a few days, all of us started testing. For example, the VRDLs, State Public Health Lab, as well as NIV unit started testing. We were only doing about 200 tests per day, which reached to about 1 lab, which augmented to about 2,000, 3,000 per day. Each lab had to do. And the state government did a wonderful job. That is, they identified all the RT-PCR machines kept idle, and it was brought to all these research from redistributed to all the government medical colleges, research institutes, and veterinary colleges. And NHM, this already has been told that NHM has provided for HR, human resources, because all these VRDL, in order to augment the testing, we need HR, and NHM has provided us with research scientists, lab technician, lab assistant, cleaners, and data entry operators, because it's very important you have your data entry operators. Only then we can enter in the LDMS portal, and that can be seen by the DMO and DSO to take action. So that is one thing. And also VRDLs were giving training to the private colleges and private labs also. Then KMSCL. I cannot just forget how KMSCL helped us in that tiring time, because they provided all the kits, infrastructure, consumables was provided, and one equipment, costly equipment was given, that was automated nucleic acid extractor. All other infrastructure to the VRDLs were provided by the central government. Other than automated nucleic acid extractor was provided by KMCL, which is a costly equipment, and PCR, real-time RT-PCR, we can do at a time about 94 samples, including 2 controls, and it takes about 6 hours. When this automated nucleic acid extractor was given, it was reduced to 4 hours. So we can issue the result within 4 hours. So we were going round the clock doing the test, and because this automated machine came. Then Sunija has already told that we have each district was allotted certain labs. For example, Trivandrum district, the samples were going to Government Medical College Trivandrum, Sri Chitra, and ISAR. So these were similarly from each district, the labs were allotted. And so Kerala started with 200 samples per day to 2 lakhs per day. And coming to the testing facilities, all government medical colleges were conducting, in addition to the real-time RT-PCR, we were also having the point-of-care molecular testing like CBNAT. CBNAT is cartridge-based nucleic acid testing, and also TrueNAT, that is a chip-based nucleic acid testing. Then rapid antigen testing, and also LAMB assays also was done. And here the result we can issue within, if it's a CBNAT that is being done, you can give the result within 1 hour. TrueNAT means 2 hours. Rapid antigen testing is the great thing that we have got. Only the deficit or the difficulty is that the sensitivity is only 50 to 55% for rapid antigen testing, while specificity is 98.5 to 100%. So if you get it positive, you can give it positive, but the patient is symptomatic, and you get it negative, you go to for real-time RT-PCR. And antibody testing is not for acute diagnosis, it's only for retrospective diagnosis. For Miss A also it can be done. So that I've already told you again, once again, I want to tell, because molecular testing now we are well equipped, our state is well equipped to do molecular testing, and all primary medical colleges accreditation. Then to start with, we had only 5 labs I'm talking about RT-PCR labs. We had only 5 labs to start with our Kerala state. It ended up with 173 labs. I'm not talking about CBNAT or TrueNAT. This is RT-PCR labs. Government side only 50, private there is 123, fully functioning to do RT-PCR. Then came the next thing, we had mobile testing booths. That also was very good, so that people can come and test it. Next is, in addition to the RT-PCR and they have some other biomarkers related to inflammation. And also imaging also has to be done in order to diagnose the clinical condition. For that, that also was done. Then TrueNat and CBNat was also used for other purpose diagnosis. For example, for TB, TrueNat was being used, CBNat, all markers, hepatitis B, hepatitis C, HIV, all that was done in CBNat also. Now, since the cases have come down, CBNat has been taken away from the labs to do for TB diagnosis. TrueNat also maybe will be taken now. They are doing it to TrueNat. And so a few words about sample to start with. Sample collection, you all know now everybody is very, very aware how to collect it. I know one of my friends, who is not at all, he's a layman, you can call, as far as this is concerned. They are also taking throat nasopharyngeal swab, and from a 2-year-old kid also he's taking. So I told you, you have to be very careful when you take from a kid. But now all of us know how to take a nasopharyngeal swab. To start with, we were finding out how to start with taking a sample. We had allotted all the PGs from clinical side as well as microbiology PGs to start with to take samples. Now a technician is taking the sample in the VRDLs. Now everybody knows there is the sample collection, transportation, maintaining the cold chain to the concerned lab. This is the RT-PCR machine, and you have the automated nucleic acid extractor. So March 10th, we started testing automated nucleic acid extractor. By July 20th, in 2020, we got it. So they reduced the time of RT-PCR to 4 hours. Next is, this is the cartridge-based nucleic acid testing. So point of care molecular testing, nothing to do. Only you have to do, take the VTM, mix it, load in the cartridge, and keep it in the machine. Everything machine is going to do for you, and you get your result within 1 hour. This TrueNat, it takes about 2 hours. Here also it's a chip-based molecular testing. This is the revolutionized our testing, because even though the sensitivity is poor, very fast you can triage and you can control the infection by doing a RAT. Then for airport screening, that was very important. Expatriates, there are so many, and for travelers, we were using Abbott ID as well as Acula. Very fast, you get the result within 30 minutes. The first one is that we do RT-PCR by using temperature. We separate the strands. Here, what we are doing is we use the endonuclease enzyme to nick the strands and then amplify the strand. That is very fast. The isothermal technique, and that is Abbott ID, very fast. That was used in the airport for screening the passengers. Then sero survey. I'm not going into sero survey because it was, I think 2 of them have already talked about it. So there was the sero survey conduct. First is a rapid antibody testing. Second sero survey was conducted by ELISA, and third by chemiluminescence immunoassay. There we were looking for anti-spike antibody as well as anti-nucleocapsid antibody. Then quality control, very important, because as soon as we started testing, ICMR told you have to send your samples 5 positive and 5 negative to your NIV Pune to check the quality. So those who have, that was done for many months. Later on, they told you 2 of them, that is NIV unit Alapui and GMC Trivandrum was again doing the inter-lab quality control. That is all other labs in the state will send for quality control to our lab, GMC Trivandrum and NIV unit Alapura, and these 2 labs have to send their samples to NIV for quality checking. So quality control process also was there, and they assured the quality assurance. Genomic surveillance. Now, one very good thing is going to happen is that now we have only the molecular testing in the VRDLs. Now ICMR is planning to give us sequencer. I'm saying us means that VRDLs sequencers is going to be given, but maybe not like all the VRDLs will not be given, but we will be doing our sequencing in our labs itself. That is now they are thinking to give sequencers. VRDL at Calicut is the regional level, and they're getting crores of money from ICMR. They can upgrade and immediately they can start, because they have got, the funding is very high in the case of a regional level. So the genomic surveillance, I'm not going into detail about the genomic surveillance because I already explained that because the sequencing, we had to send our samples to IGIB New Delhi and the data used to come only later. So if action has to be, whether these is highly infectious or is it active against your monoclonal antibodies or lockdown is needed, all this will come late only because we are sending the samples, we get the result late. So maybe the next time we will be doing our genomic surveillance ourselves. Okay, I'm not, okay. Next is, okay, now to positivity rate, I'm not going into positivity rate. Zero surveys, I've told you, 3 has been conducted and last is also been described. Lessons learned, that is only one defect I have found in the testing strategy is that we were very good. I think Kerala State was very, very good in doing all the tests and giving it correct. But one thing happened because I was also the nodal officer for antimicrobial resistance, state nodal officer. And I know that there was collateral damage, AMR surveillance has gone down because everything was utilized for COVID testing. Only defect I have found out from this the COVID testing or COVID pandemic is that AMR surveillance has come down, but we are picking up infection control practices. We had a very good, Dr. Anil Satyadas is here. He knows that there are infection control practices in Medical College Trivandrum. Our link nurses, all of them were utilized for this pandemic now. They have started coming up. So only defect I have to say is that the AMR has been, it is a silent pandemic, is going to come up. Thank you so much.
Thank you, madam, for elaborately telling us about the testing strategies in Kerala. Don't go away. I found most impressive two things in that. Lab workers were not seen before COVID. Now they are seen by the crowd. They came to the forefront in the COVID. This microbiology department, nobody even knew where it was in a college. And our students, they were put to use in the districts to collect the swabs. So they also got a good feeling out of it, that we are also important, that paramedics are important. And this swabbing duty, where the doctor takes the swab, the technician transports it and puts it into the bottle, and the nurse documents it. So the teamwork, in that, that I think was very, very impressive. And these are the lessons, the good lessons, which I have learned from Madam's talk and also from the COVID. I think it was in 2011 or 2012 when the MRU was first started in Trivandrum. I was the nodal officer. This PCR was bought. So at that time, I understood that the PCR alone does not do the job. It requires a lot of accessory equipments like centrifuge, biosafety cabinet, etc. So actually, I developed a turnkey for the PCR workstation, which is there in the KMSCL even now. And that came out to be very useful because you don't know what else to order along with the PCR equipment for running a PCR lab. It is all there in that. So sometimes you work on intuition and I'm happy it worked. The only probably the negative point which I was trying to discuss with you yesterday is this waste which has come out of this COVID. All that COVID testing, the bio waste which has come in a huge manner. You can even now see the boxes lying in the corridors. What to do with that and how to tackle it? Madam, can you just give your impressions on these two aspects? One is the swabbing, have we made an SOP of that?
Yes.
And secondly, this bio waste disposal, have we made an SOP on that?
There is a proper biomedical waste disposable by the image. It is very successful. Every day, or maybe one day, if they don't come or if they are late, we call it. And I don't think in Government Medical College Trivandrum, there is an issue. Proper disposal of biomedical waste is being conducted. And about the boxes that the person who is in charge of the lab should take the responsibility to remove it. We have removed all the boxes. SOP is there.
Any other questions, please?
Because lab portal, no, we'll just data entry operators are there, LDMS portal, they will be entering. So it was very good because that is how the DMO and DSOs were able to take action also. Immediately action will be taken for contact tracing, quarantine. So LDMS portal was very good. Yes, yes. Correct.
I don't know whether this is the appropriate session to raise this question. Healthcare safety in the lab and COVID. Madam, in your experience, how many your lab personnel were infected?
Many were infected. Many were infected. But we don't know the source, whether it is from the lab or from where they got it. But many were healthcare, you know about healthcare workers, so many were infected, including lab personnel.
If there are any more questions or comments? If not, I would like to thank on behalf of KUHS, Rajmohan sir and all the faculty here for a very nice lecture and elucidative one. Thank you, madam.
Thank you, madam, and thank you, sir. From testing strategies, we can move on to critical care system functioning. So we have with us Dr. Anil Satyadas, Associate Professor, Department of Anesthesia, Government Medical College, Thiruvananthapuram. And I also request Dr. Chandaniya, Professor and Head, Department of Critical Care Medicine, Government Medical College, Kozhikode, to chair the session.
Good evening, and I thank Rajmohan sir and Kuhas for giving us this opportunity. And I think the most important areas that was maximum stressed were testing and treating in COVID, because we have moved a long way from what we had before COVID. As we have listened to Sharada Devi madam, what much we learned and acquired. Now we are moving on to the other area, that is critical care COVID, because we were so much stressed, as we know that from day one, this disease is causing hypoxia, this disease is causing ARDS, and patients are going to die if we do not provide critical care. And I will listen from Dr. Anil Satyadas. He has been continuously involved in critical care management of COVID-19 during the entire period. Over to you, Dr. Anil.
Thank you, madam. Good afternoon, all. So I still have the memories of our patients in the ICU, even after a long time, because it was all like psychologically very traumatizing. We'll discuss the problems here. So we have the spikes in Kerala, which had the first wave and then went on to, I think our government did very well to play to the second wave. And then the third wave, maybe the second one came up, but it was less severe and it did not pressurize at all the ICU, the critical care part. What we did till now was we had around 25,200 admissions and around 10 to 15% of patients needed ICU care. We were lucky in a way because it was just previously we had that 4-level multi-specialty block was opened, which had 4 levels of ICU, and we could like cohort patients who needed critical care into that building. So that was actually a blessing. That was converted, all the levels were converted to COVID ICU. And the problem we were facing was healthcare infection. So we tried to put up some negative pressure technology, but then the problem was we could put up some exhaust fans which could suck in air, suck out air, but they were not very powerful, and the cycles were not very proper. And when we are sucking out this cold air from the ICUs, we needed actually extra air conditioning, which was also very difficult. So the initial time, the modifications were made, but the ACs were really bad. As we all know, we had good surveillance, we had contact tracing and things like that. We definitely anticipated a surge, and in any pandemic, we have to identify the space, manpower, materials, and we had to sit together to decide on the treatment protocols also. Filling the gaps, we'll see in the next slide. And yes, one of the most important challenges we faced was to avoid healthcare infection healthcare worker infection. So because that would like decrease the number of people who are with us. So filling the gap, we had a liquid oxygen plant, and the problems we faced were we had very few who were trained in critical care, both including doctors and nurses. And we had few ICU beds. Medicines, most of the new medicines we didn't have, but at that time we had very little new medicines to start with. We had the steroids to in the protocol. And we also had a concern that sometimes our oxygen might not be like meeting our requirement. Ventilators were there, but maybe not very many. And during the later phases, we had introduction of special devices like HFNC, which were not at all present in our hospital. And as you always in a new disease, we had little treatment with very strong evidence. So we had to be a part of the protocol development team also. And we had to do a lot of homework because we had to attend to all international meetings or discussions regarding this. And we had to work on ourselves regarding the infection control part, because a huge number of patients would come in where the disease would transmit as an aerosol. Faculty and residents training was started the very moment we had the government asking us to do so. That was very early. Even before our ICU was converted to a COVID ICU, we had started physical training for residents and staff nurses. And we had to start from the PP, also definitely the swab collection. Ventilator support, people knew about that, but then we had to put in nurses and doctors who were not actually taking part in ICU care. We had to train them. Medical management also, we had to train them. And ICU training was done initially on the physical route, and then we had smaller sessions on the online part. Medical management, we had very good support from the general medicine department as well as the infectious disease department. And as I've told you earlier, we had to be very careful with the use of oxygen. That is one drug that has been misused a lot, because patients go out of the ICUs and still the oxygen flow meter would be running. So we had have to be very strict, and all the outlets were made leak proof, because we cannot estimate how much leak would be there in these situations. We also trained them regarding what all investigation to do at the particular at the admission every third day and things like that. Triaging was also reinforced. We had to teach people with how to use the high flow nasal cannula machine that was actually new. We also had many soft copies of some kind of guidelines or management protocols in ICU being distributed among the healthcare workers. People were trained on non-invasive ventilation, when to step up to invasive, and definitely infection control practices. The team consisted of a very few doctors who were actually trained in the critical care. And we were helped by faculty residents from pulmonology, anesthesiology, and medicine. Most of the surgical PGs were attending to patients in the ward. Senior residents of all medical allied specialties, super specialties also pooled into the ICU team. And we had people heading as nodal officers, assistant nodal officers, as administrators. And we had a meeting every day to discuss each and every patient in the ICUs. So it start from 8 o'clock and maybe extend to 11, 11:30, 150 was, I think, the maximum number, 155 cases per day when it was the peak. The first wave was very, very difficult. We had high mortality. As you know, definite treatment was not there. And one of the drug which we used was the steroids. And early, and people would we had transportation was difficult. They had to inform the government for transportation and all those things. That made patients come in very late. And triaging also, which patient needed ICU care, that was also not very definite. And we also had very little investigations which would help us to prognosticate. So these patients, and CT scan was difficult at that time. X-rays also were there, but then not commonly used. Prognostication is one thing that was very, very difficult. And during the first wave itself, we found that the invasive ventilation had a higher mortality, which were subsequently substantiated with studies from outside also. Maybe it is because of less care or the problem of the new disease, new pathophysiology. The problems where we literally head down were refractory hypoxemia. You give oxygen, patient does not come up with the SpO2. You give more oxygen, nothing will happen. And the patients had a lot of work of breathing. They would be literally exhausted at the end of the day. And we would put them on a non-invasive ventilation. And some of these patients were totally dependent on that, meaning that we cannot even take off the NIV for feeding purpose. And we had to sometimes we would put in a Riles tube, the cut one, to be used as a straw. You would put that in between the mask and the patient's face, and they would try to suck in. But again, that was very difficult to produce a negative pressure with the positive pressure going from the ventilator end. People would feel hungry, they would feel fatigued, but then the NIV and then all the straw feeding weight was not sufficient. Then keeping them prone was again very, very difficult. With the mask, you have to lie prone. That was again difficult. And identity was definitely a problem. We didn't know what this patient was, what was his background. And I think that the other side was more difficult for us because the patient would see only people with the PP, all the people at white, they could not identify us. But we had one patient who came back. He came back to see us. He had a very severe disease. The score was around, I think, 24 out of 25, that the CT grading, the damage is 24 out of 25. Last doctor's day, he came up. He has never seen me without the PP. So we were 4 doctors there, and he came up and we are talking. And he said, "You are Dr. Anil." It was all the sound which I identified. They could identify us with the sound. So that was really bad from our side as well as the patient side. VIPs could come up, but still we could not see the social background, all those things, which was difficult for us. And we are not talking to the caretakers personally. And phones also created a lot of problem because some of these patients would come up very costly phones. Okay, so the rule was to hand over the phones and any costly item to the sister in charge. She had to keep it in safe custody. And some were literally requesting us to give them the phone to communicate to the family. And later phases, we allowed them to do so. And also in the ICU, if they're using these phones, it can get lost. So the patient cannot take care of these expensive phones by themselves. That was also a problem. And we try to manage some kind of radio or music play so that they also would be calm, or they would hear to music also. Most of them had very little sleep at night. And when the thing plateaued, everything came into as a routine. So we had 24 hours a day, we had 1 doctor in the ICU, especially in the MD ICU. And fortunately, we had the timely modifications which in the protocol, which introduced newer drugs like remdesivir, monoclonal antibodies were introduced, and we had the number of ventilators pool increased. Most of them were supplied from the central government also. And we also could have a transporter ventilator which could give 100% oxygen, because most of the patients were on 100% oxygen, and it was so very difficult to shift them for CT scan on the on the non-invasive ventilation. High flow nasal cannula became more commonly available. That was it was again supplied by the government of Kerala. And high mortality was found in pregnant patients. Very distressing note that. Obese, immunosuppressed, and the aged. Comorbidities were definitely high in these patients. And the pathophysiologist said that it was how the patient fought the infection decided whether this patient would survive or not. Very interesting. So if your body does not respond too much to the infection, you would survive. Technology also came in, though a bit late. We had the relocation of the central nursing station. So we had A and B sites, so 12 beds each, and the nursing station could be located to outside the ICU, where paid doctors would sit there and monitor the monitors. We also had some few monitoring cameras where we could control the cameras from outside the ICU. Protocol education was continued online with the help of state training division of the NHM. We had a lot of protocol updates. And regarding the resident teaching, so that first year batches had come and they were put into the ICUs for managing, and we strictly had a 1 class per week. That was also ensured. Communication part was very difficult. Communication with the caretakers was very difficult, because we also had the facility to dial the mobile number from the phone inside, rather than connecting to the telephone exchange and then requesting them to connect. Okay, we made it a habit that to discuss the problem of the patients every day. We would also document that it was discussed with such and such person, the condition of the patient. And close relatives, during the later phases, close relatives were allowed by the government to visit them. They should bring their PP. And we definitely supported all the patients with psychological counseling. Our center was to be converted to be the hub and spoke model. So we would have tele ICU consultations with the general hospital and other hospitals. We had camera surveillance and central nursing station monitoring. When the second wave came up, we had all the newer drugs coming into our ICUs or hospitals. The trials were much better. Many survived with timely management. So that was the after the introduction of the new drugs, and maybe monoclonal antibody also helped us a lot. Though the late presenters had a higher mortality, the second wave actually had Omicron type had very less severe disease. And we also could categorize patients into steroid responsive and non-responsives. So patients who even had a high CT score, some of them would respond to the steroids and they would be out of the ICU maybe in 7 days' time. But the others had a lot of suffering. The last slide. And we are also concerned with the oxygen leak. The last phase put a lot of pressure on us, because we had to predict the oxygen requirement and inform the central government. The KMSCL, especially Dr. Dilip, did a lot of homework, and we had a lot of sheets, Excel sheets like this, where we would predict that if the wave goes at this rate, this would be our oxygen requirement. As you know, the oxygen requirement is difficult to calculate because of the leaks, which we cannot estimate. And finally, we were fortunate to have our estimates very correct. We also had oxygen concentrators installed in the hospital during the late phase of the disease. I think this is the last slide. Thank you. So most of the days our eyes were like this. It would get fogged. Could not see anything. And with this Googles, and we are supposed to put in lines, peripheral lines or central lines using ultrasound. It was so very difficult. And now there is some clearance. So thank you so much.
Thank you, Anil, for that nice presentation. And he has covered everything so very well. And as Sharada ma'am told, all our ventilators are now used, and earlier we never bothered to give oxygen, or now the resident is asking. In the emergency department, I have 5 patients, 1 require oxygen bed, 1 require non-oxygen bed, 1 on HFNC, 1 on NIV. That way they have started speaking out, and it was a lot of learning. And now actually we need more ventilators and ICU, because the training has given us the confidence to manage patient better in all areas. And all the persons who are contributing, not only medicine, emergency medicine, anesthesia and all, but those who are actually not working, like surgery, ortho, all were actually tuned to ventilator care and ICU care. I think that is a good point that COVID has taught us, but we need to work harder. We need more people, and youngsters are to be better trained in ventilator and ICU management for future similar pandemic or outbreak. Thank you. I think there are time for questions or comments. Okay. Okay. If there are any quick comments, otherwise we will wind up. It's already late, I think. Thank you so much.
Thank you, sir and madam. Now let us hear from Namita, Research Fellow, School of Public Health, on the experience of efficient risk perception and communication strategy. I request Dr. Jagadishan, retired Deputy DHS Planning, and Dr. Indu PV, Professor, Department of Psychiatry, Government Medical College, Ernakulam, to chair the session.
Good evening, all. So we will see risk communication strategies adopted by Government of Kerala during COVID-19 pandemic. So we have done a small exploration about the strategies adopted by Government of Kerala during COVID-19 pandemic as the risk communication. So as we all know, risk communication plays a crucial role during any acute public health events, like even if it is flood, or even if it is any infectious disease like Nipah, COVID, etc. The people will become, because the rumors can create panic among the people, and it can lead to distrust among the people. So communication, the risk communication is very important in this stage, because risk communication aimed to equip the people with the information needed to make learned independent decisions about risk to their health, safety, and the environment, which are meaningful, understandable, and actionable. So always the risk communication should be timely, relevant to the context of information sharing, accurate and valid, and direct to give reassurance and hope to the people. So this is very important during any type of public health event. So here we will see about what are the risk communication strategies we have adopted during COVID-19. So after reviewing the literature, we have developed a communication, how the risk communication strategies are taking place. And this is in the scenario of COVID-19. And this is according to our system. So when the COVID-19 pandemic has occurred, the government automatically started the risk assessment based on the science and evidence. And now coming to the risk governance. In the risk governance, there was a policy development. After the policy development, the risk communication is taking place. The risk communication is already taking place through different channels. So here we have mentioning only the government channels. So after the government channels, through these channels, the communication is reaching to the people. So when it is reaching to the people, it is giving a risk awareness building. So the risk awareness building is leading to a risk perception, and it is giving an outcome. So there are some of the things which is affecting this process also. But the ultimate impact is reducing the mortality, reducing the morbidity, and reducing the economic loss.
So as this is the governmental system which is taking place, but directly there is after when any public health emergency occurs, or here in the case of COVID-19, there was a risk awareness building directly taking place in the people also. So this is the communication system. These are the elements of communication system which is affecting the risk communication. So the risk communication is targeting to general population and also some of the targeted population. So always when the risk communication is effective, so we have to have a monitoring system and evaluation system. So here we have seen only the process, how it has taken place in Kerala. So here we already know the method adopted by Kerala for containing the COVID-19 pandemic was well appreciated globally, and effective risk communication and good community engagement is the one of the major and important factor in that. So the different types of digital system, direct communication strategies we have used for the risk communication. So we tried to evaluate how these strategies have taken place in Kerala. So what are the methodology we adopted? We identified behavioral content of 922 information, education, communication, behavioral change communication materials published by Government of Kerala. A sample of 15 posters we have selected, one each from 15 COVID-19 appropriate behavior recommended by Government of India, adopted by Government of Kerala were evaluated. So in these materials, you can see that we have taken 303 IEC, BCC videos and images, and 496 IEC materials, and 23 infographics and posters, and total 922 materials we have selected. So there is no need of explanation. The phases of risk communication, how it has taken place in Kerala. The COVID-19 phases, it is divided into different phases, but it is not after completing completing one stage only, another stage. It is not like that, or it is overlapping. So the first, when the public health emergency started, that is the initial phases and declaration of the COVID-19, many information sharing system, that communication strategies have developed by Government of Kerala. And the second stage is education and reopening. The education means after a period of the COVID containment, that after that we have started reopening the schools and also the reopening of the offices. So we have developed many IEC materials during that time also. And the last time we have came into the recovery phase or maintenance and control phase. And during that time, we have the vaccine rollout also. So many IEC materials we have developed during that phase also. So the total phase is divided into 3 phases, but it is overlapping. This is a system used for risk communication by Government of Kerala, especially the websites. So these are the official websites, Government of Kerala, the official websites of Directorate of Health Services, and the official website of Arogya Kerala, NHM. And this, there is no need of explanation. We can see that the Government of Kerala, we have a COVID-19 dashboard, and official website of DHS Health is having daily bulletins and links for related websites. And Arogya Kerala, we are having a COVID Jagrada portal, and also the official websites of Police Department, LSGD, and other government departments. These are the major websites we have used for IEC material publication and risk communication. Another important thing is the public has accepted the risk communication, received the risk communication is mainly through the daily press conference of Chief Minister of Kerala. So here, in the daily press conference, there was a details of the disease statistics, COVID-19 appropriate behaviors, vaccine acceptance, health maintenance, etc. Everything has included in the daily press conference. This helped the public to accept and aware about the real current situation, and they adopted they accepted that advices, and they changed their behavior according to their
advisors. Next, coming to the Disha helpline is a toll-free telephone number 1056. This provided 24/7 services, including COVID-19 related awareness, physical and mental health support, and counseling. Next is GOK Direct app is an official mobile application which increase the awareness about COVID-19 and communicate the suggestions and notification what government wanted to deliver to the public. These are important campaigns we have conducted for risk communication. So from January to November 2020, we have conducted 4 campaigns. First one was returnees from addressing to the returnees from Wuhan. And second is break the chain campaign. That is very important campaign. It has reached the public in very effective way, and the people accepted that campaign, and it has given more than 80% effectiveness in the COVID containment. So the break the chain campaign is to spread the information on COVID-19 appropriate behavior, especially the public and the personal hygiene. The next campaign is addressing to the returnees from foreign countries and other states, emphasizing the reverse quarantine. The fourth one is to generate awareness on the community spread. Next, coming to the January 2021, the major campaign was Back to Basic campaign to educate the people on the importance of COVID-19 related protocols and reduction of transmission. Next is September 2021. Another campaign was Be the Warrior campaign. It ensures the COVID-19 appropriate behavior and speed up the vaccination. Other campaigns conducted for risk communication was Kite Victor's channel, online campaigns for media handlers, special campaigns addressing precautions during Onam, special occasions like Onam, Article Pongala, Legislative Assembly election, Sabrimala pilgrimage. Then Karudal was a special booklet was issued to give awareness of COVID-19 and non-COVID diseases. Then WhatsApp chatbot, special post cover by Postal Department. Then mass printed with IEC messages, hoarding placed in the various parts of the state, especially in the major cities. Vehicle branding that we have seen, like Jan Shabdabdi train, and the vehicles of Department of Health and Family Welfare, they have given pictures of this COVID-19 containment, and it has reached to the public and accepted, and it has given a very important role in delivering the message what government wanted to share to the public. So every risk communication, there should be a process evaluation and outcome evaluation. So this is coming to the evaluation of the message delivery system. So the process evaluation can be done by evaluation of the activities involved, like number of messages produced, number of outreach programs conducted, number of posters released, number of press meet conducted, number of people trained. So the outcome evaluation is mainly through the assessment of the impact of program, like how far the information reached the people, how far they comply to the message, change in knowledge, attitude, skill, behavior, norms and practices, reduction in the morbidity, mortality, economic impact. So here we have done a small process evaluation. We have not gone into the outcome evaluation. Outcome evaluation can be done through qualitative and quantitative methods. That can be done later. So here we can see the message delivery process used by Government of Kerala. As these are the elements of message delivery process. The targeted audience are general population, the returnees from Wuhan, high-risk population, and health workers. The nature of message are simple, clear, understandable, and considering the health literacy of the people of Kerala. So we have used many type of messages like route maps, audio messages, posters, written messages, video bites, awareness jingles for radio, YouTube videos, etc. So I already mentioned that we have adopted 15 behavioral aspects. We have to have these 15 behavioral modification among the public of Kerala. So these are the 15 behavioral change adopted from the government of India by government of Kerala. So the time of delivery is very important for this risk communication. The exact time, the exact message should be delivered to the people. So this is appropriately done by government of Kerala, because in the early phase to the people of Wuhan, the first phase, break the chain and information on quarantine, community spread and special campaigns during occasions. Second wave is back to basic campaign, be the barrier campaign, vaccine drive. In exact time, exact delivery of messages have happened in the government, by the government of Kerala. So this is we have done a small process evaluation based on all these the risk communication strategies. So we have identified, already mentioned, 922 IEC BCC materials, and we have selected one each from 15 the COVID appropriate behaviors, and we evaluated based on these criteria. So these are the criteria we have used for the evaluation. So from each category, we have taken one messages or IEC materials we have taken for the evaluation and given a score for that. So for each 15 category, we have taken one model IEC material. So and given after the evaluation, we have found that it is having a total score of 136.5 with 91% score. So it is coming under the excellent category of risk communication adopted by Government of Kerala for the public. So what are the lessons learned from this all small process evaluation? So we have learned that the strategies delivered by the Department of Health and Family Welfare, Government of Kerala, in collaboration with other departments like LSDD, Police Department, were more beneficial in risk communication and containment. So for example, I think most of us is remembering about the transmedia storytelling by Kerala Police. We have seen that the hand washing technique they have shown through the famous Malayalam film song of Ayyappanum Koshi. So this is another method of delivering messages in the risk communication. So that has adopted, that accepted by the general public, and they learned very easily how to do the hand washing technique. So the risk communication strategies used were timely, effectively planned and delivered by multiple channels. So the people have taken them into their heart. So the success story partly owed to the risk communication, which is evident from the local innovations. I think most of us are familiar with the local innovations here. So you can see the people understand the risk communication, the behavioral change, what the risk communication changed into their behavior, they adopted into their life, and they practice in the local setting, like the washing facility in the auto rickshaw and the break the chain campaign. The public places, they have placed the hand washing facility, and they followed the masking technique and the physical distance, etc., etc. So these the people have accepted and adopted into their life. So what is as a concluding the topic, the Kerala success in handling the COVID-19 crisis lies in the lessons learned from the effort of contain of Nipah outbreak and natural disasters like flood and landslides, along with its strong public health system. Further structural and systematic research-based approach to monitor and evaluate strategies for impact assessment will be useful for further pandemic preparedness in terms of risk communication. So this is very important role the risk communication is having in the containment of any public health emergency. Thank you.
Namita, please come in. Very good presentation, very systematic analysis of risk communication methods which we used in COVID control. So they have studied in a very scientific, systematic manner 922 samples and systematically examined, and the whole process evaluation was done. And I am very happy that they could come out with a very good score also. As an insider, since out of these 18 or 22 subcommittees. IEC committee was one important one. And every day or every following every review meetings, the feedbacks were passing on to IEC team. And that was led by Dr. Ramesh, ex DHS. He was later shifted to Kazakhs, and he was leading the team, and all the IEC team of DHS and NHM was part of the team, and all the teams were giving the feedbacks, like just call centers. What were the types of calls they were receiving during the daytime was analyzed in the evening, and that was being presented. So what should be the focus for the IEC next day or next week was that way streamlined. And similarly, the evening meetings with the DHS. So based on the DMO's requirements, strategy was formed, and IEC was formulated, and including the social media IEC. So it's very good work, and it's worth publishing also, I think. Over to you, madam, and to the for discussion.
Thank you, Namita, for an excellent presentation. Actually, in recent history of mankind, I should say, this is one scenario where risk communication strategies have been used maximally, which could help modify the perception regarding the risk, as well as in modifying the course of the illness, probably course of this infectious disease. So I hope you have done an excellent work in evaluating the risk communication strategies. Hope you'll be following up with the risk perception, changes in the risk perception and outcome. So any questions or clarifications you can ask? If there are no more questions, we can wind up the session. Thank you.
Thank you. The tea is ready outside. In between, you can go and have the tea. We are continuing with the next session. That is, I invite Dr. Sanjeev Nair, Professor and Head, Department of Respiratory Medicine, Government Medical College, Thrissur, and Dr. Kamala, Assistant Professor, Department of Respiratory Medicine, Medical College, Thiruvananthapuram. And I also invite Dr. Colonel K. Rajan, Professor and Head, Department of Respiratory Medicine, SUT, Medical College, and formerly Professor and Head, Department of Respiratory Medicine, AFMC, Pune, to chair the session.
Hello. To be precise, we are running about 25 minutes behind schedule. So without wasting further time, I request my decades-old friend, Dr. Sanjeev Nair, who doesn't require an introduction to this crowd, to let us know about the long COVID and the pulmonary manifestations, along with Dr. Kamra.
Thank you, sir. Thank you to the organizers, particularly Rajmohan sir, for this opportunity to interact with all of you. Sir has very clearly told me to stick to time and finish fast. So I'll be rushing through a bit. So hopefully put a timer on so that I keep watch on time. So basically, the plan for the day was to discuss the pulmonary manifestations of long COVID overall, cover a bit on the local scenario on what we have in terms of local data. Of course, being a clinician, I would have been more interested in presenting to you some of the clinical manifestations that we came across, which are important, but I'll skip that. But I'll discuss a bit on therapeutic options, not to discuss how to treat the condition, but in terms of how the health system strengthening is needed to tackle this scenario, because this is going to be with us for some more time, including some of the public health strategies which have been told to us, and what are those issues in following those strategies. So it has been a long journey for all of us. Dr. Anil Satyadas was actually telling us about the difficulties that we went through. Dr. Kamala was one of the nodal officers at that time. So we all went through a lot of difficulty. Dr. Indu has done a study on the stress that the residents had to undergo. And so it has been a long journey. I work in the institute which reported the first case in India, and they were, they did publish that also. So, we started from them to now when we have a large number of cases there. The numbers are important. We have gone through the numbers so many times today, but the numbers are important because, in terms of post-COVID complications, if I say that something is present to the proportion of 1%, I would as a clinician say it's only 1%, it's rare. But when you have something like 43 million cases that you're talking, 44 million cases that you're talking about, 1% of that is a big number. So the health system has to tackle that 1% in an efficient way to take care of the population. The three topics are going to follow. Two more topics are going to follow here. Each of them would be discussing something similar in the various other organs. But then there is this issue of definitions. When do you call this long COVID? In between, we were also a bit confused. The current consensus is somewhere around 12 weeks, or anything beyond 12 weeks is considered as long COVID. But if you look at some of the studies that I'm going to present later, many of them have different time frames at which they're talking about. So maybe there is a bit of lack of consensus, at least during the early times in there. And WHO probably, they have a more clear definition now, which talks in terms of probable or confirmed COVID. This is one of our issues. So patient coming to us, we feel it's a long COVID, post-COVID, but there is no proven history of COVID. So we face a lot of cases like that in our clinic. So that is also sort of included in that. They talk in terms of 3 months after the onset, and they also talk of the symptoms lasting for 2 months. So, there is more clarity on what I can call long COVID now. So those things have become more clear, and it should not be explained by alternate diagnosis. There are many alternate conditions which come up during this period, which are wrongly labeled as long COVID. So that is also not permitted. And they have very clearly said that the symptoms, which is also what we are seeing in our post-COVID clinics, it could be something that continued from the illness, or something, the person might have become totally normal and now is presenting with a new symptom at much later after the illness. So both of these things are quite common in our practice. So this has been discussed a lot. The WHO document itself was talking in terms of 5 to 20% of various organs being involved, everything put together. But then, more and more data started coming in terms of the respiratory involvement. So these are from some of those countries that I put in. So it ranges from somewhere around 30% to even 70%. They're talking in terms of long COVID, symptoms which persist for a long time. These numbers seemed very high at that point of time. More clear data from the IDSA CDC website, from the US websites, talk more about around 25-30% of people having symptoms which persisted, more like some of the studies talking in terms of 10 to 15%. So the proportions were really varying, and among these studies, probably it also varies based on which is the population you're studying. Are those the sick ones which are there in the ICU? Are they the ones which are just hospitalized, or are you talking from in terms of a community cohort? So obviously some of these studies, the methodologies vary and the results also vary. UK also brought out some data in terms of shorter and longer follow-up, somewhere ranging around 20-30%. So it has always been around 20-30% would be the consensus that we thought of. Then it broke out in the Indian news media. So in the news media and the social media, as many of the speakers were talking about earlier, did play a big role in shaping policy. Ramanguti sir's talk was on policy in the beginning. So, this big thing broke out, particularly from the Mumbai media, talking in terms of post-COVID lung fibrosis as being the next crisis for India. So it started coming like that. And it's a very famous group which actually brought this out. And in fact, they used a very appropriate terminology, the tsunami that is going to follow the earthquake. So, you had an earthquake of COVID, and now you're going to have a tsunami which is going to follow and which is going to flood all of us. And that caught on very fast, so all media from all over India started picking this up. And then this became a new crisis that was to come. They even reported that hospitals in Maharashtra were filling up with patients with post-COVID disease, which led to already you had a crisis of not having enough beds for COVID, treating COVID. And there you have a large number of people taking up beds for post-COVID illness. So when this came in, the government also sort of got frightened. This all was based on an article which came in from Dr. Udvadia's team from Mumbai, which talked of the tsunami that is following the earthquake. So it was published, and that article led to all those news articles. This team, I remember this team as being very famous because they had created international attention to something called totally drug-resistant TB based on a case report of 4 cases. So just 4 cases they reported from Mumbai, but that became international news. So they have been doing it in the past, but that led to a lot of worry all over. And of course, the government reacted fast. The government of India and the government of Kerala looked at this as a major crisis that had to be addressed. And very soon we had the national guidelines. We also had the Kerala guidelines on setting up post-COVID clinics. So this was at a time when we were struggling with COVID cases. So in the midst of that, we also had to set up clinics for post-COVID. So, we had a twin burden to one, the COVID, and the other side, we had the post-COVID clinics. Very clear guidelines came in and they also gave us instructions on how to maintain the data, to collect information on what is happening in post-COVID. So that was there. But of course, the crisis was that immediately after that, every department made their own forms. I was in Trivandrum at that time. We had our formats. Kamala would know that. In Thrissur also, they had a set of formats. But we started getting burdened with all kind of work. So while I was working in Trivandrum, I was sent to Karakonam, I was sent to SUT, I was sent to SR Medical College, Varkala. So I was being sent all around the place. So we were not even taking care of patients here. We had to take care of other institutions as well. Our residents were so busy. In the midst of that, somebody sitting down and collecting data was something that did not happen, as you would see in the next slide. And so many other duties also took it up. So there was no mechanism of proper data collection. If you come to my OP, you'll see a register with the names listed of all those people who came to the post-COVID clinic, but there is nothing further than that name and the IP number or whatever is there in that. So the early data that I managed to collect from the Thrissur OP, not published, obviously, it's the number, if you look at the N, is very small. So, this is an OP where we treat about 10 to 20 post-COVID cases every day. I mean, they come to a post-COVID clinic, but at the end of it, the proper data where I could analyze was present only for about 60, 70 people. So in that number, when you look at it, the commonest symptoms that we came across were breathlessness and cough. Now, this is biased data because even if that is the label post-COVID OP for Thrissur Medical College, obviously the pulmonologists are sitting there and people with pulmonary symptoms would come there. So, you will always have a biased information coming out of it. Those coming to the cardiology OP, I'm not sure what sir is going to say, but I don't know whether they also have a different data set available for those post-COVID coming to their OP. So since that data was not very clearly visible, what we did was we just went back to the physicians and asked them, what are the symptoms with which your patients are coming? So obviously something like asthma, something looks like a bronchiolitis, something looks like organizing pneumonia or thromboembolism, which are the common things that were presenting to them with dyspnea. They also had patients coming with prolonged cough and also had some complications of COVID like pneumothorax, surgical emphysema, and some lung fibrosis as well. So this was a common kind of presentation we had. Now, if you look at the data which is available afterwards, unfortunately, despite so much of attention having been given to this condition when I did a proper literature search before this meeting, I find that there are very few publications on this area. There are a lot of publications on what is happening with COVID patients, the symptoms, the outcomes, the risk factors and all that, but very little information on what happened to patients after COVID. So I was happy to see one study from our own team here. Anish was not here. I wanted to ask Anish in detail on their tool and methodology. I could not ask it, but the whole team, team from various institutions in medical colleges actually did come out with a data set, and it actually looks at the more, something at 3 weeks and something at 3 months. I would not really agree with the percentages which have come out in this study because like the proportion of cough is only around 1%. So, that is too low to be true. So sample is quite small of around 154, but still even with such a small sample of 154, that should have been good enough to pick up 50% of cough. So the percentages are very low. So I just wanted to discuss with Anish, what the methodology was. We had some data, Kamala and team have gone out to the field here in Kallikad PHC, where we can cover the whole PHC. It's a small PHC with limited population. So we covered the entire PHC area, the entire population, the census, data collection, where sampling, where we actually took out all the patients who had diagnosed COVID. So the entire population was covered, and we had an N of somewhere around 1,300 plus. And with that, when you look at it, to our surprise, it was not respiratory symptoms, which was most common. The government has been addressing that. But if you look at the top, you have fatigue, you have weakness, you have pain, sleep loss, which are actually much more common than respiratory symptoms. But respiratory symptoms are common in terms of dyspnea in about 15% and cough in about 9%. With the overlapping symptoms, around 20% of people actually have respiratory symptoms. So that is the kind of data we have available. Tomorrow, Kamala and team, we are going to that area to look at these symptoms further in terms of what is actually the respiratory morbidity that is there in this population. So we are planning to cover those around 300 people who have respiratory symptoms in terms of lung function and all that, and determine the severity as well. So that is in the plan, and probably, we will be publishing these. So when a patient after COVID comes with a symptom, one of the major issues there is that, the definition very clearly says that it should not be explained by alternative diagnosis. So our major question there is that, is it actually long COVID or is it something else which is, coming to us as a long COVID? So that is something that we look at. I had a set of clinical scenarios which I had, but I'm going to skip those 30 slides and then go directly to a summary of what was actually there in those slides. So which actually, the summary would be that symptoms are common in those patients, but they have persistent cough, they have persistent dyspnea, which is what comes. And investigations, we don't treat the patient only on investigation, we treat the patient. So obviously, if you just look at the chest X-ray or CT scan, they often take more time to clear than the patient's symptoms and clinical features. So, earlier we used to worry on the CT being abnormal for so long, but now we are more relaxed about it. Pulmonary fibrosis, the tsunami did not come. So that is one good thing that happened to the health system, that the tsunami that was to come did not arrive. And so many cases did not come. Otherwise, the health system would have been overburdened. Even pulmonary embolism, so, which was supposed to be the big thing with every other news article discussing in terms of micro embolism inside the pulmonary vessels and all that. I'm going to moving slightly into the cardiologist area, but that also did not happen to the extent that was predicted. So, that way, small mercies in the midst of all the work that we had, at least some things were to a lesser extent. Some people do have persistent hypoxia, which remains for a long time. Home oxygen, with people managing either oxygen cylinders at home or buying oxygen concentrators, the numbers have gone up, and the cost of oxygen concentrators have really gone up. So people are really struggling. Catastrophic expenditure is a major issue. Now, just briefly touching on the management. So from the government policy point of view, the major strategy is pulmonary rehabilitation, which is supposed to be good for patients, which I totally agree with. Then comes the pharmacotherapy in terms of steroids, inhaled corticosteroids, antifibrotics, which at one time was supposed to be the big thing, has come down the list. Oxygen in a certain set of patients who have persistent hypoxia. And of course, at the end of the day, lung transplantation, which I have not seen in a single patient. So that is the ultimate. There are reported cases in India, but not to our extent. Now, pulmonary rehabilitation is the big thing which should be done. But the problem is that, if you look at the post-COVID management protocol, it very clearly talks of certain strategies which, in my opinion, are not often doable. So, for example, a patient with persistent cough, severe cough, they tell that you should have breath control. I mean, I'm a respiratory doctor. I can tell you that somebody who wants to cough will not be able to hold his breath. So that is no answer to a question of that nature. Then a lot of focus on yoga and pranayama. I've been a person who used to do yoga very frequently when I was younger, till my neck gave way. So I'm a big fan of yoga, but despite having practiced yoga for about 50 years, I don't consider myself capable enough to teach my patient yoga. So, if I don't know how many of our health service doctors sitting in the various primary health centers are in a position to teach yoga to their students. So pranayama, yoga. Pranayama, one of the commonest pranayamas that you teach is something called Kapalabhati, which is a violent in and out inspiration. Now, all these patients have high proportion of, not high, but at least a significant proportion of pneumothorax. And Kapalabhati is well known to produce pneumothorax. So we are not even looking at the risks that might be involved in putting in practices like that. So some of these things, there are practical issues. And I have been doing a lot of research on pulmonary rehabilitation for the last 10 years. And what I have found is that among pulmonary COPD, one of the definite management strategies is pulmonary rehabilitation. But even among pulmonologists treating COPD in Kerala, only less than 1% of COPD patients actually get access to a proper structured pulmonary rehabilitation program. So in that context, is Kerala or in any other state in India capable enough to deliver pulmonary rehabilitation to such a large number of people is something. Now, the major advantage we had in Kerala is that we have a public health program called SHWAS, which is delivering COPD and asthma care at primary health center level. And in that program, one of our successes is that about 200 institutions, we have trained the doctors and the nurses to actually do pulmonary rehabilitation. One of our popular pictures is our own minister sitting in the museum compound and doing all those exercises and breathing exercises as part of pulmonary rehabilitation. So we even got the minister to do a pulmonary function test and do rehabilitation exercises and all that. So that training was there, but the problem during COVID was that, we had to stop the spirometry because it's a aerosol generating procedure. So our diagnostic test went out. Inhalers, which initially the guideline was not to use inhalers in COVID, but then inhalers became the good thing in COVID, and all our inhalers from the PSCs went to the first line and second line centers. So the drugs also were lost and the staff were also diverted. So some of these trained staff are no longer in place. So in that context, delivering pulmonary rehabilitation in the SHWAS also became a bit difficult. Patient with dyspnea, the major complaint that we were discussing earlier, we generally go with a bit of symptomatic management. If they don't really respond, then we step up to an inhaled corticosteroid, which at times is available in the government sector, at times not available. Testing was a bit difficult because we had stopped this. Now we have restarted it, but there are other technologies available which do not generate aerosols. So that is also something could have been considered. A CT scan often is needed, and then you look at it. Can we give a longer course of steroids? Now, many of these sick people are already on steroid for a long period of time, which is adding to their morbidity. Do we give more of it? Now, antifibrotics, I'll discuss that in a couple of slides. That was a big thing that came in a long way, pirfenidone and nintedanib. We also evaluate for other causes. Definitely ask the cardiologist for support in terms of thromboembolism and other cardiac causes which are common in post-COVID patients. Now, this is not COVID. This is my patient with H1N1 from 2014. So this patient, extensive lung involvement. You can see the entire lungs were white. But at the end of 3 months of treatment, his lungs cleared up completely. So when COVID came for the first time and we were discussing at National Fora with all these webinars, I was asking the question, isn't this also a virus? Will this the same thing? Will it not happen in COVID? So the answer I got was that COVID is different. You are having microembolism, this thing, that thing, and all that. So COVID will not disappear like this. So you have to manage those patients with COVID. So that was the message. This was repeatedly coming, particularly from the Mumbai lobby. So that is what was happening. And this was the publication, the tsunami publication, where he had also put up pictures that, it actually goes in for lung fibrosis, and this is what is going to happen to all your patients. But then later data from other countries in the world showed that, some patients do go in for fibrosis, but some patients totally clear. So, it's not that all your patients will go in for lung fibrosis. So that was cleared. So in that context, if your lungs are going to go in for fibrosis, then to prevent that fibrosis, should you not use antifibrotics even in the beginning? So that was the question that was asked. But there are multiple scenarios. One, you have these patients who have already developed fibrosis while they are in the ICU and all that. Should I use antifibrotic or not? Even there is no consensus. I would feel that even with fibrosis having developed in a post-COVID, in a COVID patient, I still feel that's a good chance that it might clear without any medication. So why do you want to give long-term costly medication for your patient? Now, this is a debatable area. The other places, when you have something like a consolidation where you have to give a steroid, there also some pulmonologists and some physicians actually believe that you have to give antifibrotics because this may go in for fibrosis later. So a lot of misuse of antifibrotics is happening. And there was a last scenario where you don't have any of these information. Your patient is just in the ICU. You anticipate that this patient will go in for fibrosis, and without any evidence at all, patients are being put on antibiotics, which I've seen in many hospitals in Kerala also, but extremely common in Mumbai. So, every patient being put on antibiotics, very costly drugs, toxic drugs also with side effects. So, that was a scenario we have. Fortunately, that craze has come down. Now people are very reluctant to give antibiotics. So it took about 2 years for us to clarify that maybe those things are not needed. So I conclude by saying that pulmonary symptoms are common. It's not that there was definitely no tsunami and all that, but at least they are common to the extent of around 15-20%. And manifestations are varied, could be very mild to very severe in patients, some even needing lung transplantation. But the numbers did not come out as high as was what was predicted. So that is good for the health system that we were not overburdened with so much of morbidity. Pulmonary rehabilitation definitely is useful, but we need to strengthen our health system to deliver pulmonary rehabilitation. It is doable, but it definitely needed. And we are looking forward to it because our COPD patients and our interstitial lung disease patients also need this. So if COVID can bring this about, so I was discussing at the back, and one of the speakers here was saying that our oxygen facility and our ventilators should not be wasted. So we just before COVID came and we made the Schwarz program, one of our demands, the association, we had brought our pulmonology association to the minister. Our demand was we need oxygen for our patients. So, when oxygen came in, now that oxygen is available, at least the COPD patients will benefit. So somebody actually gains from that. Overuse of certain medications there, which has to be avoided. So thank you so much for the patient listening. Sir, I finished in time. But I finished in time. I was looking at the clock, so correct time I finished.
That was a professorial presentation summing up all the clinical aspects of pulmonary medicine. I think Dr. If there are any comments from the senior members of the audience, otherwise. True. Yep. My own, sir, please.
Thank you, Sanjay sir. That was an excellent presentation. Just one, it's not a question, it's a comment. The Health Services Department has actually now decentralized the pulmonary physiotherapy to the community health level. We have now physiotherapists working in all the community health centers, nearly 227 of them. He actually gave training for pulmonary physiotherapy during this COVID period, and now they are being followed up in this CHC clinic. And another thing is that we have post-COVID clinics in all the PHCs, CHCs, and all the district level hospitals. We are getting a data of that. And out of the total 50,000 patients seen in the post-COVID clinics, 26% of them were of respiratory disease. That's just a
thank you, sir. Thank you.
Maybe ഒരു ചോദ്യം കൂടെ ഈ 6% റെസ്പിറേറ്ററി ആവും ബാക്കി എന്തിനാണ് വരുന്നത് 26%. Sorry, I got confused. അപ്പം ബാക്കി എല്ലാവരും എന്തിനാ വരുന്നത്?
So let us continue with the presentation. The cardiovascular problems is discussed by Dr. Radhakrishnan VV, Professor and Head of Professor, Department of Cardiology, Government Medical College, Thiruvananthapuram. Over to you, sir.
After lung, I think heart is the other organ which is going to be affected by COVID and long COVID. Over to you, sir.
Respected chairpersons, friends, at the outset, let me thank the organizers for giving me the opportunity to talk on COVID and cardiac involvement. Now, in March 11, 2020, the World Health Organization declared COVID-19 as a pandemic. It does not involve the respiratory system alone, but it involves cardiovascular system as well. Patients with underlying cardiovascular risk factors or established heart disease carry a higher risk when they develop COVID infection. Patients with cardiac injury in the context of COVID-19 have an increased risk of mortality and morbidity. Coming to the mortality of COVID-19 infection, the initial statistics shows that the overall mortality or fatality rate is around 2.2%. But if you compare with the SARS and the MERS, the mortality is much less. But the interesting thing about COVID is the greater infectivity and the higher attack rate. This underlying epidemiological study shows that the underlying conditions among adults hospitalized with COVID-19, and it has been found that those above the age of 65 years, majority have higher cardiovascular, chronic lung disease, and hypertension and cerebrovascular disease. Now, coming to the potential mechanism which result in cardiac involvement there is a similarity between the COVID antigen and the cardiac angiotensin 2 receptor. So they react and produce direct cardiac involvement. So in patients with COVID, when they have cardiac involvement, it can produce acute coronary syndrome. The acute coronary syndrome being either an ST elevation myocardial infarction or a non-ST elevation myocardial infarction or an unstable angina. It can also result in arrhythmias like various cardiac arrhythmia when there is cardiac involvement. Direct cardiac muscular involvement or myocardial involvement or myocyte involvement can produce myocarditis and related problems. As already said, there's a higher thromboembolic phenomenon in COVID infection, which can result in venous thromboembolism. When there is myocardial involvement, it can result in heart failure as well as cardiogenic shock. The cardiogenic shock also can result from a large myocardial infarction as well. Coming to the clinical presentation, majority of patients present with breathlessness and sometimes chest pain also. Acute coronary syndrome presentation can be sometimes associated with the respiratory symptoms if they have associated heart failure. Those with ARDS, the predominant symptom will be dyspnea, cough, and respiratory distress, desaturation. Cardiogenic shock is another presentation when there is myocarditis or large myocardial infarction, or they have myocarditis followed by cardiac failure. Sudden cardiac death is another presentation. It can result from mainly tachyarrhythmias, and sometimes bradyarrhythmias. The tachyarrhythmias which produce sudden cardiac death as VT and VF. This earlier study from Wuhan, 138 hospitalized patient with COVID-19, they have found out there is a higher incidence of cardiac arrhythmia, especially the patients are hospitalized and in the ICU. The ventricular tachycardia and ventricular fibrillation reported around 5.9%. Those with high elevated troponin T had higher incidence of cardiac arrhythmias. The cardiac arrhythmias in ICU patients were a little high, 44%, and heart failure was 23%. Thromboembolic phenomenon also was little high. All these statistics are the early phase because those days we don't have any definite management. We do not know the natural history of the disease, what is happening. But later, as we have started on steroids and anticoagulants and immunomodulators, the mortality has definitely come down. Regarding the cardiac involvement, acute coronary syndrome is one of the commonest presentation of COVID infection. The commonest cause of acute coronary syndrome is plaque rupture. When there is plaque rupture, it results in the thrombus formation and acute ST elevation myocardial infarction. COVID infection also can produce endothelial damage and endothelial dysfunction. That also can produce in situ thrombus and formation of thrombus in the coronary arteries and acute myocardial infarction. As you know, any viral infection can result in higher risk of atherosclerotic events because any infection like viral infection can activate a plaque which become vulnerable and produce acute coronary syndrome. Then in patient with acute respiratory distress, when there is a hypoxia and a mismatch between supply and demand can result in myocardial infarction. That's called type 2 myocardial infarction. Coming to myocarditis, COVID myocarditis should be suspected when a patient comes with chest pain, then breathing difficulty, and acute onset chest pain with breathing difficulty and ECG showing STT changes, and sometimes cardiac arrhythmia and hemodynamic instability, that is sometimes hypotension. Suspicion of myocarditis should be raised in COVID-19 patients with acute heart failure or cardiogenic shock without pre-existing cardiovascular disorders. Echo will show LV dilatation, global hypokinesia, and hypocontractility. The biomarkers may be significantly increased, and especially the cardiac troponin T and I, and the BNP and NT-proBNP all will be elevated, even without significant cardiovascular disease. Coronary CT angiogram is probably the preferred approach to rule out underlying coronary disease. Cardiac MRI can be diagnostic. Endomyocardial biopsy is not routinely recommended in COVID myocarditis. Coming to heart failure. In the heart failure in COVID-19 is mainly due to involvement of the myocardium, that is myocarditis. Another cause of heart failure is large myocardial infarction. It can result in ST elevation myocardial infarction and heart failure. Patients with existing LV systolic dysfunction, that is heart failure patient, when they develop COVID infection, the heart failure can be aggravated. Stress cardiomyopathy, otherwise known as Takotsubo cardiomyopathy, also can present with heart failure when they have acute COVID infection. When there is ARDS and pulmonary hypertension, they can present right heart failure. As already mentioned, there is a higher incidence of thrombosis. In COVID-19 causes disarray of the coagulation and the fibrinolytic system. It results in prolonged prothrombin time, elevated D-dimer, and prolonged APTT. There is increased D-dimer, that is 1 nanogram per liter, strongly suggests associated increased hospital death and DIC. Microthromby has been demonstrated in the pulmonary vasculature in many patients with COVID lung infection. Due to prolonged immobilization, hypercoagulable state, active inflammation, and propensity for DIC, patients with COVID-19 are at high risk of venous thromboembolism and subsequent pulmonary embolism. That is the reason why later this factor has been identified and many of the patients put on anticoagulants. That is the reason the mortality as well as the incidence of pulmonary embolism has been significantly reduced. Coming to the electrocardiography abnormalities in patients with COVID, a lot of non-specific ECG changes has been described in patients with COVID-19 infection. When they have myocarditis, they'll have STT changes, sinus tachycardia, and sometimes the ECG may mimic acute myocardial infarction when there is myocarditis. Sometimes bradycardia can occur, tachycardia can occur, abnormal QT prolongation can occur. Coming to biomarkers, when there is myocyte injury, it can result in elevation of the cardiac troponin, both T and I. When there is hemodynamic stress, that is myocardial involvement like myocarditis, the BNP and NT-proBNP are elevated. The important thing is the level of these biomarkers correlate with severity of the disease as well as mortality. When you have a higher biomarkers, there is higher mortality. In the absence of typical anginal pain or ECG of ischemic changes, patient with mild elevation of these troponins does not require any definite admission, hospitalization, or treatment. If marked elevations of the cardiac troponin I or T more than 5 times, it indicates either acute myocardial infarction or myocarditis. Presence of or elevated D dimers again indicates poor prognosis. Coming to the management of patients with acute coronary syndrome with COVID, non-ST elevation MI, generally there are can categorize into 4 risk group: low, intermediate, high, and very high risk. Those with very high risk and high risk patient directly coming with non-ST elevation myocardial infarction directly sent to the cath lab for early invasive management. Those in the intermediate and low risk patient can be managed or evaluated non-invasively. Coming to patients coming with ST elevation myocardial infarction, they stand the classical MI. When they come to in the ambulance into a hospital where there is 24-hour cath lab services available, directly these patients are taken for primary angioplasty. If there is some delay, more than 60 minutes, they are thrombolized. And later, they can be taken up for angioplasty. But if the patient is coming self to a hospital with cath lab facility, again, that patient is also directly taken up for primary angioplasty. If there is coming to a hospital without cath lab facility, and if there is delay in transportation time to a angioplasty center, if it is more than 60 minutes, then they are thrombolized. This is the usual management of ST elevation and non-ST elevation MI. These are the commonest arrhythmias which are associated with COVID-19 infection. They are the atrioventricular block, polymorph ventricular tachycardia, atrial fibrillation, pulseless VT, and VF. Coming to the mortality, if you see the mortality, the highest mortality when there is cardiovascular involvement, followed by diabetes, chronic respiratory disease, hypertension, and followed by cancer. Those without any comorbid condition, the mortality is very low, 0.9%. Another important observation is that patient with COVID, patient with the COVID infection, and if they have established cardiovascular disease and elevated troponin, they carry the highest mortality. But if a patient doesn't have any cardiovascular disease involvement and a normal troponin, they have the least mortality. To summarize, although COVID-19 is predominantly a respiratory illness, a large number of patients with COVID-19 present with pre-existing cardiovascular disease or develop new onset cardiac dysfunction during the course of their illness. Myocardial injury is common in COVID-19 and presents a worse prognosis. Differentiating between the various causes of myocardial injury is crucial to determine the treatment of and cause, because some patients may present with myocarditis may present with just like acute myocardial infarction. So one has to differentiate whether it's due to acute myocardial infarction or myocarditis. The management is entirely different. So we conducted a study in our department during the last 1 year, during the COVID times. We compared the acute STEMI angioplasty outcome during the pre and during the COVID times. It's actually done by our postgraduate in DM cardiology student under the guidance of Dr. Sunitha. And this is a conclusion. ST elevation myocardial infarction admission undergoing primary angioplasty during the COVID period was significantly reduced. It was 872 during the COVID times compared to 1,152. So the STEMI PCA has significantly come down. But another important observation is that no significant difference in in-hospital mortality. The mortality was not different in hospital, or there is no significant difference in stent thrombosis. However, in patients, the in-hospital adverse events such as hospital heart failure, cardiogenic shock, stroke were found to be significantly more during COVID period than the pre-COVID period. A significant increase in door-to-bed time and total ischemic period was noted during the COVID period. Then this is mainly because when a patient is transported in an ambulance from a hospital, it takes a long time because the patient and the person has to be PP kit has to be, they take all the precautions when the patient is. So there is an increase in transportation time of the patient from a hospital to the definite treatment. Both this so in the COVID period, what is important is the delivery of high quality medical service related to STEMI system of care, especially during COVID-19 pandemic is important in reducing the door to balloon time and total ischemic time for a better STEMI PCI outcome and to reduce the major cardiovascular events. So this is another observation we have made during the COVID times, the early period, that is in the March and April, that is March to October 2020. During the March and April, there is a significant reduction in the primary angioplasty number to 46. It was 126 before, it dropped down to 46 during the month of April. At the same time, during that time, the thrombolysis number has gone up. This is mainly because the COVID, we are worried about how the things are going. So we do not know, we don't have the proper protective mechanism. So that's the reason why we are also increased number of thrombolysis also has been done because of this. But after 1 or 2 months time, the number has increased, and within 3-4 months, it became a steady state of around 90 to 80 to 90. And the thrombolysis number also between 40 to 45 numbers. So we have looked into the mortality of patients admitted with during the COVID time. So we have 33 patients underwent primary angioplasty. Of this, we lost 39 patients. That comes to around 5.3% mortality. So the primary angioplasty was 5.3%, which is significantly less compared to the previous years. Coming to thrombolysis mortality, we have 329 patients thrombolized. Out of this, we lost 51 patients. The mortality rate was 15.5%. So the primary angioplasty mortality was significantly less compared to the thrombolysis mortality. Again, during the 4 months time, July to October, we noticed that we had 14 COVID positive patients. Out of this, 11 patients we have undertaken primary angioplasty and 3 patients underwent thrombolysis. To summarize, primary PC has got 10.2% reduction in hospital mortality compared to thrombolysis. So primary PCI is better than thrombolysis in COVID during the COVID times. Then during 2019 to 2020, the number of primary PC was reduced by 36% because of various logistics. And the door to balloon time also increased by 11%. It's mainly because of the transportation time and all the other factors involved. Coming to our experience in managing what we have done in our department to rearrange our department during the COVID times. So as you know, the first case of COVID-19 pandemic was reported in Kerala on 30th January 20, a medical student from Wuhan. The efforts of the Kerala government was well appreciated both nationally and internationally during the initial stages of COVID-19 pandemic. Let us have a glimpse of our department strategies and protocols, which we observed and experienced during that difficult times. The government of Kerala declared high alert on 8th March 2020. During this time, that is the month of February itself, we started thinking of ways of handling the upcoming situation, which we were not heard of and have not seen till.
Excuse me, so the time is over.
20 minutes.
Okay.
Yeah. Try to sum up, sir.
So I can stop it now. Okay, I know. Okay. Okay. So the most important thing is we have collected the protective masks, sanitizers, and shoe covers. Then we have streamlined the ICU. We created a red channel for patient transportation. Then the ICU was cleaned and fumigated for patient receiving patient. Then all our staff were in PPE kit. Then the multi-specialty ICU for the COVID patients. Then we are given the Ward 22, which we converted that Ward 22 into a transit ICU where we triage patients, we check the rapid antigen, and if whatever be the antigen result, we have taken patient for reperfusion, and if the antigen is positive or an RT-PCR is positive, that patient is sent to the COVID lab. This is the Ward 22, which was converted to a makeshift ICU unit. Then this is the echo we have designed. We have designed a special protective measure to prevent the COVID infection to the echocardiographer. And to conclude, the state government has stopped the daily reporting of cases following fall in the number of active cases. No lockdown restrictions were there. We have resumed our OPD to full swing. Primary angioplasty has been back to normal. Both our ICUs were functioning normally, and we are back to normal function. Thank you.
Thank you very much, sir. That excellent presentation.
Now let us continue with the next presentation by Dr. Thomas Hyde, Professor and Head Department of Neurology, GMCT, Neurological Management of Patients with Neurological Conditions.
Respected Rajmohan sir, Pro Vice Chancellor, friends, let me and chairpersons. Today, I will be presenting the data from Kallikada Panchayat. I should thank them for sharing their data with us. There were around 21,000 people in that Panchayat, and we looked at patients who developed COVID during the COVID period. There were 1,347 people, and among them, 193 were above the age of 60. I'll concentrate myself on this older age group. 193 people, 70% were male. They had many comorbidities. According to their estimates, 99% had hypertension, diabetes was 90%, dyslipidemia in 86%, 40% consumed alcohol, 24% were smoking, 15% had a heart attack, obesity was there in 10%, coronary intervention was done in 7%, and they had kidney disease in 6.7%. Hundred and three of them had symptoms persisting after the COVID. Headache was the commonest symptom that they noticed. 36.3% of 193 elderly, or out of the symptomatic 103, 67.9%. Fatigue was the next common, 35% of the elderly. Loss of smell and taste in 12%, leg pain in 1.5%, and hair loss in 0.5%. They were administered after the COVID infection. We used the fast mnemonic to identify stroke. According to that, according to that, 9.8% had acute stroke. But according to the clinical diagnosis, they had 6.7% had stroke. And if you use B-fast mnemonic, there were 69% of patients had stroke. But from that, what I understand is B-fast is not really specific. They are adding balance and eye symptoms to the mnemonic of fast, which is facial deviation, facial droop, arm weakness, and speech abnormality decreases the specificity, and you will be ending up with a lot more non-specific diseases. Then we use the subjective memory symptoms to see whether they had any memory problem. And with a cutoff of 3, we found that 93.8% of the elderly had memory problems. 93% of the elderly had memory problems. These are all screening tests. If you look at the activities of daily living using the everyday ability scale for India, which Indu had translated to Malayalam and validated it, 42% had activities of daily living affected. So I think these are all large numbers, proportions of people who are really affected. So we do not know whether it is primarily due to the COVID or they had or they already had activities of daily living affected, which may have been increased by the COVID infection. So this is the questionnaire. If you look at patients with memory loss and activities of daily living being affected, 40% were demented. 40% of the elderly were demented. So these are all large numbers. Tomorrow, as Sanjeev sir said, we are going to verify whether these facts are real or not. If you look at people who had persistent symptoms, fatigue was there in 56 out of the 87, shortness of breath, 35 out of the 87 who continue to have symptoms, memory problems in 36 out of the 87, and subjective memory loss in 82 out of the 87 people who continued to have symptoms. Again, activities of daily living was affected in 70% of the 87 people who continued to have symptoms after the COVID infection. Because of the shortage of time, I'm stopping here. Thank you for the patient here.
Thank you, Professor Wright. We have had a very fruitful session with three stalwarts, kingpins in their fields, speaking to us about COVID and its aftermath. Thank you very much for a patient listening.
Thank you very much, Thomas Saib sir, Radhesh sir, and Sajeev sir. We often come across these problems. Even now, we had a patient involved with the COVID turning to be TROP-T positive. So we are confused whether it is due to myocarditis or underlying CAD. So all these problems we are coming across in real life also, and hope few further studies will come and dilemmas will clear. And thanks for the information given to us by all the speakers. Thank you very much.
We know in fact, we couldn't do justice to the clinical presentations. Actually, for that, we arrange things in the super specialty complex because the audience is different. But this is an overall, scenario in which we have just stacked the experience sharing. That is all. It is not about, we will arrange things in, usually we arrange clinical for targeting to the clinicians, we arrange in the super specialty block. We may arrange that role, things like, because this, cardiac involvement, all this, there are a lot of experience that needs a intensive discussion that we can do later on. Now, I told Radhakrishnan, we have short of time because we have to do justice to our clinical fraternity also. We know that very well. We will arrange it. Our honorable PVC may make a note that we can arrange it in superficial because that is convenient for them. We can't expect them to come here and attend and listen. Thank you very much. Now we are coming to the closing session. I request Dr. Thomas Saib, who is the principal in charge, to come over and along with inviting our PVC. We have our guest to make the comments about, overall comments about the whole session. Professor Rahel Gotendu, kindly come over, sir. Because, 5 minutes. Rahel, the comments on Rahel. Rahel has extensive experience in arranging such scientific sessions. Actually, we wanted to get his comments at the end. So you can, mic is all right? Yeah, please. Thank you.
A very good evening to everyone, and thanks very much to Kuhas and Rajmohan sir for giving me this opportunity to share a few thoughts in way of summary of having been part of these proceedings since yesterday. I am with a public health background, and I have been privileged to be a ringside viewer of the events of COVID in Kerala, thanks to my membership in the State Expert Committee, along with Chandni ma'am, Anish and others that you all know very well. And my reflections and comments are based on that experience when we discussed COVID every single night for nearly 18 months. Every single night, Iqbal sir would send us a Zoom invite and we would meet and discuss a range of issues. And it is that sort of very in-depth involvement, struggles, frustrations, victories, and all that I sort of reflect on as I sat here listening to all the deliberations over the last 2 days. So just, I will take a maybe not more than 5-6 minutes to just summarize 2-3 points of rather general nature, but I think some of these have not necessarily been reflected upon in depth in the last 2 days, and these are just my sharing. So I want to start with 3 cautionary tales. The first is that I don't know how many of you know that there was something called the Global Health Security Index that was developed in 2019. It was a long process, and countries from all over the world were ranked about their potential ability to manage a pandemic. And the top country was the United States. And all the other top countries were in Europe. When the pandemic hit, we found to our shock that all those countries that were actually ranked the highest were actually the worst performers in many, many areas of actually managing the pandemic. And what this shows us is that despite our confidence, and I would even use the term hubris, that we know and that we have technology, reality always throws us a googly. And I think we need humility as we move forward. And the Global Health Security Index is a great example of how all our collective wisdom was literally, thrown to the wayside by a virus and society as such. The second cautionary tale is about attribution of causality. And this is something I think all of us in community medicine and public health and all clinical epidemiologists do, that many a time we are dealing with complex systems. We do something, there is an effect, and we have a tendency to sit back and say, oh, we did it, this is what happened, cause and effect. And we know that it is never, ever so simple. It could be that the disease was going off on itself. As we know, in dengue, there are these cycles. So if you do an intervention at a time in which you have a secular downtrend, it is going to show that, that intervention seemed to have an effect. But obviously, there is no causality there. And I think this tendency to attribute causality without doing scientific research, without going through the issues of confounding, without going through the issues of bias, leads us to policy disasters. Because we have this tendency to assume that just because one follows the other, that it is causality. And I think this is something we really need to be wary of, as we move forward. And finally, the third point that I want to start off with in terms of cautionary tales is the fact that all of us sitting in this room and the policymakers and the bureaucrats we deal with on a day-to-day basis and the community members, We all assume that we have aligned incentives, but we don't. And that is the struggle of working in democracies. That is the struggle of translating evidence into policy and policy into practice. Without meaning to sound disrespectful, politicians have a certain 5-year electoral incentive. Bureaucrats have a certain hierarchical supervisory incentive. Public health professionals have a population incentive. Clinicians have an individual patient incentive. None of these incentives are wrong. These incentives are there. The point is, how do we align incentives at times of crisis? And I think that is really the challenge that we have to us. How can we understand each other's languages? How can we understand each other's incentives? How do we come across, speak across assumptions and come to a common pathway that helps? And how do we learn when we realize our assumptions are wrong? I think that really is the challenge we have as we move forward. Health systems are not technical systems, and we know that. Health systems are socio-technical systems. There is technology, but that technology is handled by human beings, and that means that social causes, the social relations, that social positions play a huge role in the way that technology is wielded and that technology is distributed. And therefore, sometimes we take for granted what happens at a certain point in history. What happened in Kerala in COVID, no doubt, was a resounding success compared to many other states in India. And I don't think there is anyone in this room who doubt the amazing work that took place in Kerala during the COVID pandemic. But what were the reasons? If we put down the success to the reasons of all of us who were part of this epidemic alone, it would be wrong. The reason for our success was the historical investment decades ago into developing the system in such a way that today we can do what we did. And that means the responsibility of each one of us is to say, unless we work in ways that strengthen this very system, decades later, people may or may not be able to handle a pandemic. Are we willing to take this responsibility, not of being happy with our successes, but creating a foundation for future pandemics? And what type of action will that be? I want to, also maybe wrap up with some reflections on what I feel and what has actually been reflected in literature as some of the major reasons for success in COVID. That we have talked about, I think we have mentioned it, but how much of it, are we going to take on as we develop pandemic responsiveness in future? The first point I want to emphasize is social protection. The fact that people in Kerala were willing to wear masks at a much higher rate than other states, the fact that we were willing to stay at home, the fact that we were willing to break the chain and make all these day-to-day sacrifices was because of an underlying culture of social protection. And literature has showed that every society where there was social protection, people were able to perform the non-pharmacological interventions at a much higher rate. In other words, while evidence for masking is extremely important, free ration, NREGA, old age pensions, Sannadha Sena, These are actually interventions that enable the translation of evidence into practice. And then focusing just on the masking without looking at the social protection, even in discussions of clinical epidemiology, I think is a failure. And I think that is something, we really need to emphasize. I want to, just wrap up with, three broad areas. We keep talking about, going back to the normal, right? But disease is never about going back. Disease is dynamic. We know that there is going to be a rapid change. There is going to be a certain evolution of particular types of diseases. We know that, it's very clear. We know that there is going to be climate change. We know that we are having a rapid epidemiological transition, and therefore our planning has to take into account not just what we were before COVID, but what we expect the context to be 10 years or 20 years down the line, and not just again taking data from what we were, but what we expect to be. So that sort of futuristic thinking is something we really need to incorporate. Secondly, we need to look at multimorbidity. We need to look at individuals with disease. We can no longer, we don't have excuse any longer to look at a hypertensive or to look at a diabetic or to look at a patient with depression. No, we have to look at individuals who have all these diseases and in whom all these diseases interact, and in contexts that socially determine these diseases. How are our health systems going to address and manage these new, as it were, patients? And that is the question. How are we not just going to handle single diseases, but how are we going to handle syndemics? That's really the question that we need to take up as a challenge. And finally, while I think it's important to do all of these, wonderful things that we are all doing, unless we work on the social determinants of health, we are really not going to make an impact on health or on resilience. And for that, we need to look at equity, we need to look at community empowerment, and we need to look at intersectoral action. Yes, we have a fantastic foundation in terms of decentralization, but who has decentralization benefited and who has not benefited from decentralization, and why? And how can we close that gap? That is the question that remains in front of us as we move forward, to plan for the next pandemic. We know about intersectoral action, but how are we going to operationalize that intersectoral action? How are we going to overcome turf wars? How are we going to overcome ego clashes when we have to get different departments to sit down and look at the individual, the community, and say, that is the goal? So I want to place before you my last point, which I picked up from the recently published Lancet COVID-19 Commission, chaired by Jeffrey Sachs, where they put forth an idea called pro-sociality. Essentially, what that talks about, it's basically repackaging an old idea, but essentially talks about the fact that can every one of us decide that our actions, our policies, our programs are pro-people, rather than aligning with our own selfish incentives? Can we all sit together and say, let's put our individual, incentives aside and work for the patient? What would that future be? I invite you all to imagine it. Thank you very much.
Thank you, sir. Thank you very much. Of course, United States of America was not an example to be followed in the case of COVID, that all of us know. Thank you very much, all the speakers. And we are coming to the, is it not, sir?
we are coming to the
Closing remarks.
closing ceremony. Okay, thank you, sir. There were several programs under the auspices of Government of Kerala for assessing our performance during the COVID pandemic. But I think ours was a notable one. It is not my opinion. Somebody else told it. Definitely, 2 days deliberations were very good. First day based on epidemiology and second day based on COVID. Hope everybody enjoyed it and benefited it. Okay, and I'm inviting Professor in charge, Principal in charge. Yes, there are nearly 1,000 viewers online. I'm inviting Principal in charge of Medical College Trivandrum, Professor Thomas Ive, for his comments.
I think my mission is to say thank you to the Pro Vice Chancellor who has been here with us for 2 days, and all the senior faculty who have been here for 2 days and given a feast, academic feast for us. I am sure all the delegates have been benefited by these deliberations. Thank you very much. Again, I should thank Rajmohan sir in particular for giving me this opportunity to present on neurology. Thank you very much.
The presentations will be available in the university sites in PDF format, maybe after 2-3 days, because we have to organize ourselves. Then it will be available in the sites, and we will be preparing a document and submitting to the Honorable Minister for that. Thank you all for all the support. Please bear with us for the shortcomings. Yeah.